Good morning, everyone. A very warm welcome from us and the whole A-Line team to this emergency laparotomy meeting and the North East Anaesthesia and Intensive Care Review 2023. We're delighted to have you joining us today. I'm David Saunders. I'm a consultant anaesthetist working at the RVI in Newcastle. Joining me today is Dr. Jess Scott, an anaesthetic registrar, also in the North East.
This event is hosted by A-Line, Anaesthesia Learning in the North East. We're hosting our meeting today from Holt's Yard, a repurposed industrial site previously home to Tyneside Pottery. It is now a buzzing site for new business at the heart of Ousbourne, 5 minutes from the centre of Newcastle. We've got a wonderful tech team on site supporting us today, but they are also NHS workers with part-time enthusiasm for technology. So please bear with us if there are any technical glitches. We apologise in advance if there are any hiccups throughout the course of today.
So the aim of the meeting is to bring together ideas and to share best practice around emergency laparotomy and quality improvement in general. So we're delighted to have so many of you registered for this event today. This is the second time we're running North East Anaesthesia and Intensive Care Review, having missed running the event in 2022 due to COVID. We have a full programme for you to enjoy. Our morning session includes 6 presentations related to the field of emergency laparotomy with multidisciplinary speakers from across our fantastic North East hospitals.
A few housekeeping notes to be aware of. We know we have a packed programme, but don't worry, there will be pauses throughout the course of the day for coffee and for lunch. We have scheduled 2 panel discussion sessions in the morning following our keynote speakers. This is your opportunity to put questions to the speakers. Please submit any questions you would like to ask in the Q&A tab at the bottom of the screen. It helps if you keep the questions concise, make it clear who the question is for. Feel free to use the chat box to communicate with other attendees, but just bear in mind that the chat box won't reach us.
It would be great just to kick things off to get an idea of where you all are joining us from today. It gives us an opportunity also to introduce the poll function. You should see a poll available on your screens now. We'll be using this poll function throughout the day to ask questions and later on in the afternoon to score abstract presentations. These scores will determine the awards given out at the end of the meeting, so we would really appreciate your input into the polls as they appear. So the majority of respondents are from the North East, 67%, but I'm just looking at the rest of the screen. Yeah, there's a much wider national audience than I might have expected when we first started talking about running this programme. So that's great, very exciting to see. Welcome, everybody. Okay, so I'm going to go and just prepare my slides because I think I'm on first. So I'm going to go and do that now. All right, Jess, over to you.
So that seems to be the housekeeping over and done with. Our programme this morning includes 6 keynote presentations given by 4 speakers from the North East, who are going to give us a multidisciplinary update from the field of emergency laparotomy. Dr. David Saunders lives and works here in Newcastle. Mr. Kanakala and his registrar team of Mrs. Hawkins and Mr. Tingle work at James Cook University Hospital in Middlesbrough. Dr. Brian Carroll is an emergency medicine doctor working in Newcastle. Dr. Ian Clement is the clinical lead of critical care at the RVI, and Dr. Francis Collin is joining us from Northumbria Healthcare. I am delighted to be able to introduce our first speaker for the day, my co-host, Dr. David Saunders. Dr. Saunders has been a consultant anaesthetist at the RVI since 2006. He trained in the North East of England and Perth in Western Australia. David is a founding member of the original UK Emergency Laparotomy Network in 2010 and has been clinical reference group member for the National Emergency Laparotomy Audit from 2013 to 2017. He has been the regional anaesthetic lead for the North East and North Cumbria Academic Health Science Network Emergency Laparotomy Collaborative from 2019 to 2022. Since September 2021, he has been the National Anaesthetic Clinical Lead for NELA run from the Health Services Research Centre at the Royal College of Anaesthetists. We are extremely grateful to have someone who has been as instrumental in the development of emergency laparotomy services and NELA as Dr. Saunders presenting today. He will be giving us an overview of NELA, its past history, and its possible future direction. Dave, we can see you and we can see your slides. It's over to you.
Okay, thank you very much, Jess. Definitely thank you to the hosts for the opportunity to speak. I'm very grateful. This is a topic that's been of great interest to me for the last decade or so. I'm quite passionate about it, so it's brilliant to have the opportunity to speak this morning. Andy, can I just get your help to move that slide forward, please? How did you do that?
So it should now just go on the...
Okay, brilliant. So this is what I'm going to cover. Jess has just introduced a little bit about the background to this topic, but in preparing the slides today, I wasn't certain how far the laparotomy journey many of you will have travelled. So some of you will have heard some of this introduction before, some of you will have heard some of it from me before, I suspect, but I think it's quite helpful to go back to the beginning and set the scene for why we feel emergency laparotomy is such an important topic. I'm going to talk about progress in the laparotomy landscape over the last decade, highlighting some successes and improvements in both processes of care and outcomes from care for our emergency laparotomy patients. But I'll also highlight some areas with persisting challenges and areas perhaps with further room for improvement, including some data that was published just last week, the Year 8 National NELA report that was put into the public domain last week. So I've got some of that data in the slides. Finally, I'm going to talk briefly about the new NELA contract from April 2023, priorities as NELA sees them, and I'll also briefly mention a likely new best practice tariff that's going to be introduced in the spring. Later on this morning, there's a shorter set of slides that I prepared about how to make the most of your NELA data. As we said in the introduction, please do ask any questions as we go along. Delighted to try and answer any of those. We've got two good discussion episodes, one just before coffee and one before lunch. Okay, so to set the scene, I think this sort of information started to strike me just really late, 2006. I started as a consultant. Over the next few years, there are a number of high-profile papers were published that really struck me. This data in the slide, this is contemporaneous, but the point that I'm trying to make with this is to compare and contrast the differences in outcomes for elective surgery compared to non-elective surgery. So those examples above the line, those are some major general surgery abdominal operations that we undertake in Newcastle. Everyone knows these are high-risk operations: esophagectomy, 2% mortality risk; gastrectomy, perhaps 3%; large bowel resection for cancer, 90-day mortality is 1.3% currently in Newcastle. Below the line, some similar operations, but this time performed in the non-elective population. So emergency laparotomy overall, and that means general surgery, bowel surgery effectively, emergency laparotomy, 9% UK mortality, and non-elective surgery for colorectal cancer, 15% 90-day mortality. And I think it's just worth thinking about why there should be such big differences between the two groups of patients. So when I first started talking about this, people would say, yes, that's all very well, that there are these striking differences, but there's nothing that we can do. The patient is unmodifiable. When they present to hospital with their decompensation of their illness, this is not the beginning of the pathology. They present in a dehydrated manner, they're deconditioned, malnourished, comorbidities are not optimized. Often their condition may be complicated by infection and sepsis, and if this is a cancer presentation, it may well be a late presentation, and that's all correct. We cannot modify those things, but what we can modify are the processes of care, so we can respond in an appropriate manner, having recognized that the patient is at increased risk of complications post-operatively. So we can improve our risk assessment strategies, We can recognise the risk and treat infections. We can undertake simultaneous optimisation whilst managing their, definitive management of their surgical pathology. We can offer consultant-led decision-making preoperatively and consultant-delivered care directly in theatre. We can ensure these high-risk patients are admitted to critical care just like we would for elective surgery. And post-operatively, the opportunity to optimise things preoperatively may well have been very limited, but post-operatively, especially for elderly and frail patients, we can ensure that there is multidisciplinary input from experts. So back to the beginning of this journey for me, 2010, 2011, I was part of a group called the Emergency Laparotomy Network. We collected data on 1,800 patients having emergency laparotomy across the UK from about 30 hospitals, presented this in Edinburgh at the AGBI Annual Congress. That data was published in the BGA, and that publication formed the basis of a grant application to set up and run the National Emergency Laparotomy Audit. In preparing today's slides, I went back and looked at what I presented in 2011. So orders of magnitude different. In 2011, we had 1,800 patients. There are now more than 2,000 cases in the NELA register for our hospital alone. So a vast resource, more than 200,000 cases in NELA headquarters. Risk assessment in 2011, we didn't even ask about this because it wasn't done in a formal manner. That is now largely systematically delivered for emergency laparotomy patients. High-risk patients, care in theatre is systematically delivered by consultants. Surgery has always been ahead of anaesthesia in that regard, but for both specialties, it's now largely done once it is recognised that the patient is high risk. And mortality, I alluded to this before, that's fallen from 15% was our best estimate in 2011 to around 9% now, and a similar reduction for the elderly, albeit at a higher level. This is, a criticism of our early work was all sorts of potential sources of bias, reporter bias, case selection bias, but this data around mortality is from the NELA register itself. Over the last, this is about 8 years worth of data, and it shows a steady and stepwise reduction in 30 and 90-day mortality over that period. This is national data. And right up to date, this is the chart that's in the Year 8 report published last week. So we don't have NELA yet because of delays with NHS Digital. We don't have ONS 30-day mortality, but what we do have is self-reported in-hospital mortality. So plotted that all over a similar timescale to the previous chart with the Year 8 data added. And for the first time, mortality has not fallen, it's leveled off. So that might be something that we could discuss later. Process measures amongst over the NELA decade. So risk assessment on the left, a steady and stepwise improvement in practice. And on the right, that's the proportion of high-risk patients that are admitted to critical care post-operatively. And again, a steady improvement, notwithstanding the disruption in the last couple of years related to COVID. This heat map, don't expect you to digest this in totality, but the point of this is Year 6 and Year 7 of the NELA programme. This is the proportion of high-risk patients that have direct consultant surgeon and consultant anaesthetist present in theatre. Columns are the days of the week, the rows are the different times of the day, but the point is largely across the board, this is green, so greater than 80% of high-risk cases have direct consultant-delivered care in theatre. And there's probably a trend of improvement between Year 6 and Year 7, and that continues into Year 8. So it might be tempting to think that processes are better, outcomes are better. In fact, there's some evidence perhaps that improvements in outcomes have leveled off, and it might be tempting to think that the work of NELA is done. It's run for 10 years, has it run its course? But I think that would absolutely be the wrong conclusion to draw. So some key messages from the Year 8 report. amongst other things, diagnostic pathways for patients are too long. Usually once the machine starts working and a decision to operate is made, the interval between that decision and arrival in theatre usually is pretty good. But if you look backwards at how long the interval that passed between the patient arriving in hospital and that decision to operate, it's much too long, it's excessive. We've got evidence that infection and sepsis management is lacking. Perhaps a hint that there's a shortfall in critical care capacity, and I won't talk much more to that because I'll leave that for Ian later on, who's our expert in that regard. There's certainly evidence in the NELA report that post-operative multidisciplinary input is under-resourced. Got a slide about that in a moment. And importantly, the problem with, or one of the considerations of the aggregated national NELA data is it's just that, it's aggregated. So it can hide wide variation in performance in both processes and outcomes of care between different hospitals. And we all know this from experience, and you'll know in your own hospital which parts of the system function well and which parts function less well. So let's look at infection management. This is data from the Year 8 report, and I picked out two groups of patients here. Those where the box was ticked to say sepsis was suspected at the time of arrival in hospital. And then the lower bar, that's a group where gross peritoneal soiling was predicted at the time of decision to operate. So these are not borderline cases. It would be hard to argue that either of these groups of patients do not require early antibiotics. And the Royal College of Surgeons set standards for this. They say antibiotics should be given within an hour. That aligns with the Sepsis Trust, and it aligns with the Academy of Medical Royal Colleges. 1 hour for antibiotics. We all know that. In reality, for those where sepsis was suspected on arrival in hospital, it's about 3 hours until they receive antibiotics. And for those with gross peritoneal soiling, this is the median time, almost 4 hours. So that means that half the group wait more than 4 hours. And the upper quartile, I can't remember, but it's much, much worse than that. The median hides the extremes. To emphasize variation, this scatter plot. So each of these dots represents a hospital with at least 10 patients who had suspected sepsis at the time of arrival in hospital, and plotted against the median time from arrival until they received antibiotics. So this should, I hope, emphasize this point about variation in care. There are a number of hospitals that can manage systematically to give antibiotics within an hour, and a large number can do this within 2 hours. But there are a lot of hospitals that are performing in a manner worse than average, 8 hours, 7 hours, 6 hours. So that's something to think about in your own local hospital. How well do you perform in this measure? What about definitive management of the intra-abdominal infections? We talked about antibiotics. RCS guidance again, or standards of care, say that patients should be within theatre within 6 hours for those with suspected intra-abdominal sepsis, within 6 hours of arrival in hospital. In fact, the reality is worse than 13, 14, 15 hours, and that's the median time. So I said before that once the machine starts working, you've decided to do an operation, they probably do get to theatre quite quickly, but it's the time prior to that decision during the diagnostic pathway that time is lost, and that can only be deleterious to the patient. Critical care, just to touch on this from the Year 8 report, for the first time there's been a fall off in the proportion of high-risk patients that were admitted to critical care amongst the NELA group. That may be COVID related. 15% of high-risk patients return to a general ward after surgery, and I propose or suggest that that just would not happen with elective surgery. I don't know whether this is down to capacity constraints. I suspect it is, but it might also be that the team at the time looking after the patient in theatre failed to recognise that this patient was at high risk of complications. Elderly care involvement for post-op frail and or elderly patients in NELA. Again, you don't need to read the details. This is another heat map for Year 6 and Year 7 in the NELA report. The point here is that this is absolutely not green. the standard here says that 80% of high-risk patient, 80% of frail or elderly patients should be seen by a geriatrician post-operatively. Only about 1 in 10 units manage that metric. And overall, for the elderly frail population in NELA, about 1/3 of these patients are seen post-operatively. And compare that to orthogeriatrics, where it's just systematically delivered for hip fracture patients. That remains the worst performing metric within NELA. Is elderly care involvement important? Francis is going to talk to us in a much more learned manner later on this morning, but in the Year 8 report, absolutely frailty and being elderly is important. The presence of frailty, however old you are, doubles your risk of mortality. So frailty alone, regardless of your physiological derangement or your surgical pathology, frailty or the presence of frailty makes the patient high risk by definition. For all of the age groups and frailty bandings, if a geriatrician reviews the patient post-operatively, that was associated with a halving of mortality. It's a very striking difference. They're not exactly the same groups. This isn't a RCT, but it's a striking association and worthy of further consideration. So to finish off, where does NELA go from here? Much of the improvement to date, I think, has been around management pathways for emergency laparotomy. And I've talked about improvements in risk assessment, senior delivered care preoperatively and in theatre, and admission to critical care for high-risk patients. And some of the latter, senior involvement in critical care, that's been incentivised by best practice tariff since 2018. But most of the improvements, I would say, are down to clinicians, nursing colleagues, colleagues across the spectrum that have risen to the challenge for this group of patients, just highlighting their profile and making it clear that this is a high-risk group has, and people have responded in an admirable manner. And we should not fail to congratulate colleagues for behaving like that. It's fantastic. But problems persist, and Year 10 for NELA begins in April this year, and there will be an increased focus on attempting to improve this diagnostic pathway, what I might call upstream of the decision to operate. So we're going to look at amending the way risk assessment is done. We will concentrate some data collection around infection and sepsis management. We're also going to look more closely at post-operative multidisciplinary input, and there's a likely change to best practice tariff coming from April. I'll talk about that in a slide in a moment. Just as a very brief comment, I'm not going to talk to this much more this morning, but for those that are interested, from 2023, NELA has been asked to look at a different patient group or add in a different patient group. So this is the group of patients who, under some circumstances, might have had an emergency laparotomy, but for whatever reason, did not. And NELA have been asked to look at processes of care and outcomes for that group. And that work will begin in April. It already has started. For the first year, it will just be designing how the audit will be undertaken. And then from April 2024, patient data collection will commence. So risk assessment in NELA, POSSUM has been superseded. We stopped using that a while ago. Since 2018, we've had a NELA risk algorithm that correlates really well between observed and expected mortality, but it requires a bit of effort and about 22 variables. So to make life a little bit easier, a parsimonious risk score has been developed. This uses just 13 variables. It's been shown to have strong correlation between expected and observed mortality. For the first time, this parsimonious risk score takes into account the predicted surgical pathology, ischemia, sepsis, perforation, obstruction. So that will be coming from April, as well as I mentioned a moment ago, frailty. So this is really important. This guidance was published September 21 by the Centre for Perioperative Care in collaboration with the British Geriatric Society. This, amongst many other things, the guidance states all patients aged 65 or older should have a frailty assessment documented, and we should use the clinical frailty score, the Rockwood clinical frailty score. There is also a strong recommendation that all hospitals should have a perioperative frailty team with expertise in comprehensive geriatric assessment. So I find the wording quite interesting. It does not talk about a geriatrician, it talks about a perioperative frailty team. But to me, expertise in comprehensive geriatric assessment does mean a geriatrician. But it also suggests that someone else, a perioperative physician who's particularly interested in this, could train in comprehensive geriatric assessment and begin to lead that team in a manner similar to that done by geriatricians elsewhere. From April, NELA have had notice that it is likely NHS England will begin to financially incentivise better post-operative multidisciplinary input for frail and elderly patients. As I say, that just applies to England. Test. The threshold targets for that have not been defined. As I say, at the moment, only 30% of frail and elderly patients are seen by a geriatrician, but it's likely that the target will be 80%. So if that was initiated in April, that would just be 10% of hospitals receiving that money. And what that's worth, well, in Newcastle, best practice tariff for high-risk patients was worth about £200,000 a year. So this is a large sum of money that's up for grabs if hospitals can deliver the resources. So that's all I'm going to talk about in this introduction, bit of a flying overview of the emergency laparotomy landscape. I want to emphasize that clinicians, hospitals should be proud of their achievements to date. Genuinely, I think we've risen to the challenge, but it's wrong to give the impression that everything is fixed. Not all standards are met, wide variation persists. The next priorities for NELA that I've talked about are upstream of theatre, including managing infection, simplifying risk assessment, and then I've touched upon this forthcoming best practice tariff to incentivise better elderly care. Thank you very much.
Thank you, Dave, for that excellent talk. I think it sets the scene perfectly for the rest of today. Our next presentation comes from two general surgical trainees working here in the North East. Helen Hawkins is an ST8 currently working at Sunderland Royal Hospital and has an interest in emergency general surgery. And Sam Tingle is an ST4 with an interest in hepatobiliary and transplant surgery. Venkat Kanakala is a consultant upper GI bariatric surgeon at James Cook University Hospitals in Middlesbrough and is the current clinical director for surgery there. He has helped Helen and Sam put together this presentation and will take part in questions following it and in the panel discussion later. Helen and Sam, we can see you and we can see your slides. It's over to you.
Thank you very much for the introduction, Jess. So I'm Helen, as you said, and we'll crack on with Sam's part of our presentation.
Yeah, thank you very much for the introduction and for inviting us to talk. So we've been asked to give a bit of a summary, really, of the surgical perspective around NELA. We're doing it together, so Helen's controlling the slides. So could you pop to the first slide, Helen? So the plan for the session is we're going to talk about some of the common NELA cases using examples that of different patients that we've been involved in. I'm going to talk about some of the common NELA cases and then touch a little bit on laparoscopic and open operating. And then Helen's going to have a bit more of a discussion about futility and some of the reasons that decision-making in NELA can be so complicated. So the four most common NELA cases that get done: small bowel resection, division of adhesions, segmental colectomy, and Hartmann's resection. And I'm just going to come up with a couple of example cases for each. So the first example is small bowel resection. We do these for all kinds of reasons. This first patient whose CT scan you can see on the slide, this is someone who presented with small bowel obstruction, had a CT scan done, and on the CT scan you can see the white arrow points to this target sign, and that's some small bowel that's intersuscepted, so telescoped through itself. And the lead point in this case was a lipoma. So this is technically quite a simple operation. By the time we got to the operation, the intersusception had actually resolved. There was a lipoma with some pretty normal small bowel around it, no previous surgery, no adhesions. So from a tiny little cut in the midline, very easy to get all of the bowel out of the abdomen, find the area that's the problem, and then do a simple stapled small bowel anastomosis. So really, really quick case. I think it took about 20 minutes to get the bowel out, and then a very small amount of time because you've got a tiny little cut in the middle. So very, very technically simple small bowel resection. The next one, again, this is someone who came in with a small bowel obstruction, but also right upper quadrant pain. This person had a gallstone ileus, so large gallstone in the gallbladder, too large to go through the common bile duct, which then chronic inflammation fistulated through into the duodenum and then caused small bowel obstruction. So on the far left image, you can see a gallbladder that's inflamed with gas in it. The middle image, the white arrow points to this fistula that's between the gallbladder and the duodenum. And the image on the right, you can see this dilated bowel that leads to this bright white gallstone in the right iliac fossa, and then collapsed bowel after that gallstone. And sometimes for these, you don't need to do a resection. If you do need to do a resection, it's generally a short section of small bowel that needs to come out with a reasonably normal mesentery, which again makes it a fairly quick and simple operation to do a small bowel resection and join things back together and close things up. Then there's the more complicated. So we also do small bowel resection for things like ischemia. The CT scan that you can see on the picture is a contrast CT scan. You can see there's a little bit of colon on the patient's left, which is enhancing. By that I mean there's blood going to it and therefore contrast going through it, so it looks bright. The rest of the image is small bowel that's got absolutely no contrast in it whatsoever. It's non-enhancing, it's ischemic, dead small bowel. So the small bowel ischemia, they're much more complicated small bowel resections. There's often a much longer section of small bowel that needs to be resected. There's a lot more decision making about what gets left behind. And there's all the decisions about, is this person stable enough that we can join them? Because if they're unstable, there's a higher chance they leak. There's all the decisions about, if we make a stoma, how proximal is it? Because the more proximal the stoma is, the higher the output from that stoma is going to be. And in some patients, the two unstable, and the sections of bowel that we're just not sure about. So we sometimes just leave stapled ends of bowel, send the patient to ITU with an open abdomen, and bring them back for a relook after a couple of days. And obviously that's a much more complicated operation than just removing a small wedge of relatively healthy small bowel. So then there's division of adhesions. This is a patient that I operated on a couple of months ago. You can see that this person's got a massively dilated stomach, big dilated loop of jejunum. The rest of the small bowel actually is very, very collapsed. And on the image on the right, there's a single transition point where this bowel goes from big and dilated to small and collapsed. Because it's a collapsed loop of small bowel, very easy to do laparoscopically because there's not all that dilated bowel there in the way. It's easy to get the gas in, it's easy to get a good view. And this is someone who'd never had an operation before, and they had what we call a band adhesion. So basically a band, a string of scar tissue in the abdomen that bowel had slipped underneath and got trapped. So this we could do laparoscopically. It was very obvious where the band was, very obvious to cut it, and it takes a very short period of time and can be easily completed laparoscopically. And then you contrast that to, sometimes there are people who have adhesions after multiple previous operations, and you've got to, all of the small bowel is just welded together, and that's an operation that you can only do open, and that can take hours and hours of unpicking adhesions before you even get to the adhesion that's the problem. So then there's the Hartmann's resection. So a Hartmann's resection essentially is our get out of jail free card for when there's problems in the sigmoid colon. So that can be cancer, it can be diverticulitis, it can be sigmoid volvulus, which is what you can see on the slide. The steps of that operation, so we need to mobilize the sigmoid colon and the descending colon off the retroperitoneal structures, things like ureters, and then we divide with staplers, leave the rectum in place, and then bring up an end colostomy, a stoma, and that's called the Hartmann's resection. Sometimes they can be really simple. So this is a sigmoid volvulus. It had perforated, needed to go to theatre. They've got to be an open operation because of how distended everything is. But actually, because of the pathology, the bowel is very, very mobile. The mesentery is very, very long because it has to be for you to get a twist. It has to be for you to get a twist in the bowel, which then means there's very little mobilization to do. It's very easy to staple off ends and just cut through the mesentery. And then in contrast to that, you can get Hartmann's resections that are very, very complicated. So this is someone who's had diverticulitis. It's been left managed conservatively for a long period of time, because in most cases you can manage them conservatively. Then they've had a perforation, and the arrows here point to this abscess cavity that leads from the sigmoid colon and down into the pelvis. And here, because there's been inflammation for so long, the tissue planes are really difficult to appreciate. It's really, really hard to mobilize that colon up. It's really hard to make sure that you're separate from the ureter and that you're not going to cause damage to any of those retroperitoneal structures. And these are the sort of Hartmann's operations that can take hours and hours in theatre. So I think the take home is that these operations that get labelled as the same name, it's a small bowel resection, it's a division of adhesions, they actually have a massively wide spectrum of technical difficulty and therefore time of the operation. And I think that's far more so the case in emergency operating than it is in elective operating. I think it's important from our point of view, from a surgical point of view, to discuss this at team brief. And I think it's important for you to sort of prompt us if we don't do that. Is this likely to be a young person who's never had an operation before, who's likely to have a band adhesion that might be a 20-minute laparoscopic operation? Or is this someone who's had 15 previous laparotomies for division of adhesions where you're going to be there for 5 hours? It can often be difficult to know how hard things are going to be before you actually start the operation. And that's where there's this concept that's coming in now, where we often start a case laparoscopically, we have a look to see how difficult it's going to be. And if it's obviously going to be a hard case, then we convert early to an open operation. But if on that diagnostic laparoscopy, it looks like it's going to be possible laparoscopically, we'll then continue and try and complete the case laparoscopically. So in terms of laparoscopic and open, it's the pathology that's important for NELA. So whether it's laparoscopic or open, those cases all go in NELA as long as the pathology is one of the NELA pathologies. The views actually are often better laparoscopically. You can get into some of those smaller spaces better and get a better view. The caveat to that is if someone's massively obstructed with lots of distended bowel, it's very difficult to get a laparoscopic view. With adhesions, it's hard to tell from the CT often whether it's this single band or whether there's lots of adhesions. So then you often end up putting a laparoscope in first to tell if it's going to be a case that you can achieve laparoscopically. In general, there's lots of research which shows there's better recovery and often less complications with laparoscopic versus open operating, but most of that research has been done in the elective setting. And there's actually an ongoing trial called the LACES 2 trial, which is looking at emergency colorectal surgery, and it's randomizing people to starting laparoscopically or starting cases open. And they've reported the results of the feasibility trial. It showed a trend towards less complications in the laparoscopic group, but it was just a feasibility trial, and the main trial was ongoing and hopefully will be reported at some point soon in the future. That's the end of my section. I'll pass over to Helen.
Okay, so my half of the talk really is, I imagine, not telling you anything you don't know already, to really highlight some discussion points that I think are really important going forwards with emergency general surgery. So a lady I saw recently, a 91-year-old female who only had a past medical history of hypertension, just on one antihypertensive medication, was sat having some bacon sandwiches with her granddaughter at lunchtime, and after that got sudden onset of severe lower abdominal pain. Her only past surgical history was of a laparoscopic hysterectomy a number of years before. She came to the emergency department at 4 o'clock in the afternoon. She had some blood tests done. Her observations were very remarkable. Her heart rate was in the 80s, her blood pressure was 180, and her CT scan was requested, which showed small bowel obstruction, which was a closed loop, likely due to adhesions, but there was a concern that the small bowel that was obstructed was ischemic. There was also quite a bit of free fluid in the abdomen. So straight away, when we see a CT scan that shows these features, we're thinking this is an urgent case for theatre, and it's a life-threatening pathology. Putting her information into NELA, she had a predicted mortality of 15%, and so it was time for a bit of discussion. So, armed with this information that I had received from the emergency department, I went to speak to the lady, asking her about what her baseline was. She's 91 years old, but lives completely independently, gets on the bus to do her shopping in Morpeth, and it was her and her daughter's wishes that she would be given the opportunity to have a potentially life-saving operation. So at this point, I talked to them about what I imagined to be the best case scenario, which is, as Sam's previously discussed, the best case scenario here would be that this is an adhesion, essentially, and the small bowels got stuck. And we go in, we snip one adhesion, we see the bowel suddenly jump back into life and pink up. We close her abdomen. In the next 24 hours, she's eating and drinking, and over the next couple of days, she's away home again. We all know that realistically, we have to discuss the other end of the scale, and it's always important to do so. So for these older patients who are actually independent, their feelings, from what I understand, are that death isn't necessarily the worst case scenario. It's how you get to that point is what's truly terrifying to them. So they don't want to lose their independence. They don't want to need a higher level of care, becoming dependent, and they definitely don't want a long, protracted, miserable in-hospital death. So I talked to her about the possibility that the ischemia was so much that a resection, even if technically possible, would be extremely high risk, and bringing a stoma, if she was to become unstable during the procedure, bringing a stoma out that's going to be high output is not going to let her thrive and let her enjoy a quality of life where she's eating and drinking and she's getting home. We discussed that would not be an option. So in the consent process, not only did I consent of the usual things surrounding the operation, things that we also consent for in this group of patients is explaining to them about delirium, etc. But also we were putting some limitations on what we would try to achieve surgically. So we wouldn't be bringing out a thought to be high output stoma. It's unlikely we were going to do a stoma at all whatsoever. And if we were to do a small bowel resection and we were to join the bowel, there was also an acceptance that this is most likely her one chance of a life-saving procedure, and we didn't think that if she was to leak from a join that would be a return to theatre. We thought that was probably going to be moving to a palliative care for her. So the procedure, so consented the lady because she was keen for theatre. I couldn't think of a reason not to operate on this lady. The numbers didn't look terrifying, and we were obviously prepared for the worst case scenario, but hoping for the best case scenario. The amount of free fluid that was on the CT made us think twice about approaching laparoscopically. We wanted shortest, quickest operation with this lady, and a small midline incision seemed to be the right choice, and we were proved correct. When going into the abdomen, there was lots of dark blood-stained fluid, looking really miserable, and then an extensive amount of ischemic small bowel. We didn't do a resection, we didn't do anything to even try to divide and reperfuse this bowel. It was dead. If we had done that, if we'd untwisted things, she may have got become toxic on the table and died on the table. We wanted to give her the best chance of having a little bit more time on the ward with her family. Just to kind of take a step back, sorry, she had general anaesthetic, she had spinal anaesthesia and invasive monitoring, obviously before we knew what the pathology, how extensive the pathology was. This is always a little bit of a cheeky thing between myself and the anaesthetist, that I do quite enjoy an operation that lasts less time than the anaesthetic time. So, moving on. Now, this lady was transferred to the ward in a side room. Her family were obviously there pre-operatively and were fully understanding of the risks and what we hoped to achieve for her, but were fully in the picture that it may not be possible that we could save her life. She was transferred to a side room, which in the hospital I was working at the time is very normal. You don't have to struggle to get a side room, but I know that that's a luxury in some places. So, but it was the right place for her in that particular trust. I don't think this is the best case scenario, obviously, because we weren't able to save the lady's life. It definitely wasn't the worst case scenario. We gave the lady a definitive diagnosis. We gave her family that understanding of the pathology. She wasn't in any pain at all. She didn't require any opioids after theatre. And her family, including her grandchildren and great-grandchildren, got to come and say goodbye in a really nice way, really, for want of a better word, sorry. It was all very controlled and very calm, and truly she didn't appear to suffer, and they were very grateful for that. So that's just one case that I think highlights the difficulty in this decision making, because if you look at NELA, you see, well, she died within 24 hours of an operation. Surely that's not a good thing. And how could we have decided before that this was going to be futile? So the future from a surgical point of view, Sam has already discussed minimally invasive versus open operating. I don't think in this case we would have changed anything. It was the right thing to do an open procedure. And actually, if we'd have done it laparoscopically, she may not have got that spinal anaesthesia that actually made her last day so comfortable. We need to look towards regional pathways, not pertaining to this case, but for ischemic bowel, and making sure that we're involving vascular surgeons, etc., early in places where there isn't a vascular team immediately available. We need to discuss further what futility means, and especially what surgical futility means. We need to know what patients' experience is. It's no good us making decisions for patients. We know that shared decision making is what the future is and what should be now. But to do that and truly understand what we're consenting these patients for, we need to look at what their experiences are with patient-related outcome measures. We talk about sepsis, we talk about, we've given patients and their relatives and all healthcare providers lots of information about sepsis, about surviving sepsis. And really, when we're talking about sepsis to the frail patient, are we actually giving them mixed messages, because surviving sepsis is the message. And really, if a patient's septic already and they're frail, should we be talking about something else potentially? In some cases, we need to do all of this decision making and discussion, avoiding bias where we can, and accepting that we're here trying to make this all fit into 20 minutes today with an audience who already understand mostly about what we're talking about. We're expecting patients and their relatives in a time of high emotion to understand things that we still can't make a unanimous decision on. So avoiding bias, but also accepting that people need help to make these decisions. And again, multidisciplinary meetings, mortality review, but also getting patient representation in those kind of settings to really make sure that we're delivering care for these patients and not just to make numbers better. Because we all know the best way to make the NELA numbers look better is operate on less people. Then we'd have easier access to CT, easier access to theatre, but we should not be operating on people who potentially we can save their life and give them a good quality of life afterward, the right timely operation. So what are we going to do? So as a group, nationally, we have to keep striving for these marginal gains, such as giving the antibiotics in time and getting people moved along the pathway nice and quickly. We need to, as a team, be encouraging to your emergency general surgery colleagues. It's much more pleasant and it's much more efficient to be working with committed and confident and engaged enthusiasts. We need to reframe this idea of being on call. The unscheduled work needs doing, and we just need to crack on and get it done. And obviously talking to each other in a way that makes this happen. So we all know that civility absolutely saves lives. We need the patient to be at the centre of these discussions. No two general surgery emergency laparotomy patients are the same. This is not a fractured neck of femur. It's not possible to treat everybody on a pathway pretty much the same. And I think something I just really, really want to press upon everyone is that, again, 20 minutes for this really brief whistle-stop tour of the surgical perspective. These discussions and these patients that have so much more complexity to them than other things we deal with. This takes time, and the time taken to make the correct decision and the talking to the patient and the relatives, that is time well spent when you have to be creating dialogue and a relationship that's going to go forward no matter what the outcome for this patient, whether it's the best case or the worst case scenario. They need to know that you have considered these things, that their opinion's important. And so please don't see in every case that time taken to make a decision is pathological indecision. And so we need lots more of this, lots more multidisciplinary learning to understand, what difference it makes talking to the patient before to their outcome afterwards, actually. This is a very, very busy slide. This is all really super stuff that I absolutely love. So it's about futility, about the uncertainty, about ELF2, which is defining the denominator, that's looking at patients that aren't operated on. And then really interestingly, patient-related outcome measures, which you see to the bottom left of your screen, which is about traumatic brain injury and patients becoming more frail. They still think that that's a positive, that they've lived, they've survived, and yes, they've become more frail. So it's interesting. What we think would be maybe not what they want, they potentially do want. And just a shout out in the top in the middle there, Emerald, look out for it. It's going to be about pathways in emergency laparotomy. So I know I've taken longer than 20 minutes, as always the surgeons do.
Thank you, Helen and Sam. That was fantastic, really interesting. So to our audience, there are plenty of questions coming in. Please keep posing your questions. Our tech team in the back room are curating them, and we'll be asking them asking those questions to our speakers during the panel discussion later. Okay, our next speaker is Dr. Brian Carroll, who will be presenting his talk on early consultant assessment and cross-sectional imaging in rapid assessment areas of the emergency department. So Brian is a consultant in emergency medicine working at the Great North Trauma and Emergency Centre at the RVI in Newcastle. He's previously held substantive consultant posts at University Hospital North Durham and Cumberland Infirmary in Carlisle. His primary clinical interests are major trauma, minor and soft tissue injuries, and point of care diagnostic testing. Hi, Brian, we can see you. That's great. We can see your slides. Oh, we can't quite see your slides just yet, Brian. So just hang fire for a moment, if that's all right.
What I'll do, Dave, is I'll upload a fresh set.
Okay, thanks, Brian. Yeah, we can hear you clearly, so that's great.
Now,
So Dave, just while we're waiting for Brian's slides to appear,
yeah.
You talked about the new introduction in NELA of looking at no laparotomies, is that right? When the decision's made not to operate?
Yeah.
When is that starting? When does that go live?
So the NELA contract runs for 3 years, and all being well will be extended for a further 2. Written into that contract are some timescales. So for the first year, April 23 to April 24, there's a year of sort of preparatory work, getting a head around how we would do this. Yeah. Second year, we begin to audit it, perhaps in a very focused patient group, maybe one pathology only, or a certain number of pilot hospitals. And then the aim is from year 3, 4, and 5 to roll that out more widely. So it'll be a phased introduction of the program. It's quite an ambitious project.
Right. Okay,
Brian,
I think we're good.
Thank you, Dave, and thank you all for inviting me to speak today. And thank you to the previous speakers for what they've put in so far. So I'm going to give a brief overview of what happens in the emergency department at the RVI, but is similar practice is shared throughout the nation, and how patients actually progress from being out there in the community to suddenly require an emergency surgery or a decision not to operate, ideally within the 6-hour window. So I'll just carry on from that. So in the emergency department, we have an abundance of patients, the majority of which come by ambulance. A certain percentage of those patients transferred in by ambulance will be pre-alerted as resus or monitoring patients. A smaller percentage will self-present. All of these patients will undergo a form of triage assessment, and then will be potentially redirected to a different area of the emergency department. Today, I'm going to talk mainly about the assessment area, which is also the rapid assessment and treatment area. And a lot of EDs throughout the nation have taken on this, adopted this model in terms of a more seamless and rapid processing of patients. Despite the flowchart showing them separate to the resus and monitoring patients, they share a lot of characteristics in being unwell and the investigation pathways that they subsequently follow. And ultimately, with those investigations returning a diagnosis, hopefully we can refer them on appropriately. Okay. So the assessment area which we have in the trauma centre at Newcastle consists of a 4-bed unit. We have 24-hour staffing by at least 2 staff nurses and 2 healthcare assistants. And we have the luxury of having 12 hours of rostered consultant time between midday and midnight, 7 days a week, where basically at point of entry into ED, a senior decision maker can assess, decide what needs to happen, and hopefully enact those plans. So the sort of patients we see in the assessment area are entirely unselected. As I said already, the bulk of those patients will be conveyed via ambulance. Some will walk in, and a smaller percentage will be redirected from other services. So surrounding walk-in centres, our own minor injuries, patients who become unwell in the hospital grounds or nearby, patients who become unwell in cardiac outpatients, etc., etc. So all of these patients, when they land in the assessment area, will have a set of observations done. In ED, we are very, very heavily dependent on news scores and patient pain scores as a triage tool to decide how sick or how urgently we need to assess these patients. Like I say, 12 hours a day, and usually beyond 12 hours a day, they will have a fairly prompt medical assessment, which will trigger their investigations. And if they require treatment, Dave and Helen have already spoken about particularly the 1-hour sepsis bundle of target time for antibiotic initiation. These are the sort of things that we have focused on in the back assessment area as a marginal gain and a quick win. Once they've had their medical assessment and their investigations initiated, they will then be retriaged to the ED queue. They may be unwell enough to require immediate resuscitation, get transferred to resus. They may require less urgent less urgent management and go to monitoring. Quite a few of them will await their investigations and be parked up on a corridor or in a room in ED, and a certain proportion of them will end up waiting for their further investigations in the ED waiting area. There may be barn door pathologies evident to the clinician who sees them, and they may generate an immediate specialty referral and bypass the ED queue. Okay. So like I say, 12 hours a day, we have the benefit of a consultant. Quite a few of our trainees are quite interested in this area and will try and run some degree of rapid assessment 24 hours a day. So if there are 2 regs on overnight, one of them will quite often be dedicated to resus or the back assessment area, depending on demand, but will trigger early investigations. So we bespoke each patient's investigations to their condition, and what we have at Newcastle is very good access to early cross-sectional imaging, which has become the mainstay of pretty much all diagnostics. If a patient has a very clear pathology with a very clear specialty, umbrella specialty with it, we will refer them directly and hopefully not have the whole duplication process, excuse me, of seen in ED by an ED F2 referred to a surgical or other specialty F2, then referred on to said specialty registrar, and the delays that all of that creates. So like I say, we have very good access to cross-sectional imaging. It was all set up under the umbrella of being a trauma centre, but we do have a dedicated CT for the emergency department. When I say dedicated, it's very, very well dedicated for trauma patients, and as part of the trauma call alert, CT do receive a trauma alert and know that they need to put the scanner on pause after the next patient comes off, pending the trauma patient's arrival. We do not at this time have a similar setup for the abdominal catastrophe patient, and that's possibly something we should be looking to evolve. In terms of CT acquisition, it's all pretty seamless. 24 hours a day, we do have at least an ST3 radiology trainee for advice on imaging and reporting of said imaging. Big benefit which computer systems have given us is that we've got immediate availability of images on PACS systems. But all that said, the workload that we provide or deliver to the CT scanner at the RVI is very significant. And it's much easier to get the images than it is to see a written report. You know, one thing is much more rapidly available than the other. And plain head scans are much easier to report than complex abdominal scans, and we need to bear that in mind. So trauma CT scans are really straightforward. They've got very fixed protocols. All they want to do is identify skeletal, organ or vascular injuries, and they look for hemorrhage. So all trauma CTs are arterial phase CTs, the end. If there is a hemorrhagic site identified, they may go back for a delayed arterial phase scan to see how extensive, if the hemorrhage is ongoing. Abdominal CTs for abdominal emergencies are less straightforward and they require discussion. And this is one of our rate limiting steps, that we need to go and speak to a radiologist, present them with the clinical information that we have, and between us decide what's the most appropriate imaging protocol for said abdominal emergency. Once we've agreed on what sort of imaging to acquire, then we have to accept that the interpretation of those images and the time taken for reporting is considerably more intensive for an abdominal scan than. So in trauma scans, we have the trauma team leader accompanies the patient to the CT scanner, and there's a handwritten sort of primary survey CT report on which will identify life-threatening emergencies. It's very, very rare that the clinician who has requested the CT will be in a position to go to CT with said patient for a live report from the radiology registrar or consultant. And again, is this an area that we need to improve? And it probably is, if we're going to achieve better timeframes and NELA concordance really with referrals. So once we've decided what imaging we want and what specialty we want, we'll be referring to the surgeons, and I'm hoping not to offend anyone, but certainly the surgical on-call service at the RBI feels stretched, and that's on a 24-hour basis. It's difficult. You ring up and you're told by a theatre nurse that the certain on-call registrar and SHO are operating. The consultant is sometimes available, not always available, particularly out of hours, because of contracts and working time directives. The surgical on-call service cover more specialties, and certainly at the RBI, the surgical SHO out of hours covers plastics, which is also a busy service. Traditionally, surgeons like to have diagnostic results before they actually make patient contact, and this is even more the case now. when I was growing up, you'd refer an acute appendix to the surgeons, and the first question they ask is, what are the white cells? Now you refer them an acute abdomen, they say, what does the CT report say? These things take time, and if we're referring patients to the surgeons at 4 hours post booking in an ED, waiting until the report comes back, we've already lost 2/3 of the time before they should be undergoing laparotomy. So maybe there needs to be some cultural change as well. At the RBI, we have a specialty trainee delivered service 24 hours a day, and whether or not they're the most appropriate person to be making do we perform a laparotomy decision is again a reflection on how stretched their service is, and maybe we need to encourage development and expansion in the surgical services. All of that said, we don't see very many patients who fall into the NELA category in the scheme of the number of patients we see a day. They very often present fairly atypically, as Helen and Samuel have just presented. We see pre-alerts for fast AF, low blood pressure, and it turns out they've got ischemic bowel. We see shorter breath elderly patients, and it turns out they've got bowel obstructions. There may be a delay in image acquisition because they require a certain level of resuscitation before they're well enough to go around to CT. And quite often they've got multiple comorbidities which need to be addressed as part of their ED management. So where might we improve? I think I'm blowing our own trumpet, but to have 12 hours a day of consultant prompt assessment is pretty good at the RBI. In our current model, we don't have resource to extend that beyond 12 hours, but it should be something that we strive to do. Again, at Newcastle, we have tremendous support from the critical care team, and that rarely creates any delay to have a critical care assessment provided. Through no fault of the individuals, the surgical specialties may be slightly more delayed in their response. And if they kick the can down the road a little bit and say, ring me back when the CT is reported, we've lost a great deal of ground. The other frustration at times with Newcastle is some of the surgical specialties are at the Freeman, and they can be slightly more difficult to access. I'll leave it at that. Quick wins, as Helen alluded to, should we have a more robust CT triage system? Does somebody with an acute abdomen trump an elderly person on a DOAC who's had a minor head injury, but NICE says we need to scan them? So we need to liaise with the radiology service and see if there's a way we can bump people up or down the queue depending on what we feel we require. CT is very good to us, but one person 20 out of hours reporting on the number of images that we demand from them is probably not enough, and whether or not there is scope for expansion in how CTs are reported and how rapidly the reports get turned around should be something we consider. In terms of the specialties, to have an ED dedicated surgeon who is always available would be ideal, but again, the surgeons are under-resourced, and how we can generate that is open to discussion. But ultimately, we need a surgical consultant making decisions a bit earlier in the whole diagnostic process. And that, I think, is pretty much all I'll need to say today. Thank you.
Thank you, Brian. We're really grateful that you could join us today, and having an emergency medicine perspective really helps appreciate the patient's journey from arrival in the ED through the anaesthetic room and eventually onto theatre and critical care. We're going to move on to the panel discussion and invite our speakers back to join us.
Oh, hi, Venkat.
Think you're on mute, Venkat.
Hiya.
Unmute. Go.
And have we got Helen and Sam as well?
I think
I'm unmuted, but my video's not being started, as I can't do it. You cannot start your video. There we go.
There you go. We can see you now.
Right, brilliant. Right, I'd like to say thanks for your talks. That was really good, really thought-provoking, stimulating stuff. Fantastic. We've got lots of questions that have come in. I'm just gonna, Helen, can I ask you a question first? I've written down a note here. I don't exactly understand your specialty training, but unless I'm mistaken, you are one of the only, if not the only, senior registrar in general surgery that I've come across who has a stated interest in emergency general surgery. I don't even know if that exists as a subspecialty within the training program, and if there are other colleagues that are on that training program. And listening to your talk about the lady with ischemic bowel, I think what struck me there is with your EGS interest, do you think you bring a different approach to this sort of patient than the generalist abdominal surgical senior trainee? Does that make sense?
Yeah, so I'm definitely surgically weird, and I'm sure there's a few people in the audience who have worked with me that would agree. But this is because we've made emergency work so unpalatable for the majority of people. We make it chaotic, we make it difficult, we have difficult conversations with people, not just patients, but colleagues and people from other teams. And I think the things that kind of suit me about it that make me weird in a surgical specialty are that I'm pathologically nosy. I want to know what everyone else in the hospital is up to. And I don't like knowing what I'm doing next week, because that means I have to have planned it and be organised about it. So anyone who knows, like me doing this presentation, it has to be done last minute because I'm just not someone who prepares. Those aren't things that generally get you very far through surgical training. So I think I am weird. I hope that through my protracted training that maybe a few people have seen along the way that, oh, you can enjoy emergency work, but they're few and far between, again, because I think although we might be excited by the operations that we do, the other stuff that goes with it, just in emergency stuff, especially frailty, emergency general surgery, and as Brian alluded to, a lot of the presentations that we see don't end up in a laparotomy. So a lot of my colleagues, especially when you're going through training and you're kind of fighting for numbers really to get through your training, you think, oh God, not another one that I can't operate on because I need to get those numbers. And when you talk about the regs in theatre, that's where we have to be. That's the only way out of our training. It's the only way to progress. That's where we have to be. So it's kind of that conflict really between training, the job, and looking after patients. And yeah, I don't know how else to answer that, Dave.
No, that's okay. Well, Venkat, yeah, am I right? You're training program director. I don't know for which part. I'm sorry to be ignorant on that. But what are your thoughts as training program director in general surgery on emergency general surgery training? You know what I mean, as a subspecialty.
I think it's an important subject. Just let me introduce myself. Yes, I'm a training program director for the core surgical training. I think last 5 years or so, various associations, especially ASGBI and other associations, have promoted emergency general surgery. But nationally also, there's not much at stake. But however, it is such an important subject as we all trying to provide swift care for these emergency surgical patients, because time is so essential. We have advertised nationally, quite a few centers have done that, but still not much of uptake. I don't know what else we can do to promote, apart from the sort of awareness programs what we're delivering today might be helpful in the long run, definitely, for sure. But yeah, so having that mindset from the early part of the training, as Helen was interested in, will be certainly helpful for future, no doubt.
It's really hard work, isn't it? Non-elective work, emergency work is much harder than elective work. Certainly in my specialty, for me, my day in the emergency theatre is much more draining than any elective list.
Yeah, and they're not prepared. They're all common as a kind of, you don't know what you're getting, and that's a big challenge. But having that focused training, what Helen was interested in, will be really, really helpful, because the mindset is the way you think, touching upon the care of earlier involvement, and then getting the CT done, having the clinical assessment before asking for the CT. Those things will be really, really helpful for patient outcomes, which Brian touched upon before.
I could. Oh, sorry. I'll just add a couple of things, if you don't mind. So I think things we need to focus on with emergencies are that this is a subspecialty of its own, and being good at emergency is being good enough, like to call yourself a surgeon. You don't have to have another interest as such. You can be interested in emergency, and the places that have been successful in recruiting have changed their way of working. And it's the attraction of emergency surgery, emergency general surgery, is you can do sessional work. This is going to talk to the anaesthetist. So any trainee anaesthetist that suddenly think that emergency general surgery is a good idea, that would be great. Yeah. It's sessional, like anaesthetics is. You team working, you don't have to have the ego of having your name at the end of somebody's bed. You can work in teams, you can do all the things that kind of, I suppose, historically surgeons don't do. And when you look at other countries such as the States, acute care surgery, so we're not talking trauma, because let's be honest, in the northeast of England, and I know we've got people from around the UK, but there's very, very few places in the UK where you could truly be a trauma surgeon and have enough throughput to truly be your specialty, your niche, because the volume just isn't there compared to other countries around the world. And so we do have a training pathway that is trauma. Again, historically, it was only really military that could do that, because you had to be able to wire a jaw and tests and stuff. And so around the country, you can't really get the exposure to do the emergency training pathway. But all of us in general surgery have to reach a certain level of emergency general surgical competence. But obviously there's a mass variation in what people's interests are, and that is where their confidence is, will be where their main interests lie.
Yeah, thank you very much. Brian, I mean, it's sort of related to that topic. Well, I don't really have a feel for what proportion of patients with an acute abdomen that present with an acute abdomen end up in theatre having a laparotomy or major emergency laparoscopic work. I haven't really got a feel for that. Is it 1 in 10? Are the 10, assessments for each patient that ends up in theatre? I'm not certain. And for each 10 that end up referred to surgery, are there what proportion arrive at the ED with tummy ache? I don't know. So I'm just, while you were speaking, Brian, I'm struck by, in our specialty in anaesthesia, we're very lucky because we are presented a patient with a diagnosis, and all we have to do is work out the easy bit, which is the technical side of how we're going to optimally manage them in theatre, really. What I don't have to do in my job is take an unfiltered patient who's just presented to the emergency department and come up with a diagnosis. So, I'm it's good to reflect upon that a little bit. But the question I'm going to pose you, Brian, sorry, I'm rambling.
Yeah.
I've got a question related to what I've just said. It's about pathways. So what do you think about having formalized pathways of care for patients with abdominal pain, perhaps a minor derangement of their news too, their physiology? So I've come around to the way of thinking that pathways are quite good, because they will probably over triage, and you begin that pathway and then you'll work your way through a diagnostic process. But that is different perhaps to what you're bringing with your senior expertise to the emergency department in the RVI. What do you think about that?
I think the key word in all of that is filtration. We're currently rolling at about 320 to 350 presentations a day. We probably refer somewhere between 10 and 20 in a 24-hour period to surgery. So it's a small percentage, but invariably we have more than a semblance of a diagnosis by the time we refer them, because there's little value in our framework in referring somebody unless they're a surefire admission. So one of our key points in the patient journey is a decision to admit timestamp, and we're measured on that. So quite often we will strive to decide that this patient does not need to be admitted and can be seen the next day. So in terms of pathways, we have pathways are good if you're stable in the emergency department. So Helen alluded to a neck of femur pathway. Great if you're stable, no use if you've got fast AF and not much blood pressure and a broken hip. So, stable surgical patients, we will refer to the surgical assessment unit either the same day or the next day, with investigations in between or not. Unstable patients, we have to resuscitate and investigate simultaneously, and then coerce the surgeons to come and make a decision. So because the presentations are so varied, and quite often they generate a curveball. So as I said in the talk, little old man with fast AF and not very much blood pressure, we CT him because he's got a risk for VTE, and it turns out he's got ischemic bowel on his CT. We may already be 5 hours into managing that chap before the ischemic bowel comes to light. So I think to construct pathways, because we've such a broad spectrum of presentation, it's difficult to plug people into pathways.
Yeah. Okay, fair enough. Communications around CT. So I'm quite interested in this.
Yeah.
Lots of anecdotes. It's really interesting that you say that here's someone with, you think they've got appendicitis, and you ring up the RSO and they say, get the CT. The subsequent phone call says, what did the CT report show, or whatever.
Yeah.
And it surprises me a little bit that the decision whether or not to come and review the patient is entirely based on that CT report. So what happens when there's a mismatch between what the provisional CT report says and the patient condition? If the patient has not been seen by a surgeon, there is no opportunity to go back to that radiologist and say, are you sure that we're not missing something else? Because you're saying this is just a bit of early inflammatory bowel disease. I'm looking at a patient with hypotension, tachycardia, raised lactate.
Yeah.
It just doesn't quite add up. So if you don't have that direct communication, I would be worried that you've lost the opportunity to push the CT provisional report back up to the consultant radiologist. So what do you have there in way of communication?
So again, we are pretty fortunate in that there is a 24-hour ED consultant on site. If one of our training,
is that right? You'll, sorry to speak over you, but you'll step in if there appears to be a mismatch going on. You will assert some authority there and say this just doesn't add up.
From a personal point of view, yes, I would, and I suspect 80% of my colleagues would. If any of us have sufficient concern that a specialty review is required, regardless of what the CT shows, I personally would never accept a surgeon saying, well, the CT is normal, so I'm going to do something else for the next hour. If the patient requires a review, we'll insist on a review. If the surgical juniors don't feel that that's appropriate, we will discuss it with their consultant, and invariably somebody will be dispatched to come and review the patient pretty promptly. But not all units have on-site 24-hour consultants for, you know, and it's the year 2023. We should not have to get out of bed because a surgical reg has decided he doesn't want to see a patient based on a normal CT scan. You know, we should be a bit more developed than that. But I'm quite happy to take on that battle, and most of my colleagues would if somebody felt that a CT is a perfectly valid reason not to review a patient.
So we're lucky, or the patients in Newcastle are lucky, that we have a resident ED consultant. We're also quite lucky in our hospital that we have a resident radiologist.
Correct.
Things 24 hours a day.
So we're very much more blessed than most hospitals, certainly in the Northeast.
Yeah.
Could I mention something on that?
Yes.
Yeah.
I think, and Helen will probably agree with this, just when you were saying about the number of patients and the number that end up in laparotomy. So I work currently in Northumbria. We see maybe 30 or 40 patients every day with abdominal pain. Helen, would you say that's about the right number? Yeah. And of those, a small handful end up with an operation, and maybe, you know, one of those will end up with a laparotomy. And I think no matter how good of a surgical reg you are, it is very, very difficult to say which one of those patients out of the 40 are going to end up with a laparotomy, because they'll all have abdominal pain, they'll all have some peritonism, without any bloods or any imaging. You know, a fair few of them may have a news or two of three. Some 60 or 70-year-olds, or some people who are a bit immunosuppressed or diabetic or whatever, may have a use of 0 and have perforated their abdomen. So it's really, really difficult to narrow down which of those 30 or 40 people are going to be the one person that's going to end up in a laparotomy. I think how quickly we see people often depends a bit as well on how worried the ED department are. So if ED have said, oh, I've got this person who's come in, they're in resource, they've got a use of 6, I'll say, right, fine, I'll come and see them straight away. There was a woman who came in like that the other week whilst I was on call, went straight to resource, wheeled around to the CT scanner myself, and had a discussion with the radiologist, like live, as soon as the images were available, about what was on the CT scan. And then that's a case that's really obvious and that's easy. And I don't think there's any surgical reg that wouldn't come and see that patient in resource pre-imaging. But then also there might be someone who's got a bit of tummy pain, right iliac fossa, you're not sure what the cause is, the white cells and CRP are a bit in the middle, their U score is 0, they look otherwise well, the ED team aren't particularly concerned about them. And then I can come and see them before the CT scan, but based on the blood test and the story, which I trust my ED colleagues, to have gotten correct, I know that the only thing that's going to change what I do next is the CT scan. So it makes perfect sense when they're stable and the ED team's not worried about them, for me to see them after the CT scan rather than going to see them saying, I agree completely with what the ED team said, we need a CT scan, leaving and coming back when you've got the workload of 30 or 40 other patients to see. So I guess that's a bit of my rationale for why sometimes I see people after the CT scan's been done, and why sometimes I'll go straight to resus and see the person. It's also a lot more difficult if a person's sat in the main waiting room or in a corridor and you can't examine them properly and what have you. That makes it a lot more difficult to go and make a decision, especially when it's a department you don't work in, you're not exactly sure how it works. Whereas if you get a call and it's, there's this patient who's in red 3, they're ready for you to come and assess them, then that's a lot easier for you to come and quickly make an assessment. So I guess that'd be my input on it as a junior surgical reg. Yeah.
Thanks, Sam. That's interesting. It's interesting to sort of hear that discussion from both sides and get both sides' opinion on it. Dave, I've just got a few questions. There's quite a lot of questions that have come in about sort of quick questions about NELA. So can trainees log into NELA?
Absolutely, they can and they should. So the local anaesthetic or surgical lead in each hospital has privileges to create new user accounts. So every rotating trainee should have their own NELA login. Sometimes we get asked, can we have a generic login that people can share? The official answer is NELA does not support the idea of sharing logins because there's patient identifiable data in there. Just to reiterate that, that's the official line. NELA does not support generic logins, but I know they exist.
Okay. And is anybody able to export their own data from NELA?
Yes, absolutely they are. In fact, I've got another small slide set later on this morning that I'll talk about that in a bit more detail. It's a good question. Yeah, I'm glad there's some interest in that.
Okay. And then where do the targets and the standards that NELA use, where have they come from?
Yes, it is a good question. So often I hear people referring to the NELA standards, but these are standards that are written by others. They are adopted by NELA, and NELA has a contractual, it's given the task of auditing against those standards, but they are written by other groups. So a big part of it's a recent work, there's been a set of standards that have been used for about 10 years. Some of them are slipping out of date. So a big recent piece of work has been to review up-to-date recommendation and standards. And that is influencing the year 10 data set that we're starting from April. But definitively where most of them come from is a publication called The High Risk General Surgical Patient, published by the Royal College of Surgeons 2018. And that sets out some very clear, unambiguous standards of care around diagnosis and management for high risk general surgical patients. But there's other groups in there, NICE, NCPOD, Royal College of Anaesthetists via the GPAS documents, CPOC, I alluded to that this morning, Centre for Perioperative Care. So NELA takes these different sources of standards, and that's what sets the RAG rateable data that we record and report upon.
And then we've got an interesting question that's come in that's both for the surgical team and for sort of you from an anaesthetic point of view for us. Is there a general opinion that spinal analgesia for an emergency laparotomy is advisable even if a patient has suspected sepsis? So Helen, I know you spoke about your patient who benefited, in your opinion, from that spinal, and I know that there's kind of some polarizing opinions about that. So what do we think about advice?
So I could ask you that, Jess. What do you think?
I think it's a difficult question to answer. In terms of advisable, I think it depends, which is not a great answer, but I've certainly seen it in suspected sepsis, a one-off spinal, if you think that will be beneficial to the patient. However, I'm not sure what the evidence base is for that. There is a risk. There's a risk with any procedure. There is a risk in suspected sepsis. For all that risk is small. And I think it's about having a discussion with the patient about what that risk is and what we feel the benefits are. In terms of the evidence base, I'm not sure there's an evidence for outcomes based on having a spinal, but it feels humane and it feels like something I want to do and have certainly done before.
Yeah, I agree. There are different opinions. Some people have very polarized opinions that it's the right thing to do, always do this. Others, no, never do that. I've covered the emergency list for 14, 15 years. I don't think I've seen a patient that has come to harm for a lack of central neuraxial blockade after emergency abdominal surgery. And I have seen patients that have come to harm from an epidural catheter that was placed in the emergency setting. So probably those anecdotes, like all of us, that slightly influences one's own practice. In elective surgery, I have no hesitation to recommend, effectively, it's joint decision making, isn't it? But I would recommend the use of intrathecal diamorphine. I think it's fantastic. And Helen's given us a really good example in the emergency setting where it was transformative to that patient's care. Some anaesthetists are thicker skinned than others about this. Some are very sensitive and exquisitely sensitive to the risks. Others feel that this provides some very clear benefits to the patients and that we should do that. Yeah. I think it depends. It's quite nuanced, probably, isn't it? And you need to take the entirety of the patient's comorbidities and the predicted pathology. Helen, did you want to say something there?
I just think that recently, having worked with someone who is hugely pro, and I'm sorry, I'm clearly not fully informed anaesthetically, but he does a quick shot for pretty much anything, such as bum abscesses, etc. I've forgotten the term that's used for it. I'm so sorry to everyone, because I know you're majority anaesthetists. So, but you know, even where there's infection, because sustainability wise, this is much better. You know, the patient gets out of hospital still, there's a lot less stuff going on, and cost wise and things, than even a short GA. So I think extrapolating kind of from that, and saying, because you know, not every laparotomy is sepsis. The lady I was talking about, she's obstructed. She's unfortunately got dead bowel, which we can talk about, you know, whether transligation or anything is a risk or whatever. But the truly septic person with a ridiculous temperature who's got a belly full of poo, that's a very different patient to someone who's got a pocket of pus, who's got something that we're going to control quite quickly. And I think we just see huge benefits from our side of things. The patients that have truly well controlled, who are well analgesed from the get-go, the difference it makes them, as we know, in elective setting. And we just need to take that information and make it work. And then if we see a problem, then we'll have to again.
Guidance.
We can't just keep trying to find evidence before we do anything.
There's some guidance coming from the ERAS Society around emergency abdominal surgery. They've done it in 3 bits: pre-op, intra-op, and post-op. And the latter 2 are, I think, ready to be published. I haven't seen them, but I suspect there might be some guidance in there with an increasing interest in ERAS amongst emergency surgery patients. I think we're almost out of time. I've had a signal to say to wrap up our discussions. Fantastic start to the day. I really appreciate the effort that goes into this, guys, for your time in preparing and presenting this morning. So I'm going to say thank you now as well. Thank you. We're going to take a break now till 11 o'clock, to allow everyone to replenish their teas and coffees, and we'll see you back here at 11. Thank you.
Welcome back, everyone. We hope that you're feeling refreshed and enthused for the next section of our programme. We're going to kick off with another poll. We would like to see what level of experience you have in terms of your grade working within your specialty or within anaesthetics. The poll should be appearing live on your screen now. There it is. While you're answering the poll, we are going to now introduce the next guest speaker. Dr. Ian Clement has been a consultant in critical care and anaesthesia at the Royal Victoria Infirmary in Newcastle since 2007 and has for the last 8 years been head of service for the Ward 38 General Adult Critical Care Unit. His clinical interests involve a range of work seen in a general adult critical care unit with an additional emphasis on the specialist care provided for burns, upper gastrointestinal surgery and maternal medicine. In addition, he has supported the development of a proactive clinical research team who actively recruit patients to NHS portfolio studies. He provides anaesthesia for neurosurgery, colorectal and maxillofacial surgery. His major non-clinical focus in recent years has involved acting as lead clinical advisor to estate services in developing a major project on the RBI site, which will ultimately deliver a new, modern, carbon-neutral hospital wing, housing multiple specialist regional services, including the largest integrated critical care unit in the north of England. Ian, we can see you and we can see your slides. It's over to you.
Thank you. Thanks so much for giving me the opportunity to talk about critical care in relation to emergency laparotomy in this group of patients. This is a topic that Dave and I have discussed frequently over the last decade or so, and I know that it's a topic that we both feel very strongly about. What I'm hoping to do in this next 20 minutes or so is maybe just to help people think about the role of critical care in relation to this group of patients, and maybe challenge some of the assumptions that sometimes hold us back in terms of our thinking around what role critical care might play and which patients might be appropriate for it. Now, let me see if I can, there we are. So without wanting to kind of patronize the audience, start with a very basic question. What does critical care actually do? Clearly, organ support is our mainstay. We provide organ support for patients with reversible organ failure in order to buy time for the treatments that we're providing in conjunction with our specialist colleagues to get the patients better. That's kind of your standard definition of what an intensive care unit does, and would be how most people would view it. And the picture on the right at the top is kind of how most people would imagine an intensive care patient to look, attached to a ventilator and lots of invasive monitoring and a lot of machines. I suppose what I'd like to get over is this concept that there is much more to intensive care than that. There's a significant role for monitoring in the absence of organ support, and and consider this kind of, if you like, difference between the level 3 ITU level care and level 2 HDU level care that we provide. Many patients within a critical care unit will look more like the patient on the right at the bottom. They're not directly receiving invasive organ support for much of the time that they're on the unit. What they are doing is receiving a higher level of monitoring than they would get access to on the ward. And they are under the care of an extensive multidisciplinary team, which is able to bring to bear many more resources and a much higher level of staffing than is feasible or necessary or even desirable in a ward environment. And that, in many ways, I think is the biggest difference. I don't want to be too data heavy in this, but I'm just going to show you some data from my own intensive care unit, which I think maybe illustrates some of the work that we do, and then we'll go on to we'll look at a case which I think throws up some interesting questions, and then we'll just consider in general terms some of the things that we've talked about. So I work on Ward 38 at the RVI, where we have 2 intensive care units, 42 intensive care beds. We admit between 2,500 and 3,000 patients a year across the 2. Ward 38 fulfills the role of a general intensive care unit for general medicine, general surgery, and is very much a kind of typical mixed intensive care unit, albeit at the larger end of the spectrum. So we admit about 1,200, between 1,200 and 1,400 patients a year. 1,200 actually is a little bit of a lower than our historical number. As all general intensive care units, our data in terms of our kind of annualized run chart data has been thrown into havoc by COVID. So the data we're looking at is 2022. If you go back to the previous couple of years, it's very hard to interpret data in a meaningful way because things changed dramatically. And even in 2022, we still had a hangover effect with staff absences through COVID. So our activity wasn't up to our historical kind of norm. But in 2022, out of 1,200 admissions, we admitted 168 patients that would fall within the kind of NELA remit, if you like. So this data has been extracted from our ICNARC database. As many of you all know, all intensive care units in the UK submit data to ICNARC, which provides benchmarking and quality key performance indicators for intensive care units against a standard critical care model. So the patients that I've extracted in this data wouldn't map exactly to those that you'd get from the NELA database, because I'm approaching this from the critical care database perspective. But these are emergency general surgical patients, essentially, that would more or less map to what we would consider a NELA patient. So 168 out of 1,200 admissions, so significant proportion, around about 15% of our overall workload. What's the age distribution of those 168 patients? You can see that it's skewed very much to the older age range. There's a significant tail of the younger patients. These will generally, many of those will be patients with inflammatory bowel disease, and then increasingly amongst the older age group, it'll be the kind of stuff that we saw presented by the surgeons this morning. If we contrast that with the average age for all comers to our intensive care unit, which is 58.2, you can see that this population of patients, the NELA group of patients, is skewed very much towards the older age group. What about the length of stay in intensive care or in the critical care environment? A lot of patients stay for a short period of time. So the majority will stay for less than 2 days. And then we have a tail of patients who stay for a more prolonged period of time. And again, this would contrast with a median length of stay across all 1,200 admissions of around 3.5 to 4 days typically. So this is an older group. It's a group that many of whom have a relatively short stay in critical care. What's the highest level of care that these patients receive? So only 20% of them will receive level 3 care during their stay in critical care after their surgery. That contrasts with about between 40 and 50% of our admissions will have a highest level of care of level 3 care. That's not to say that 50% of our bed days are level 3 care. Many patients obviously will begin as level 3 and then convert to level 2. And I'll say a little bit more about that distribution between level 3 and level 2 care a bit later on. The mortality rate, this is hospital mortality rather than critical care mortality for this group. 7% mortality rate on discharge from the RVI for this group of patients admitted to critical care. That contrasts with an overall mortality rate for our 1,200 admissions in the year of 12%. 12% is absolutely typical critical care mortality rate. So one of the things about Ward 38 being a general intensive care unit, it's almost a sort of bellwether, if you like, for UK intensive care as a whole. Clearly, within the total sort of the totality of the 250 or so critical care units that submit data to the ICNARC database, there's a very disparate group with lots of surgical specialist units like cardiac units, neuro units. Many of these units have a very high proportion of elective surgical admissions and report much lower mortality rates overall. But if you look at the totality, then 12% mortality is the standard for patients in the UK being admitted to a critical care unit. And that actually, interestingly, represents a significant reduction over the last 15 years when mortality rates ran at more like 20%. What's a discharge destination for our 168 patients that fall into this category? This is the ultimate discharge destination on discharge from the acute hospital at the end of the hospital stay, which included this operation and intensive care unit admission. 87% of them got home, even though they're an elderly group. 6% of them ended up in a nursing home or similar sort of longer term care facility. 7% of them, hopefully presumably the same 7% that died, ended up in the mortuary. So that's just a quick run through of some of our data, just for a representative data from the last year on Ward 38. So that brings us to the question, which patients should we be admitting to our critical care unit after an emergency laparotomy? So we can look at, we can use our predictive models, the P-POSSUM score that we used to use, or the NELA risk model, and we have similar ones in critical care, the ICNARC risk of death model, for example. We can look at those and say, well, clearly we would want to admit the patients at higher risk and maybe not admit those at lower risk. We've traditionally talked for the NELA group of maybe a cutoff of 5%. Interestingly, if you compare that 5% figure with what we consider acceptable mortality rates for elective surgery, then clearly we wouldn't countenance not admitting an esophagectomy or a coronary artery bypass graft patient or a craniotomy, elective craniotomy patient to a critical care environment, even though all of those operations carry a much lower predicted hospital mortality. Clearly, there's a difference. They're elective cases. These are emergency cases. We can choose to do the elective cases around bed availability, whereas we don't have the same freedom with emergencies. But it does bring the question, how sick is sick enough for critical care? And are we discriminating still against emergency cases versus the elective cases? I know Helen in her talk earlier on talked about how emergency care remains is made to still look like an unattractive option within the NHS. I think those of us that have been around for a bit longer in the tooth would say that this kind of prejudice, if you like, in the NHS against emergency work in favour of elective work is very long standing, and actually things have improved significantly compared with when I was setting out as a clinical medical student 30 years ago, and even as an anaesthetic SHO working at the John Radcliffe in Oxford in the late 1990s. The concept of an emergency list just didn't exist. When emergencies came in, they were looked after by the most junior member of the team, which at that time was me. You wouldn't get a consultant present. You didn't have a dedicated operating theatre. You had to just take your chance on finding somewhere to do even very complex cases. In terms of that evaluation of, does this patient deserve intensive care? Are they sick enough? Are they younger and fitter and therefore more deserving? Or are they older and frailer, more fragile and in that way more deserving of a bed in intensive care? I think just before I move on to the case, which I think illustrates some of these examples, the concept that I'll come back to at the end that I think we should consider is that a value added. What is the value added in bringing a patient to intensive care? Rather than thinking about is it deserving? Is there a specific mortality? Are there a specific set of criteria that necessitate critical care admission? The way I always like to look at this is there value added in bringing this patient in this situation with this set of circumstances to critical care? What can we do that may be beneficial? So I'm just going to, I think it's always useful just to look at, it gives a slightly more human perspective. If you look at a case, I'm just going to briefly describe a case. This has quite significant similarities to the case that Helen described earlier on this morning. But I'll just run through this because I think it raised a few interesting questions. So this is a patient that I was involved with. We admitted when I was covering the unit. A 96-year-old lady. She weighed 39 kilograms. You might think, blimey, she's cachectic. In fact, she wasn't. She was just one of these sort of sparrow-like kind of bundles of energy. I suspect she'd never been much more than 40 kilos throughout her entire life. She'd been not right for about 3 weeks. She'd seen a GP a couple of times and wasn't particularly keen to go into hospital. She'd got some abdominal and some back pain. Then in the run-up to finally been persuaded that she needed to come into hospital, she'd started vomiting and that was getting worse. By the time she was persuaded to pitch up in the emergency department, which she did in the early hours of a November morning, she had an acute kidney injury, a urea of 10 and a creatinine of 88, which for a 39 kilogram 96-year-old represents a really quite significant kidney injury. That's set against a baseline creatinine of 50. She had a lactate of 4.3. She was recognised as having likely abdominal sepsis. She got early antibiotics, early initial resuscitation. She got a CT scan at admission plus 2 hours, which was still, she'd come in about 6 in the morning. So she got a CT scan before 8 o'clock. That was reported in a timely fashion. That showed a closed loop obstruction with extensive small bowel ischemia. That was reported by a consultant. In terms of background, she was really no significant past medical history, treated hypertension. Social history, she lived at home. She didn't have a care package in place, but she did get increasing amounts of help from her family. And there had been discussion about maybe setting up a care package, but that hadn't yet happened. Rockford clinical frailty score of 6. The team did the maths, NELA mortality of 15%, morbidity of 59%. She was reviewed by a consultant surgeon, and then further discussions with senior anaesthetic and critical care over the course of the morning. And her son was present. She had capacity at this point. She was unwell, but able to understand what was being discussed. She was given the option of conservative management with emphasis on keeping her comfortable, but on ongoing care, and the likelihood that in view of the CT findings, this would be a non-survival event, versus surgery. She was keen to proceed with surgery if that was thought reasonable and advisable. So it was agreed that we would proceed. We had, prior to surgery, other discussions about where she would likely go post-op, and it was agreed that HDU would be appropriate, given what was likely to be a not insignificant surgical intervention. But if things went badly, if she was in significant organ failure at the end of the operation, we wouldn't be escalating to level 3 care for a prolonged period of time, and a DNA CPR, given her age and her frailty. If we got to the point of cardiac arrest, then we'd probably lost, and the DNA CPR would be appropriate. And she and her family are in agreement with all of that. So she went to theatre just after lunch. So that was, time into theatre was about 8 hours after the time she was booked into ED. That showed an adhesional obstruction with a twisted ischemic small bowel. She had 80 centimetres of small bowel resected. She had plenty of small bowel left. And a primary anastomosis. There'd been discussion about stoma. She'd said if it's absolutely necessary, she would accept it, but she would prefer not, given the choice. Thank you very much. And post-op, she extubated in reasonable shape, and so was transferred in fairly quick fashion from recovery around to HDU. When she arrived, she was on noradrenaline at 5 mils an hour, and she was admitted and kept a close eye on overnight. She was visited quite a few times by our resident on HDU, had several small fluid boluses prescribed based on clinical assessment and urine output. By the next day, I saw her on the ward round and noradrenaline was off. Blood results showed that her acute kidney injury was resolving. She was mildly confused, although intermittent and not very significant. I remember on the ward round, I'd asked her if she'd had the chance to speak to any of her family, and she said she'd spoken to her husband. I looked a bit perplexed because no one had told me that her husband was still alive. I thought it was unlikely. And when she saw my perplexed expression, she said, "Oh, no, I mean my son." She said, "I think I'm a bit doolally." So she was a sweet old thing who completely won over the hearts of all the nurses. Anyway, she made good progress. We got her out of bed over the course of the day. She was starting to take fluids. Things looking good, so we got her discharged to the ward in the evening. She remained intermittently confused for a few days, but then that just gradually resolved and she returned to a baseline level of cognitive function, which was essentially bright as a button and able to do the crossword. She was seen by the older person's medicine team on day 5 of her hospital stay. And then she had ongoing input from physios, occupational therapists, and the hospital interdisciplinary discharge team was involved relatively early on. And she was discharged home on day 22 with a new care package in place. and she remains alive and at home when I checked on our electronic patient record last night. So I think that raises a few questions, doesn't it? Historically, you'd think really we're admitting 96-year-olds to intensive care. Is that right? Is that a good use of resource? Comes back to a question of what is the value added. We did very little in terms of organ support for that lady. She was on a little bit of vasopressor, which she probably needed, but it came off relatively quickly. What she had was close attention from being nursed at a 1-to-2 ratio by an HDU nurse, and having a resident doctor who only had 8 to 10 patients on the HDU to look after overnight, getting close attention to detail. She was seen by the physio in the morning. She was got out of bed, attention to detail in terms of what was on the drug chart. None of these things are huge, and they're all potentially deliverable on a ward, but we just have the resource and the capacity to do it better. And I would argue that in patients like this, the ones I would describe that patient as physiologically fragile. So not scoring high in terms of news, not in established organ failure, but needing careful handling because she's fragile. We've put her through an operation. We've given her a chance at surviving. Let's now do the basic things right. And that is something that within our organisation we can do best in an HDU environment. So I would argue it was a good use of resource, even though we maybe didn't do a huge amount. Maybe we just nudged her in the right direction. Counter arguments to that: what about the cost? We know critical care is expensive. People quote £1,800 a day for an intensive care bed. Bear in mind that's not the marginal cost. If you've got a bed that's empty, then the marginal cost of putting a patient in it is trivial, actually, given that those facilities are already staffed and equipped. What if you have a limited resource? It's then more difficult, isn't it? With elective cases, you can cancel them and bring them back when you've got capacity. If you don't have capacity, then you have to begin to make choices. And then it comes down to the questions of equity of access. Are there alternative models of care? The reason that I'm suggesting for patients like this that critical care works well is that we're able to provide a level of multidisciplinary team resource that isn't deliverable on a ward. But if you have environments that can provide enhanced post-op care outside of a critical care environment, then they would likely achieve the same ends and possibly in a more efficient way. And they would be tied in with dedicated pathways of care. And again, the models for this might be some of the hip fracture trauma care that we see with fragility fracture wards and fragility fracture teams that are able to provide pathways of care for fragile but not necessarily significantly physiologically disturbed patients. So in summary, I guess my argument in relation to the role for critical care in relation to this group is about equitable access when we think that would add value. And I think there are many situations within the NELA group in particular where patients in whom historically we may have felt these patients are not ones that are deserving of or would need an intensive care bed. Actually, we may be able to add value and there may be a role for them. The question of do we add value isn't an absolute. It's not defined by a set of physiological parameters. It depends on what the ward level resources are that you have in your organisation, what the MDT resource is for this particular patient group. Do you have the presence of an enhanced care area? Do you have the critical care capacity? In relation to that, and this is touched on in the 2023 NELA report that Dave referred to earlier, I don't think it's sufficient simply to say we don't have critical care capacity. If your service, your organisation doesn't have critical care capacity for these patients, then the answer isn't to discriminate against these patients. The answer is to address the deficiency in critical care capacity. And that's something that I've felt strongly about, that we as critical care senior clinicians have a long-term responsibility for making sure that we have the resources we need to look after the patients that are deserving of our care. Thanks very much.
Thank you, Ian, for that talk. It's really interesting to hear from your side of things how sort of NEAIR has progressed and what the benefit and the role of critical care is for those patients. So thank you very much. We're going to bring up the results of the poll that we did just now to have a look at who's been joining in. So that should be available on your screen there. So that's really encouraging to see that we've got a real mix of core and higher trainees, associate specialists, doctors, and a lot of consultants joining us, and even a foundation trainee. So that's lovely to see. Thank you so much for joining me with that.
Okay, so our next speaker is Dr. Francis Collin, who will be talking about his role as the lead of his Trust's surgical liaison team from an elderly care perspective, whilst giving some examples of their local quality improvement work driven by data from emergency laparotomy patients. So Francis graduated from the University of Bristol in 2005, trained in the Southwest, then London and New Zealand, and finally Newcastle. He completed a Master's in Medical Education at Cardiff University in 2015, undertaking research into the transition from registrar to consultant roles. He's been a consultant geriatrician at Northumbria Healthcare Trust since 2015, working in general and ortho geries, and has been the head of elderly medicine department for the last 4 years. He's previously spoken at the National Geriatrics for Juniors Conference 3 times. In 2019, he established a new surgical liaison service and joined the Trust's NELA QI group. When not working or spending time with his wife and son, he plays ultimate frisbee and grows vegetables in the allotment. Hi, Francis, we can see you fine. We can see your slides, so over to you.
Thanks very much, and thank you for the invitation to talk today. I've been really interested so far to hear other people's perspectives, and I guess maybe some of you will be interested to hear my perspective as a geriatrician in looking after this group of people. So I'm going to talk a bit about how we as geriatricians approach older people, something about how older people deal with surgery, and then touch on some things about how this can influence our clinical practice and also our service development. And I guess fundamentally, the thing that's been most striking so far is just understanding that the emergency laparotomy or having this this thing happen is a terrible event in people's lives, and particularly for frail older people, it's often a catastrophic moment. And I think trying to hold on to that as I talk is probably useful, because that's certainly the way we in geriatrics approach events in frail older people's lives. So just starting with some fundamentals, frailty is the obvious buzzword, and you'll all be aware that it's increasingly common, that there's an aging demographic, and there's, as was mentioned earlier, there's an association with increased mortality and length of stay, and big and important work such as the ELF group and a lot of the NELA data that Dave was talking about earlier obviously highlights that. It's not a surprise in any way, because fundamentally what frailty is just a reduced ability to recover after insults or to deal with stresses. And what's important from my perspective is that there's lots of different ways that you need to be resilient after stresses, and it's not just the physical. And I guess I'll touch on some of these things as we go along. This is a useful visual aid memoir. The person A is the kind of classical historical person who's ill, so they're doing fine, they're going to work, and then they get this insult, maybe they break their ankle or something. They're a bit less mobile, but they get their elbow crutches and they get going, and they're back to work within a few weeks. No problems there. Patient C is maybe what's thought of often as a frail older person, so they're more independent. They're more dependent to begin with. They have their insult, and because they're because they're frail, they don't have the ability to maintain their independence after that insult for a while. So they have some help and they get better, but they end up a bit more dependent than they were before. Person B is the person that's most worrying, and very often we see in hospital geriatrics, which is somebody who's had an insult. They're kind of getting a bit better, but they never quite escape that level of dependency before they get their next insult, because they're pretty vulnerable. So this idea of frailty is not just that they're at risk of losing their independence from one insult, but also that they're at high risk of further insults as they go along. And that, I suppose, in this context is about, they have their emergency surgery and then maybe they get a complication down the line. You'll certainly have seen this in your hospitals, and it's something that's nationally recommended as something that all old people coming into hospital should be assessed by. In essence, it's a disability scale for older people, but it is validated in describing frailty. And just to say that the obvious, really, there's good data to show that if you're more frail, then you are more likely to die and more likely to stay longer in hospital, and that's across medical and surgical problems. So there are other things that are useful. We've talked about some geriatrics literature stuff there, but there's actually some fairly useful, well-known stuff that describes the same sort of situation. And maybe this is becoming a bit more historical, but these are things you might notice. And when I hear those things, I'm thinking about frailty, I'm thinking about risk of delirium and institutionalization. So it's important, I think, because once we've identified that someone is living with frailty, we should also acknowledge that they're at higher risk of lots of those frailty syndromes, falls, delirium, becoming more dependent, and at risk of going into institutional care. So it really gives us an opportunity to improve our conversations and our goals, and also to make better decisions and better plans with people. So I'll try and touch on what it is we actually do in geriatrics, and it's in these 4 areas that I think my surgical work, I spend most of my time. So the first one is a structured multi-domain assessment and intervention. So in elderly medicine, we use the comprehensive geriatric assessment, which is a multimodal, multidisciplinary assessment, which is iterative and developing plans to meet people's overarching goals. In our hospital, one of my colleagues, Dr. Clark, does the vast majority of this in the surgical ward and the ITU, and I kind of pick up some of the pieces later on. So this is, as I said, comprehensive geriatric assessment. There is good data to support its use, in that it does reduce institutionalization and death at 6 months compared with usual hospital care. And just to be clear, those multi-domain assessments include the physical health stuff, but also the mental health, the functional abilities, what support networks they have, and the environment they're living in. And it's absolutely interdisciplinary working, which I'll get more into. So we do a structured multi-domain assessment, and then we really try to contextualize what's happened to them within what they are, who they are. So their overarching life goals and the stage of their life are really crucial in setting the direction in terms of what goals might be realistic, what goals might be important to them, and also what we might do if things go particularly badly. And there's some big movements in medicine around realistic medicine and shared decision making, which are fundamentally related to this. So it can be useful to have a look at those if you want to see more. There's an interesting study that I wanted to just raise a couple of years ago now, and it kind of chimes with what Helen was saying earlier on about best and worst case scenarios. This was a study about can palliative care consultants training surgical consultants improve their communication skills around complex decisions. And it turns out they can. But the more important thing, I think, is that this idea of what's best case and what's worst case scenarios for people are very, so this is an American study, and actually in their writing, they think of best case being survival and worst case being death. But I think it was helpfully highlighted before that a long protracted hospital stay, which is dreadful, leading to marked cognitive impairment and dependency, might be someone's worst case scenario. They'd much prefer to die quickly and comfortably than they would to have that really bad thing happen to them. But also there's something in here which is really important, which is what's the most likely thing to happen. So what's the journey likely to be like in heading towards that thing? It's unusual with for a lot of people that it goes absolutely swimmingly all the way. It's probably more common that there are bumps in the road and things happen. And I think there's something in there about us being honest with people and giving people the opportunity to express either themselves or via their advocates what it is they really want. There's something else in here, which is another study coming out of the Elke group, which I think was really interesting about what is important in terms of consent. And when people were asked what was they discussed was that they wanted to know about the realistic outcomes, not just about death. So how is it likely to happen, and will I be independent at the end? Will I get home? Will I be able to look after myself? And they were very worried about the burden on others and the relationships with others, not about being isolated individuals. And I think we've learned internally in our quality improvement work that through our multidisciplinary team M&Ms that these things are not always highlighted. They're not always discussed in consent processes, and people actually don't always get the opportunity to voice those things early enough, maybe. The next part is about psychological and practical support. And I think the fundamental thing here is just to highlight how strikingly strange the environment and situation is for frail older people. Going into the emergency department, they may have never been there before. It's really busy, it's really noisy, it's light, and if you think the emergency department's bad, what about going into an operating theatre? That's really weird for a normal person. I appreciate very few of you people are normal people in that regard. Going to the intensive care unit is also it's perplexing for me. So I'm not surprised at all that it's hard for them. And I think that their experience, their lived experience of this trauma is very frightening. It's very destabilizing. They often lose a lot about their sense of self. And so when I'm talking with people, they're saying things like, I thought I would die. But they're quite open about that, and they're very thankful for the support they got. They often describe confusion and marked hallucinations and how frightened they were and how ashamed they are of themselves and what they did, how they behaved. And sometimes some of this language about not engaging and not eating and not trying, or indeed not being independent with stoma, is in some ways related to that psychological distress that they've suffered. And we've been working with our health psychology team on this particular area, and we're inviting a lay member into our NELA group, particularly on these areas as well. We've also been working on an emergency bowel surgery information leaflet. I've been working on it for a little while now, but it's a lot about helping people to understand what's happening to them and what's likely to happen. The next part is just to say that we generally set direction and lead and develop teams. This is to say that in Dave's data about a 50% mortality reduction when they've seen a geriatrician, it's really, as much as I'd like to say that it was all about me and how wonderful I am, actually what we're doing is looking at team working and ward processes focused on the person, which is a different mode, and I'll try and explain that. So I've got a couple of examples here about MDT working that we've developed and some QI work that might help. The first thing is just to say, when I started in this area, I was noticing the dramatic difference in mortality. We were getting a lot of referrals to the elderly medicine team, and they all seemed to say the same thing, which was this person needs to go somewhere else. When we did get involved, it didn't seem to impact on the journey particularly in the way that it might on our own wards. But I did see significant interest from the surgical department, but also some of the clinicians about our input on a broader sense. We managed to work I worked with one of the surgical consultants. We were on a course together, and we got talking over the dinner and decided we were going to do this as a project to get some money and get going. And really crucially, we got some clinical time, but also some QI time in that job planned funding from the surgical unit. And one of my colleagues, Dr. Clark, I mentioned before, she does the lion's share of the work. She does 2 PAs into the acute side of the service, and I do one morning a week into the more subacute side, and we both work into the QI area. And using that, we have about 250 people a year having emergency laparotomy in our service. About half of those are over 65, and we see about 85% of for a lot of people within that. When I started working on the surgical ward, what I noticed were there were loads of assessments by the nursing team. The consultants were doing ward rounds every day, and they stayed for a few days at a time, and they focused primarily on the surgical issues. The ward was clearly set up for people to stay a short period of time, but when people did pass over into the next week or the week after that, there was a real lack of focus on the direction of care and really what that length meant to that person. So after a bit of trial and error, we instigated a weekly MDT meeting. We did some systematic discussion of that systematic multi-domainal approach that we talked about before. We had an open forum for sharing and challenge, and sometimes that was about whether we should be doing anything or stopping or whatever. And we agreed an overall direction, so we didn't get to the point, 2 weeks in, that the surgeon suddenly said, drip down home today, and nobody else had done anything, and the family didn't know, and all that sort of thing. And we built into that a lot about patient and family concerns and psychological well-being. A crucial function of all of this is about flattening the hierarchy of the team. The people who were looking after these frail older people on the wards were the nurses, the nurse practitioners, the junior staff, and the therapists. The surgeons were not the primary caregiver, and they may have been an important decision-making role, but they weren't necessarily the ones who would hear best from the patient and family what they wanted. There were lots of questions about escalation plans and whether we should be palliating or not. People worried about sending people home if they were confused, and there was a lack of positive risk-taking in that area. And we did a lot to raise the profile of cognitive impairment and frailty. But the crucial thing was that we didn't look to take over the care. The surgeons didn't want it, and we didn't want it, but actually to support that team to function more effectively for this group they were looking after. And helping them to tackle some of those difficult ethico-legal situations has been a really enjoyable area. Some clinicians will take to it more readily than others. I just wanted to touch on this other way that we might influence second direction, which is to use the tab 8 and our delirium work in the trust. So when I started working into this area, I got access to the NEAIR database, and I found amongst all these boxes that there was one for me to tick, and it was this one, 7.3, yes or no, or unknown. And I think that was helpful to gather some kind of information, but it didn't really help us to do any QI work within the elderly medicine department. A lot of the focus had been on the early stage A&E, ITU, operation, all that, and less about some of the later work. So what Nikki Clark did fantastically well with Liz Hall, who runs our NELA setup, was get this tab 8 set up, which is an area where we could record some of the stuff that we were finding. We looked at the literature and found some common complications that we ought to keep an eye on, and some other things about things we were doing, like checking their medicines. So this is a sort of data that was originally available even before we did the tab 8, although we separated it into under 65 and over 65. But then we also get this extra monthly data, which I think has been really useful. So one of the things to highlight just on here is the graph second from the left, and the so top middle, which is perioperative delirium, which is just to say it's really, really common, phenomenally common, and the surgeons didn't know. And the anaesthetists and ITU team didn't know. Nobody really knew, but it's phenomenally common. More than half the people are getting some kind of delirium when we assess them properly. So how does this help us? Well, it helps in a lot of ways. It adds a lot of weight to the conversation. Should it be part of the consent process, which is what people want, because they want to know what's going to happen to them. There's some which is about specific things we can do. So we worked with our broader team, nursing colleagues at the Trust, about getting this 4AT delirium assessment put in pre-op and post-op. We had a lot of conversation about delirium and dementia training. We're including it in the GP letters so that people get appropriate follow-up. Other things we've done, well, the surgeons ran off and got very interested in this idea of using rectus sheath catheters to try and reduce opioid use, because we were highlighting that the pain management down the line was quite different for different people. The anaesthetists have got really excited about anticholinergic burden for intraoperative stuff, but also more recently looking at even in the elective sphere, what can we do to reduce anticholinergic burden in the preoperative phase. We've had conversations about anaesthetic techniques, as we started to have a bit earlier on today, BIS monitoring in theatre and now also in ITU, as I understand it. Not that I understand it particularly well. We've had education sessions. We've got lots of stuff around environmental and non-pharmacological strategies. But really, it's just this idea that across the whole spectrum of their care in all these different places, there's lots of things that might impact. And there's a kind of trust-wide things that we ought to work on, and also local things within our gift, within our wards that we can do. And I think the way that we've succeeded in any of these things has really been working with partners. We've engaged our trust nursing hierarchy a great deal around frailty scoring, around delirium assessments, not just for surgery, but also across the whole set of people coming to the hospital. We've got a nursing program, a training program, actually, allied health professionals and doctors can go on at the enhanced care of older people training. And we've had some fantastic work from local champions, but the surgical business unit funding the time, they've employed a NELA nurse specialist, and increased physiotherapy and pharmacy input on the surgical wards just for these people. So I guess my major focus has been to say that it's a multidisciplinary approach, that there's a big focus on realistic medicine, and there's lots of ways to work on improving services for older people through using data. And I'm more than happy for you to contact me if you had any questions.
Thank you, Francis. That was an excellent talk and highlights some of the benefits of using NELA data locally to drive and hopefully drive improvement. I think we're all aware that frailty in perioperative care is an area that will only continue to expand, and some of the examples you've given really highlight the importance of that collaborative working nicely. We've got plenty of questions coming in for our speakers, so thank you for helping to make this an interactive meeting. Please do keep putting questions into the Q&A box. Our next and final speaker of the morning is Dr. Saunders once again. Having heard from various specialties that feed into the care of emergency laparotomy patients, and having seen some examples of how data and QI projects can improve services for this patient group, Dave is going to talk about how best we can use NELA data locally. Dave, I can see your slides. I can't see you yet. We just get Dave up on the screen. There you go. We can see you now. All right, over to you, Dave.
Okay, I think I'm on. Can you hear me all right? Brilliant. This is actually a much shorter set of slides, non-clinical this time. Before we get some more discussions, thanks from me, Francis, as well, for those excellent slides. This set, though, this is about getting more from your local NELA data. And just think about why you might want to do this. Get in touch with me after today if I can help in any way with any of this. This is quite a superficial, fast overview of what the NELA web platform can do for you. Thank you. Right, so do you know what that is? Apparently that's the first picture of a black hole. So the purpose of this slide is to make the distinction between quality assurance and quality improvement. Traditional systems of data collection, data registries in the NHS, like NELA, but traditionally this involves a lot of data going in, being collected locally, and it disappears into a black hole. And 2 years later, after consideration and analysis and a lot of report writing, a weighty tome is published. But the problem with that mechanism is that the data, by the time it's published, it's already out of date. And right from the start, NELA was commissioned to facilitate and encourage local and more contemporaneous quality improvement, as well as systems of quality assurance. So I'm going to show you, as I say, in quite a superficial manner, I'm going to give you 4 worked examples of how you can use the resources built into the NELA platform to help with your local quality improvement. Some quarterly hospital level reports that are provided by NELA, dashboard functions that are built into the web platform. I'm going to highlight one that I think is the best of them all, called EUMAs, exponentially weighted moving averages, around mortality monitoring. And for those that are more interested in more precise and granular data analysis, how to get the data out of the platform. Okay, so I've got a series of pictures really about how this works. So if you would like to look at quarterly reports for your hospital, there's the landing page for NELA up on the top blue banner bar, reports. Click on that. There's a drop-down menu at the top of there is hospital reports. Click on that. That opens up another page with some timetables for when the reporting is done and going to be done in the future. Down at the bottom, select the hospital you're interested in. And for this set of reports, you can look at data for any of the hospitals within NELA, not just your own. So you can get all the data from regional comparators. Click on then the type of report you would like. So since 2018, when best practice tariff came, these quarterly reports are aligned with financial quarters. And the most recent report that NELA has published is for Q1 2022. So that's April to June 2022. And there'll be the next quarterly report will be available very soon. Click on that and it just produces some nice PDFs with succinct data summaries for you to look at. On the left there's a little mini run chart that shows performance against time for each of these key process measures, case ascertainment, CT reporting by an in-house radiologist. They're all RAG rated, red, amber or green. There's the proportion of your patients that meet those targets compared to national averages and regional averages. The AHSN is used as a surrogate for the regions. Now, from April or not long after that, we're hoping that this will move to monthly reporting because that's a condition of the next contract. And I also hope that these reports will be pushed out to units rather than relying on someone having to log in and go looking for them. Built-in dashboard functions, there's a couple I'm going to highlight. There's a poster generator, which is really good for highlighting your QI work within your hospital, and also some built-in reporting functions. Let's look at the poster generator. So again, back to the blue banner bar, this time at the top, click on poster, set the date range that you'd like the software to crunch some numbers for. You can put your name in and your contact number if you'd like, and there's a free text box to say what you're currently working on, which quality improvement project. Click go, and it produces this nice looking summary. I'm afraid that the fields are fixed. You can't choose which fields are going to be reported upon, but the idea is it's a very easy tool just to produce this poster, as I say, put it up on the coffee room wall within the theatre suite. Okay, dashboard reporting, similar sort of mechanism. There's the home landing page. Again, click on reports, drop down menu. On the left this time, I showed you hospital reports we looked at a moment ago, but there's a few other specific report modalities that are available. This time I've clicked on documentation of mortality risk preoperatively. I've given you a worked example from our own hospital there over 8 years from 2013 to August 21. The black line shows the local hospital performance and the grey bars show confidence intervals, effectively plus or minus 2 standard deviations. And there's a number of other dashboard reports that are available. I'm going to show you in particular, I really want to draw this one to your attention because I think it's excellent. So EUMAs, exponentially weighted moving averages. I think this is a statistics mechanism taken from industry in sort of manufacturing processes. And the idea with this statistical tests is that it's meant to bring to the attention of the operators an early warning that there might be a problem with processes of well, manufacturing processes, or in our example, clinical processes. So it's a real-time monitoring system. And the idea is this will give local teams the chance to detect potential problems amongst their emergency laparotomy care sooner and correct those before they become more significant. If a hospital does breach -2 standard deviations, so it goes into potentially outlier status that in the traditional mechanism would wait 2 years until there's a report published and then that hospital will be named as an outlier. There is now an automated email system that will push this warning out to local clinical leads for NELA, and they can look into what's going on. So click on reports, UMA, and there's a worked example on the right, again, from our own data, from a similar date range to what I chose before, over 2 years, September 19 to August 21. So the black line is observed mortality within the unit. The blue line is predicted mortality, weighted by sickness severity as per the NELA risk algorithm. The dotted grey line is the current national median mortality. And the big grey bars up and down, those are the confidence intervals. So using this example, you can see for a while, we were very proud that a smaller number of our patients than predicted were dying, but then spring 2021, something seemed to happen. And using this monitoring system, we were able to pick that up. I met with the local surgical lead. We looked back over 6 months of cases, all the patients who died, and just looked at the standards of care and did a more forensic examination of what had gone on amongst those patients. And I'm pleased to say that there wasn't some systematic failing within the hospital. It was just unlucky. A string of highly complicated comorbid patients underwent emergency abdominal surgery in quick succession, and they had bad outcomes. But there was a common theme. Ischemia, bowel ischemia, was commonly represented amongst this group. So there was some learning there about just how high a risk that patient group is. So that's UMAs. Finally, the raw data export. So for this is for those of you that like Excel, pivot tables, slice and dice, filtration. The entirety of your NELA data set is available for export and analysis. So for this one, blue banner bar, click on clinical, click on export. There's a number of different export types. Oh, you need to be logged in to the NELA platform for this, by the way. There's a number of different exports that are available. I would suggest just stick with that top one, NELA Performer, with shortened field names. Put a date range in. Now down at the bottom, there's then some stuff about encryption. There's a little shortcut to avoid that. So right at the very bottom, a tick box. If you tick that, it takes away the requirement to download an encrypted file. Up to you and your local information governance rules, but in my experience, exporting the encrypted file makes it impossible to read without installing some special software that can't usually be done on NHS computers. So tick the box. That will give you a non-encrypted download. That's what it looks like after you've ticked the box. And then there's an enormous spreadsheet of data. So all the field headings for all 7 of the NELA tabs, they run across the top, as you might expect. Some of them are, it's easier to understand what those field names mean than others. So you need a key. Also, the content of the fields can be difficult to interpret. Some it's easy when it's as 0 or 1, but others are more complex coding. So you need a key. That's available through support, clinical audit export key, and that then exports a separate Excel spreadsheet that shows you, that gives you a key to what the main spreadsheet shows. Okay, so that's all I was going to talk about for data analysis, dashboard reporting. UMAs, give them a go. I would definitely recommend them. Just as a final comment, so within the Northeast, for the last few years, we've had a collaborative, and I'm pleased to say, representation from all the hospitals in the Northeast: surgical, anaesthetic, critical care, some elderly care, some emergency medicine, radiology. So it's been an excellent initiative. The funding for that project has finished, but as part of the runoff from that project, it's been suggested that we set up a platform within the NHS Futures website. And my intention is to start making available links to different emergency laparotomy relevant publications, NELA reports, standards documents. And with your agreement and the agreement of the A-Line team, after this event, you'll be sent an invitation if you would like to sign up to that NHS Futures platform. There are some other NELA QI resources available through the NELA website. Follow that QR code. It will take you to some videos and recordings of previous NELA webinars around quality improvement. Thank you very much.
Thanks, Dave, for sharing your advice on how to use that impressive data set. I think the vast majority of us will have been involved in putting data onto the NELA database, and I'm sure that you've inspired a lot of new quality improvement projects starting as a result of today that can just help to improve services for emergency laparotomy patients. So we're going to end the morning with another panel discussion. So I'd like to invite all of our speakers back to join us. Again, we've been collating your questions throughout the morning, so please continue to write them in the Q&A box. And we're going to open up discussion to the floor and try and get through as many of your questions as we can. So the first question that's come in, Dr. Clement, is for you. There's a member that would like to know specifically what anaesthetic that the patient you presented had, the case that you presented.
Yeah, she had a general anaesthetic. She didn't have any neuraxial anesthesia, analgesia. I can't remember if she had rectus sheath catheters in. I think she did for analgesia, but yes, GA.
Okay, great. And there's another question specifically for you, Dr. Clement, about the role of a PACU and whether you feel that PACU would be a better place to provide that enhanced care for those patients rather than on HDU to help with sort of competition for critical care beds when they can be scarce.
Yeah, it's an interesting question, this, and there are factors pulling in both directions. PACUs absolutely have a role. I have to say, I personal opinion, envisage the role of a PACU more for protocolized care of major elective surgical cases, rather than managing emergencies, which tend to be a much more disparate group, harder to protocolize. The other issue about the general trend in terms of critical care provision is of centralizing critical care services within big centres, bringing all of the critically ill patients into a single integrated critical care area, moving away from this model that you know historically we've had in the NHS of rather disparate kind of higher care provision with higher care areas and wards, surgical HDUs, medical HDUs, and then a separate intensive care unit. The trend in the bigger centres, and you think, Queen Elizabeth Hospital in Birmingham is the kind of example of that, is bringing together disparate higher level care areas into a single big integrated critical care area where the resource is concentrated. And a PACU always, in some ways, it feels like the sort of a sticking plaster solution for inadequate provision of that core critical care resource. I think as a temporary solution in resource limited areas, putting these kind of patients in a PACU may well be better than it will address many of the deficiencies that would be faced if they were sent straight back to the ward. But if I was designing an optimum pathway and an optimum service, I don't think I would start with a PACU for this group.
Okay, yeah, makes sense. And I suppose looking at developing the unit that you're talking about at the RVI that we discussed earlier is that kind of model of having everything in one place rather than those disparate areas. So it makes sense. Thank you for that. We've had a question come in that's asking about patients who come in with upper GI bleeding or GI bleeding who are initially managed by endoscopists and maybe with sedation, but then end up needing further intervention, maybe general anaesthesia, and potentially progressing to surgery. Is there a role for NELA for those patients, Dave? I wonder if you know anything or have any examples of that?
This almost sounds like someone with a slight axe to grind about something, and I could also think of some axes I might have to grind. So the short answer is no. NELA is not intending to expand its repertoire. When I got this executive role a year ago, I was really keen on the idea of sharing this fantastic project. Let's spread it out a little bit more widely. I asked, why are gynecology patients that need to return to theatre not included in similar systems of auditing standards of care? Urology patients, vascular, hepatobiliary, why are they all excluded? So this would be another group. This is a group of medical patients, isn't it? But the answer is, well, it's the sort of commissioning is really, really tightly controlled. I think some of it is related to the legal basis for collecting data, because data is collected about patients without their specific permission. Well, without any permission. It's just collected about them. And that's quite an unusual arrangement in 2023. That is just not really the done thing for most systems of data capture. NELA has got specific exemption for patient consent, but the framework that sits around that is really, really tightly controlled. So every patient group that you might consider adding into those systems, somebody has to really closely consider it and ask the question, is this a valid thing to do? And then someone else would need to come up with the money to add in, to sort of expand the ability of NELA to do that. And it just stops at that point because someone says, no, we specifically don't want you to do that. I was quite interested in adding in the trauma laparotomy patient group, because I think the process measures that you would see there, in some ways it's the same sort of operation, albeit a different patient group, different pathology, but a similar sort of set of operations. But I think we would find that the processes around that are completely different. And that would open up all sorts of discussions then about why those processes are so different. But I'm afraid, yes, NELA won't be expanding its repertoire. It did in a very small way from last year. Complications after gynae oncology surgery, where a general surgeon has been asked to sort out the complication in the take back to theatre, those patients are now included. But it's a very niche group, and there was some political stuff behind the scenes about a perception that patient group had a high level of serious complications. And then it was always the general surgeons that were asked to sort out those problems. So people want some high level politics for getting that group included into NELA.
And Francis, just a question for you as well. You have talked, obviously, in your talk about seeing these patients post-operatively, and I know that one of the NELA targets is to see them pre-operatively. When that's out of hours, is there any scope or any way that we can improve that? What are your thoughts about being able to see those patients pre-op? Is there benefit in it, and what currently happens?
Yeah, it's a difficult area actually. There's, a bit of a talk earlier about the kind of the time taken between being seen and ending up in theatre, and that I think clinicians often think that time is quite short in the way they experience it, but patients can often wait quite a number of hours into the next day or whatever, and so there is time to do things. Interestingly, as I was alluding to before, that kind of the situation they're in is very strange, and it's actually quite different to a lot of the times we might be having conversations with people in geriatrics in general, when things are a little bit clearer. There's a lot on the table, and there's a lot of actors, and there's a lot of activity, and it's quite bewildering for everyone. And so maybe that's a good time to be in there and talking about some of the more realistic options. I think there's always going to be a trade-off in if you provide that sort of access, then it's going to take an awful lot of time. You'll see some of those people, but you won't be able to deliver some other part of the journey maybe. So while it might be really valuable, actually what we've discovered is that through working with our anaesthetists and intensive care and surgical colleagues very closely, some of those conversations are more in line with realistic medicine than they maybe were before. Some of them are more attuned to consenting for delirium and institutionalization. And so I think there's a balance to be struck between how much time you put into the different parts of the journey, how much of an impact you can have. And I think there is a danger that if you overemphasize that very, very first bit, you lose much more about that broader sense of helping the person come to terms with what's happened to them and helping them get back to life. Because you have to remember, this is just a small, although potentially catastrophic moment in their life, and that getting back to normal life or some kind of life is actually the idea. So if we focus everything on that pinpoint moment, it's very costly resource-wise, and maybe not as useful as some of the other areas.
No, interesting thought there about sort of that use. I think we sometimes focus on that beforehand, but actually for you, a lot more of the focus is on actually what happens after that. Coming back to that then, there was a question that was posed specifically for Dr. Clement, but actually I think is very relevant to all of you, which is how do we make decisions about the ceiling of care and the ceiling of level 2, level 3 care for these frail, complex patients perioperatively? Who's best placed to make those decisions, and who should be involved in those discussions?
Shall I start?
Yeah.
So clearly, critical care have an important role to play in this, because this is our bread and butter. This is what we do, with the whole gamut of emergency patients that we admit to intensive care, not just the NELA group. But that discussion needs to be informed by input from the other medical services involved, and clearly, close discussions with the surgeons, with the radiologists, what the extent of the pathology. Ultimately, this has to be a discussion informed by the patient's wishes, though, doesn't it? And that's often challenging. The patient may or may not have capacity. There's often a window of opportunity, like in the case I presented, an unwell 96-year-old, but she had capacity and was able to participate in the discussions pre-op in a way that we suspected, she may not be able to post-op. So I think particularly in the NELA group, there may be a window of opportunity to get that discussion in before they go to theatre, and you need to do that. Often, in the very elderly, that'll be supported by relatives. Cautious with relatives. I mean, they're not independent, clearly, and you always have to take into account the perspective that they're coming from, and try and distinguish their own perspective from that of, are they speaking on behalf of themselves or on behalf of the patient, and that often comes down to judgment. But critical care have an important role to play there, and that's why I think it's important to engage with critical care before you've actually shoved the propofol in. Rather than, always better to find out then, rather than 2 hours into the laparotomy as it evolves and goes downhill.
Yeah, thanks. I think all of what Ian said there is really crucial. I think that from a geriatrics perspective, I guess the way we think about escalation of treatment is often far broader, so more maybe around who the person has been in their life, where they are in their life journey, what's happened to them in the last year or two, how the next year or two might pan out, what are their values, and I think that sort of conversation is obviously, it takes longer, it can be complicated, but it's just a different sort of approach, and often when as things develop through their time in the hospital, that can be more useful because you get a better relationship, you have more time, you hear more, the way they understand what's happened to them can be conceptualized within all the other stuff that's ever happened to them, and it becomes clear that whilst we tried to save them in this current situation with good reason, actually at this time we've done enough trying, and it's time to change. So I think it's just we have a different approach, but we would always work closely with our critical care colleagues, because obviously their perspective is going to be different. So that it's one of the most fantastic things about joining this service is the kind of understanding that people's perspectives are so strikingly different, and yet we're coming at it all from a good intention, and that's just really enjoyable clinically, but also in the QI stuff to see that.
Yeah, wonderful. And leading on from that, I suppose someone has asked specifically, are there most important or commonest patient factors that you consider that have a significant impact on morbidity and mortality in the context of an emergency laparotomy? Are there specific factors? So they've asked, what are the most important or commonest factors that lead to morbidity and mortality? I suppose a difficult question to answer, Ian. I don't know if we come to you first.
Yeah, I mean, I hesitate to be too specific about a defined set of characteristics that will determine that. I just think it's more nuanced than that, isn't it? We know that frailty has an enormous impact on both mortality and morbidity in the aftermath of a big event like this. As Francis said earlier on, presenting with an acute abdomen and going through an emergency laparotomy is a huge event for particularly frail elderly patients. One thing to have to be mindful of is that this event may come at the end of a period of decline. I think careful inquiry will often be sold. I mean, certainly in intensive care, you're often aware that clinicians, in referring a patient to you, often feel under pressure to sell the patient. They kind of feel they're acting like the patient's advocate, and are very keen to tell me about how Mr. Bloggs, drives his car and goes and does his shopping and walks the dog. And actually, it turns out that's what Mr. Bloggs was doing 6 months ago, but has gone progressively downhill over the last 6 months, and we find ourselves in the position that we're in today in ED with an acute abdomen. So there aren't a set of specific factors, and indeed, even if they were, the solution will be different for different patients. What do they want out of this? What's a good outcome for them? Survival often isn't the best. Survival may not be a good outcome, and death, as Helen said earlier on, death may not be the worst outcome. So you have to be informed by a whole host of other factors. And again, it brings me back to the central point of my talk in terms of, if the question is, do we put this patient through a period of organ support and admission to critical care, then the question is, what is the value added? And for a very physiologically frail, very elderly patient, there may be significant value added in a couple of nights in HDU. For a much more resilient younger patient who we're going to do everything for anyway, from a critical care perspective, if resources are tight, there may not be much value added because they're going to do fine on a surgical ward anyway, even if their physiological disturbance is greater.
Yeah. Absolutely.
Can I come in on that? As I agree absolutely with what Ian's saying. I think that the things most overt for me are people who are frailer and people who have more in the way of cognitive impairment or social isolation, or all those kind of normal things that people struggle with. They're all at high risk of some bad things happening. And from our internal data, if 60 or 70% of these people are having an episode of delirium related to their emergency laparotomy, or the whole thing, then everyone's really high risk. In terms of morbidity, more than half of people are getting a delirium if you're frail and older, and I think that's one of the things talking within our team is when people start to understand that, then actually those things like, well, we should be doing pre-operative and post-operative cognitive assessments, we should be doing frailty scoring, because the conversation with the person and their family about what we're going to do must understand that this is the likelier outcome. that your journey ahead is likelier to be like this than it is to be like that. And so I wouldn't say that it was, you know, obviously if you have terrible kidneys or you have your liver's busted, they will have their impacts, but on the broadest sense, anyone who's older and frailer, and particularly if you're cognitively impaired, you're in there's a high chance of some problems. So we have to understand it, choose wisely, treat them well, all of those things.
Absolutely. Okay. Dave, I'm just going to come to you with a question. So we've had a question come in from one of our anaesthetic colleagues who said, sometimes as anaesthetists, we get asked by the surgical team whether or not we would be happy to anaesthetise a patient, with the feeling that perhaps there's an expectation we will decline because of comorbidity, etc. And the person who's written this question has just said that they don't feel comfortable making that decision purely on an anaesthetic ground, and don't want to perhaps take sole ownership for declining operative intervention. And where are your thoughts on that?
These are all good questions. There isn't a simple answer to that. I am a theatre anaesthetist, and I suppose I do come across these sort of questions. The question is should not be, can we anaesthetise this patient? Because of course the answer is yes, we can anaesthetise them. The correct question is, should we be embarking upon this journey? And I will initiate consideration of those sort of wider aspects of their care. So I'll start to touch upon the scale of surgery and the potential impact this will have upon the patient. But this isn't just absolutely not for me to make that decision in isolation. These difficult questions, that's where we need help from the entirety of the multidisciplinary team. So I need my intensive care colleagues, and if there is time, elderly care would be excellent. It's really interesting listening to Francis's talk and just reflecting upon that. There's almost a conflict between a lot of the stuff I've been talking about, which is this is very much a time-sensitive admission to hospital, and I need to bang, make some quick decisions, get a CT scan, get a diagnosis, decide whether we're going to do an operation. But that is in conflict really with the time that some of this takes to get all these different multidisciplinary views, including the family and their carers. It's quite difficult. But I think if there's a marginal decision, you should not be doing that on your own. I don't think that's right. Get a second opinion from another anaesthetist if necessary. But that should not all be lumped onto one anaesthetist, or it'll get a very simple answer. Yes, I can anaesthetise them. What's the next question? Sort of thing.
Yeah, absolutely. Dr. Clement, I don't know if you've got anything you would add there.
Yeah, I mean, I think Dave's hit the nail on the head. It's the wrong question to ask, isn't it? It's a bit like, have you got an intensive care bed? That if you've got an emergency patient, that's the wrong question. Whether I've got a bed or not has no bearing on the value or otherwise of admitting the patient to critical care. It's difficult, isn't it? And you have these decisions along the journey about how far do we go, what's the right course of action once a patient's had their operation. I mean, one of the things, again, just to reflect on some of the points Francis made as well, there's a lot of uncertainty. So we're presented on arrival with a comorbid patient with a potentially reversible problem, but attempting to reverse that problem with an operation and intensive care stay and all the rehab that follows may be too much for the patient. And we can offer an opinion based on what we think a likely course of action might be, but there's a lot of uncertainty attached to that. And certainly the more my career the longer my career in intensive care goes on, the more I lose confidence in my ability to prognosticate. And that's something that we see in intensive care. We gradually get more and more conservative, I think, as we get older. And then this comes back to, well, give me a sense of what is acceptable to this patient. We can take a risk with this intervention. It might go badly, it might go well, and I can offer you an indication of what I think is likeliest, but we just don't know. At least in intensive care, we have the option of changing tack. You know, we can embark on a period of organ support, and if things are going badly, we can say this isn't working and stop. It's more difficult for the anaesthetist and the surgeon at the outset. It's a binary decision, isn't it? Are we going to do an operation or are we not? And you know, that is a bigger call. And as Dave said, it's unfair for that to phrase it in the question, can you anaesthetize this patient? That's not right. Dave says you can always anaesthetize them, and you can almost always get them off the table, actually. The question is that the right thing to do? And that's a collective decision, informed by a sense of what is and isn't acceptable to the patient and their family.
Yeah, thank you. I think that probably clarifies. Yeah, go on.
Yes, just to say one other thought, because I don't know whether a question's come from a trainee or an associate specialist or a consultant. I would be very clear that if that question is being posed to a non-consultant anaesthetist, they absolutely must get an opinion from someone more senior who carries that can for the patient's care. It is absolutely unfair to put a trainee in that just for political reasons.
Yeah.
So I'd be very clear on that. You must refer that up through the chain.
Absolutely. Okay, that's really helpful. Thank you, Dave. So I'm just going to finish the discussion there with just a statement from the audience. So I've had a comment from the audience to say that they think it's very interesting that there's been two very similar cases presented from two different hospitals with very similar features, with sort of patients who are elderly with bowel ischemia that have been managed very, very differently, but have both had a positive outcome for that patient. So that's just something that's been highlighted from the audience this afternoon. So thank you all for an absolutely outstanding morning. I think we can all agree that our speakers have been superb, so thank you very much. The panel discussions have raised lots of very interesting points for debate and some very useful clinical points as well. I'd like to thank all of the speakers for joining us. We're going to have a break for lunch now, and we'll be back at 1:30 and look forward to seeing you for the afternoon programme. So thank you.
That's a good question from the audience.
Yes.
Or a good comment, a comment from the audience. I thought she was going to say, host.
Welcome back, and thanks for joining us for the North East Anaesthesia and Intensive Care Review meeting. My name is Elke Kothmann, and I'm a consultant anaesthetist at North Tees and Hartlepool hospitals, as well as being the college tutor. We have an afternoon packed with brilliant abstracts demonstrating all the exciting quality improvement work that is ongoing in the region, and also a little bit further afield. I'm co-presenting with Dr. Jeevan Subramanian, an SD5 trainee in anaesthetics in the North East Deanery.
The aim of NEAIR is to provide a platform for sharing ideas, best practice, and quality improvement work amongst anaesthetists. We are delighted to have so many of you registered for this event. We are aware that we're presenting a packed program this afternoon, but don't worry, we'll be pausing for a break at 3:30. At the end of each abstract section, we have an excellent keynote speaker hailing from the Northeast, both demonstrating their own capacity, how important it is to continue to do quality improvement throughout your careers, and how rewarding this can be.
The abstract presenters have each been given a total slot of 10 minutes, 7 minutes for presentation and 3 minutes for questions. If you wish to submit a question to the speaker, please use the Q&A box at the bottom of your screen, and we'll be able to ask it for you. At the end of each presentation, you'll be sent a poll to score the speaker out of 10, and the prizes will be announced at the end of the day. Gerry and Rupert are automatically winners, but you'll see why when you hear them talk. So without any further delays, we'll start the first abstract session.
Dr. Matt Bickerton recently finished working as a trust grade CT3 at Sunderland Royal Hospital Integrated Critical Care Unit, having departed acute medicine training in favor of a career in ICM and anesthesia. He is flying to Sierra Leone tomorrow to take up a global health fellowship before hoping to start anesthetics training in August. Matt, we can see you. You can bring up your slides. And it's over to you.
Brilliant. Thank you. Good afternoon. That introduction. My name is Matt. I'm presenting a case today that I hope is relevant to an emergency laparotomy and anaesthesia conference. So it's a case that took place in Sunderland last July, and it's specifically around tension pneumoperitonium secondary to a stercoral perforation. So the patient themselves was a 24-year-old chap. He had a background of learning difficulties and specifically autism spectrum disorder. And whilst he could read and write, his speech was limited to echolalia, making communication quite difficult. He also had a background of chronic constipation. He presented with a month's history of reduced bowel opening, and actually had presented to A&E 4 days earlier because of this and because of progressive abdominal distension. With no concerning features identified at that point, he was discharged home with an increase in his laxatives, but unfortunately then came back into hospital a few days later, having started vomiting and with a 24-hour history of pyrexia. His examination found a tensely distended abdomen, and his heart rate was markedly elevated, and he therefore had an erect chest X-ray, which looked like this. There were clearly some reasonably concerning features on his chest X-ray, and he therefore went for a CT abdomen and pelvis. The CT itself was generally very interesting, but I've chosen one specific slide, and I chose that slide for 2 reasons. So partly because it demonstrates the posterior displacement of his abdominal viscera, but also because it demonstrates how marked the fecal loading in his sigmoid colon was. So at this point, we'd clearly identified this gentleman needed emergency surgery, and he was brought through to the anaesthetic room. In the anaesthetic room, he looked dreadful. So he arrived on room air having not tolerated an oxygen mask and was saturating at 87%. We managed to improve that slightly with a nasal cannula, but he still had a really significant work of breathing. From a cardiovascular point of view, he was grey and clammy. He was tachycardic at 154 beats per minute in a sinus rhythm, and he was normotensive. His lactate was mildly elevated, but it was in really significant emotional distress, and only at this point had a 22 gauge cannula in place. It wasn't tolerating any attempts at getting anything larger, and clearly needed something something bigger in place. And so in terms of what we did next, we identified that he needed sedation in order to improve the vascular access that we had. And so we chose to give intravenous ketamine in 10 to 20 milligram aliquots. And when I say we, it was my consultant, Louise Roberts, and a senior registrar, Sarah Dawson, who were involved with the case. The ketamine worked very nicely. We got him into a state of calmness and managed to get a 16-gauge cannula in, through which we gave a litre of Hartmann's. Following that, we saw no improvement in his hemodynamics at all. And it was at that point that we were concerned about the possibility of tension pneumoperitonium. We spoke to the surgeons, and with their agreement, we attempted to decompress his pneumoperitonium by inserting a 14-gauge cannula through his abdominal wall, so 2 centimeters below his umbilicus. There was a hiss of air, similar to with a tension pneumothorax, and immediately saw improvement. So his heart rate fell to 120, and his breathing improved. Following that, he had an uncomplicated rapid sequence induction. We inserted arterial and central lines and moved him through to theatre, where he had a laparotomy. The findings during laparotomy were of megacolon and of megarectum. His cecum in the operation note was described as macerated, which sounds deeply unpleasant. And there was a contained perforation identified there. And so he went on to have a subtotal colectomy and an end ileostomy. He was transferred post-operatively to the intensive care unit, intubated and ventilated, and his recovery was quite rocky with several complications, but he was ultimately discharged home just a couple of weeks later. I thought there were 2 main learning points from this case. The first was around sedation in patients with learning disability. Because whilst there's fantastic guidance on anaesthesia in the elective setting for patients with learning disability, and there's a reference on my final slide about that, it is particularly challenging in the emergency setting without the ability to plan in advance. We preferred ketamine in this setting because of the risk of paradoxical dysphoria with midazolam, and that's something that's described again in the review article that's on the final slide. The other learning point I felt was around cannula decompression in tension pneumoperitonium. It's a procedure that's performed relatively rarely, given that tension pneumoperitonium is quite a rare finding. The risks of cannula decompression are similar to that of abdominal paracentesis, so primarily of puncture of abdominal viscera, but also bleeding, infection, pain. But the benefits were pretty clear, I think, in this case, and we all felt concerned that inducing anaesthesia without decompressing his abdomen could have been catastrophic. Thank you very much for listening, and I'm happy to take any questions.
Thank you, Matt, for that very interesting presentation. I've got 2 very quick questions, really. Do you know the long-term outcome for this patient?
So I had a look just recently on the system to see if he's got any recent any outpatient clinic letters. Unfortunately, he doesn't, but I think no news is probably good news. He was certainly discharged home in to the same level of care he was at before, and so I think we assume that he's doing all right.
And then just lastly, I've only ever seen this once before after an endoscopy for perf DU. How common is stercoral perforation causing this? Is it a common event?
So I think tension pneumoperitonium is rare. The most common causes of it are in endoscopy due to the pressures used and the risk of puncture, or in the intensive care unit if in a positive pressure ventilated patient, if a tension pneumothorax communicates with the abdomen. This is actually the first time, as far as we can see, that stercoral perforation has caused a tension pneumoperitonium from our review of the literature.
Thank you.
Thank you.
Thank you.
I think we're going to launch the poll now. Our next speaker is Dr. Sophie Ingham. Sophie's a CT4 ACCS anaesthetic trainee working in the Northeast. She'll be presenting a quality improvement project, which she completed alongside fellow anaesthetic trainees, Dr. Max Richardson and Dr. Dave Sweatman. So Sophie, we can see you. And I think we just need to see your slides.
Yeah, just share my slides. Thank you.
I think we just
see your
we
slides
can
now.
see your slides now. If you'd
Thank
like to start.
Yeah, thank you very much for the introduction. So, and good afternoon, everybody. So today I'm going to be presenting my quality improvement project on mean arterial pressure targets at Sunderland Integrated Critical Care Unit. So first, a bit of background as to why I think that this quality improvement project is important. So as you'll all be aware of having worked on intensive care, admissions to ITU for blood pressure support are really common, whether that's as the sole reason for admission to ITU or whether that's in conjunction with other methods of organ support, for example, invasive ventilation. There is some evidence that targeting specific mean arterial pressures in specific patient circumstances can lead to improved clinical outcomes. For example, if we look at sepsis, there are 3 trials listed here. So the Surviving Sepsis campaign, which is something that we have all heard of from 2016, they recommend a MAP of greater or equal to 65 in patients with septic shock. And more recently, the trial at the bottom there, the 65 trial, which was a large multi-centre randomised control trial, which looked at patients over 65 who were critically unwell. They recommend a MAP of 60 to 70 and that this is safe and can improve clinical outcomes. The Raising the Standards document, which is produced by the Royal College of Anaesthetists Quality Improvement Compendium, which is also more colloquially known as the Audit Recipe Book, recommends that patients should have a recorded targeted MAP in their twice daily consultant reviews. Now, we wanted to just get a snapshot of what current practice was on the unit. So I took a prospective sample of 20 patient days from February to June in 2021, just on a selection of shifts. I looked at the data from the previous 24 hours. I reviewed the notes, so I looked at the electronic admission documents and the electronic IMP ITU clinical document, which is the document where the ward round is section is filled in the morning and PM. And then I looked at the paper observation charts. The data collected included admission diagnosis, current diagnosis, target mean arterial pressure readings, where they are documented, when they are documented, and how frequently, and the adjustment of the actual readings, the documentation of the actual mean arterial pressure readings, and the subsequent adjustment of vasoactive drugs. So in this sample of 20 patients, 15 of them were admitted with sepsis, and 5 of them were admitted post-cardiac arrest. As you can see here, if you look at this graph, which shows the number of patient days on the y-axis versus where MAP was documented on the x-axis, the first bar shows that 95% of patients had a target MAP documented on the admission document. However, if you look further along the graph, you can see that only 10% of patient days had evidence that this target MAP had subsequently been reviewed and approved by a consultant and documented on the ward round. This is something that we wanted to improve upon. So we first decided to have a look and try to improve documentation on the morning ward round. We thought of several interventions and we discussed these at the intensive care audit meeting. We thought of popping a sticker on the observation sheets. We also considered putting a laminated sheet on the patient space. However, as everything is moving towards electronic documentation, we decided to alter the morning ward round documentation. So we added a mandatory box where target MAP had to be documented and reviewed, and that this had to be in place as you would be unable to sign off the document and move on. This was discussed in the 5 slides in 15 minutes, which is a daily meeting for junior trainees on the unit. Then in February 22, we took another sample of patients, and this was a sample of 28 patient days, and we collected the data as before. The diagnoses in this sample was a bit more varied. As before, you can see that a lot of patients, the majority of patients admitted with sepsis, followed by cardiac arrest, but there was there was other diagnosis, including post-op vascular patients and post-op general surgery patients, and there was also a trauma patient there. if we look at the difference in documentation now, as initially, admission documentation was very good and 100% of patient days had a target map documented in that section. Now, if we look here, we can see that now 100% of patient days had a documented target map in the AM ward round. There is still significant improvement to be made on the PM ward round, however. So has this intervention worked? So yes, target map is now documented in the ward round on 100% of patient days, which is a 90% increase compared with the initial data collected. So it has worked in improving documentation. However, I think there are a few questions which still need to be answered and are actually quite difficult to answer. So are the targets appropriate? If you have a look at this table here, there are quite a wide range of targets. So some of them are single figures. So for example, greater than 60. Some of them give a target range of 60 to 65, 65 to 75, for example. However, if you look, the vast majority of targets seem to be around 60 to 75. The two at the bottom there with a target map of greater than 80 were two post-cardiac arrest patients, and that target map was very patient specific because of everything else that they had going on. So I think it's difficult to say whether they're appropriate. Should the blood pressure targets be more standardised? And by that, I mean, should there be boxes to select a specific range of targets? So 65 to 75, that would make it easier for junior trainees, and also put a limit, an upper limit on a map, because having a map reading, for example, with no upper limit would suggest that there are no negative consequences associated with the overuse of vasopressors, which, as we know, is not true. And finally, is once per day review of blood pressure targets enough? And according to the Royal, the standards that we used, they do need to be reviewed twice daily. So that is an area which we think we could possibly improve upon again in the future. Thank you very much. Any questions?
Thank you, Sophie, for your presentation. Going forwards, are there any plans to improve the understanding of mean arterial target pressures on the unit?
Yeah, so two of the other trainees that are working there, that worked there at the time, they've created a teaching program for new trainees coming through to the unit, and that includes covers septic shock, the types of septic shock, and the use of vasopressors, adjustment of these, and any studies on mean arterial pressure readings.
Okay. Are there any other targets or observations you feel documentation like this or should be addressed in a similar manner?
So yeah, so I think we should include, in terms of the mean arterial pressure targets, I think we should expand that to include the PM ward round. And I also think that this could possibly be useful with other targets where a range is used, for example, with oxygen saturations, and that might have been quite useful, for example, in COVID.
Excellent.
Thank you.
So we're launching the poll for Sophie's presentation. Polls will now be open for this presentation and should be up on your screens now. Dr. Mary Leese is a CT3 trainee in anesthetics, as well as secretary of CRANE, which is our collaborative research in anesthesia in the Northeast, the Northeast Trainee Research Network. CRANE has successfully run a number of region-wide audits recently, including projects relating to obesity, bariatric anesthesia, and also obstetric pain relief. Mary, we can see you. It's over to you now. Just need to unmute Mary.
So thanks. I did try, and then it said the host won't let you. Anyway, so thank you very much for having me. So as sort of Jeevan alluded to, I'm here to talk about rapid sequence induction, a survey of practice in the Northeast on behalf of CRANE. First, if we look at why, so we've had a morning of talks all about NELA. Obviously, we all know that those patients need an RSI when they're having a laparotomy, and we all know what an RSI is. So those are some obvious reasons why this is relevant. But let's go backwards. So picture the scene. You're a core anaesthetics trainee, you're a new starter in anaesthesia, you've done a couple of sessions on the emergency list, maybe you've been to your new starters course once or twice, and you're with an old school consultant, you are seeing someone with, say, a strangulated hernia, and he says, oh, well, they need an RSI, so draw up some thio and sucks. And you think, no one does this. The other people that I've seen, I think they've used propofol and rock. Overall, actually, what is the balance of practice and what is the evidence? So not very long ago, that was me. I had this experience where someone wanted to use thiopentone and sucks, and I thought, am I sure about that? And then because I'm part of Crane, I thought, actually, I've got the opportunity to find out from everyone else what their practice is. So over 2 weeks in June, we ran a survey in 12 hospitals around the region. We asked anyone doing anything that they thought was an RSI in that period to fill out our survey, so that we could look at what people were doing. So we got a total of 177 responses. We had a couple of extra that we discarded because they were outside the study period. And we've got responses from all around the region, so some DGHs, some tertiary centres. You don't need to look at the details on the pie chart, and I promise that there will be no more pie charts because I'm trying to keep it snappy. The pie chart is just to prove that we did have lots of responses. So then if we look first at how many true RSIs there were, so we all know what a true RSI is. You don't give the patient any opiates, you use thio, you use sucks. The ODP gives the patient cricoid pressure. You don't give the patient any breaths via bag mask ventilation. So in our sample of 177 RSIs, there were 3 true RSIs. So that's 1.7% of results. So that's a pretty small proportion. And then if we sort of look sequentially at all the different parts, so in terms of induction agent, so we got 154 of 176 people using propofol, so that's 87%, which is kind of in line with what we were expecting. And then 4.5% used thiopentone and 7.9% used ketamine. One thing that we thought was interesting that we hadn't specifically asked about is that at least 3 people definitely used TIVA. So 3 people had sort of written in our free text box that they'd used TIVA. We think we probably tick boxes, and one of them was propofol. So some people doing TIVA would have just ticked propofol. So it looks like some people are starting to move towards using TIVA. Then if we look at our neuromuscular blocker, we're finding similar proportion for rocuronium, that 147 out of 178 people used rocuronium, so that's 83%, and only 15.8% of people used succinylthonium, so a lot more for rock. We also had 2 responses suggesting that people had used atracurium, which we were a little bit surprised about. Then if we look at opiates, so 77% of people were given opiates, and that we did have some obstetric cases included. So if you exclude them, then 80% of patients had opiates, and of those, nearly 90% got fentanyl, and 5.1% each got alfentanil and remifentanil. If we look at cricoid pressure, then that's more in line with what we would traditionally expect. So 85% of people received cricoid pressure. Then if we look at breaths via bag mask ventilation, obviously traditionally you don't ventilate the patient at all. We got 63% of patients had at least some breaths via bag mask ventilation. So, that's against the sort of traditional practice. And then to sort of summarise, we're finding that majority of people are using propofol, majority of people are using rock, majority of people are using opiates, of which the biggest opiate is fentanyl by a long way. Majority of people are using cricoid, and majority of people are bagging their patient, with slightly different proportions around all of those things. So that's quite significant modification of the traditional practice. And then I did promise at the beginning that I would talk, or I was interested in what the evidence was. So we're going to briefly look at some evidence. There's a slide here that it's very small. I'm willing to send it to anyone who wants to further read up about the topic. But in brief, there's a few references here. So references 1 to 3 are other surveys of practice. The first one was in, I think, 2001, and they're practice from around the UK, and one's just Wales, where they're showing a gradual evolution with an increasing use of propofol and rocuronium. They suggested that consultants were more likely to modify their technique. That's not in line with what we've found. And then 4 to 5 are systematic reviews, where 4 suggests using sucks over rock because it says it provides superior conditions, but then it says at 1.2 milligrams per kilogram there's no difference. And then 5 is looking at the use of cricoid, and it's unable to find any studies directly comparing the use of cricoid. And then there's a couple of others. So I think that that's me out of time. So I'm very happy to take questions.
Mary, thank you for that very interesting sort of presentation of the data. Do you think, based on your results, that it's time that we should be updating the guidance about how to perform a rapid sequence induction for new starters in anaesthesia?
I absolutely think that we should update the guidance, because I think the guidance can be confusing for new starters. When the traditional guidance says to use thio and sucks, and in practice everyone's using propofol and rock, I absolutely think we should update the guidance. I think that's less confusing for new starters, and also I think people who are early in their career, they're thinking about sitting their exam and giving the right answer, and I think that would give them confidence that actual practice is the right answer.
Okay, thank you very much. We're going to launch your poll now, so just give everybody a moment.
Poll should be now open and up on your screens.
Our next presenter is Dr. Victoria Mowat, who's a Foundation Year 2 doctor working in South East London, currently on her GP placement. She's hoping to undertake an F3 fellowship next year in intensive care and plans to pursue a career in anaesthetics. Victoria, we can see you, and if you could just, we can see your slides. So
okay,
back to start.
Great, thank you. Yeah, hi, my name is Victoria. I'm currently in F2. So today I'm going to speak about an audit that I did during F1 with a couple of colleagues and consultant surgeons in Tunbridge Wells, and it's looking at concomitant IV fluid prescriptions in patients who are on a variable rate IV insulin infusion. And it was done as 2 cycles as a prospective closed loop audit. So all general surgical or any surgical patients who are going to be nil by mouth for more than 1 meal need to be put on a variable rate insulin infusion, mainly just to maintain their glucose into the specified range. And we just looked at the IV fluid prescription and how much it was adhered to the guidelines that were published locally. This had been done as an audit previously in September 21. And been kind of outlined as a high risk area in that there was quite poor adherence previously. So we just had another look at it. So why is it important to have the variable rate IV insulin with the correct IV fluids? So things to consider: making sure that their electrolytes are within normal range, and making sure they're not going hypoglycemic. So hyponatremia, hypokalemia in terms of their electrolytes is important. And also looking at their fluid status and making sure that they're not kind of overloaded or fluid deplete. Ultimately, trying to prevent them going to funny arrhythmias, and ultimately increasing the risk is increasing the patient's length of stay in the hospital, and ultimately bad patient outcomes. So what were we looking at was looking at to determine how many of the general surgical patients on a sliding scale were prescribed the correct IV fluids, and ultimately to improve the adherence to the local and national guidelines. And we did some interventions and a re-audit to see if this helped. So it was a prospective audit. Each one was done over 15 consecutive weekdays in April and July last year. So we only did general surgical patients, that is, so in the DGH it was upper GI and lower GI, but didn't include any of the other surgical specialties, and looked at the IV fluid regime, documented their potassium, their sodium, and then it was looking at the trends, and importantly, whether their fluid status was documented. And there's 4 criteria that we sort of looked at to meet, which I will go through. So making sure that each patient would have received the correct IV fluid, depending on their fluid status and their electrolyte levels, and making sure that all have their fluid status documented in the notes. And this is the sort of guideline that's published in Maidstone and Tunbridge Wells, which is kind of what we were measuring it against. So importantly, it was making sure that their fluid status was documented, because that's sort of the fluid prescribing was dependent on that, which wasn't always adhered to. And the key points we're looking at were making sure that the fluids weren't changed dependent on their blood glucose level, making sure that extra potassium was given unless it was above 5.5. And yeah, making sure that their fluid status was documented initially. So this was the 4 sort of standards that we were looking at. If there wasn't no documentation of the fluid status, then we had to assume that they were euvolemic, which obviously isn't the most accurate. So in cycle 1, showed quite poor adherence generally. So we found there was a total of 12 patients on those the general surgical wards, and only 2 out of 12 had their fluid status as documented, with just 3 out of 12 having the correct potassium prescribed on top of their fluids, which in total only 8%, so one patient out of 12 had the complete correct IV fluid prescription then, which obviously isn't great. And of course increases the risk of sort of the arrhythmias and increased patient stay. So anecdotally, we sort of were trying to work out why it was so poor, and I think a lot of it was just not knowing that the guidelines existed, not knowing where to find the guidelines on the internet. Lack of time was also noted, and also just not really, I suppose, understanding why it was important in patients on a sliding scale and these surgical patients, making sure they were having the right fluids. So we did a few interventions before re-auditing. So we were just trying to raise awareness of the guidelines and general education. So we presented it at the monthly departmental meeting to the consultants and junior doctors. And then importantly was mainly the informal teaching, so dissemination of the guidelines and where to find them through WhatsApp groups and through posters. And that seemed to help. So in cycle 2, there were 15 patients that were found to be on a sliding scale. So the number of patients with their fluid status documented did increase, although only to 46% from 17, which is still quite far off the 100% target that we were initially hoping for. And although the supplemental potassium prescribed did show to be quite a lot bigger, and overall there was quite a significant increase. So from 8% to 73% did improve outcomes. And this is just kind of outlining it as well. And it was difficult, I suppose, again, with the kind of under 50% of the correct documentation of fluid status within patient notes, meaning that it was difficult to know if the correct fluid was prescribed after that with regards to if they were overloaded or depleted, because it wasn't really documented very well. So significant mistakes for alternating the fluids was between saline and glucose, which isn't recommended, not giving the potassium. In one case, no fluid being prescribed at all. Cycle 2, kind of similar mistakes, just a little bit reduced. Lack of fluid status documentation was quite key. And this was kind of similar, I suppose, results to what had been previously done. Although there was some adherence, it still shows quite a long way to go, and definitely wasn't really that close to the 100% adherence. The time was quite a key reason in terms of general surgical ward rounds, I suppose, in terms of the fluid status documenting. Anecdotally, I know that it's not always #1 priority for junior doctors or the reg or more senior doctor that's on, and maybe people aren't aware that that is kind of quite key in patients who are on the variable rates. And I suppose in terms of education, not reaching colleagues on call rota, colleagues being away from work, etc. And yeah, obviously it was a small study and we only wanted to a certain level.
Thank you, Victoria. So just a few questions.
Yeah.
For the 3rd cycle, what interventions would you implement to improve further adherence?
So I think what we were thinking in terms of a third cycle would be maybe trying liaising with kind of the medical team as well, trying to get the diabetes doctors on board, maybe integrating some kind of educational sessions for that, because it's mainly F1s that are doing the ward cover in on those wards. Just integrating those sessions with them, especially with the beginning. I think going forward, I think they're now doing e-prescribing, which should create the opportunity to maybe integrate educational alerts and pop-ups for patients who are on sliding scale. I think it offers opportunity for there to be less mistakes in the fluid prescribing.
Okay, yes, another supplementary question. How might you have improved data collection here?
So I think, as I was saying briefly at the end, it was obviously only a small data sample set and done in quite a limited, done in one hospital and one section of the hospital. I think we could definitely expand it to the other surgical specialties and maybe even compare it to the other medical specialties, just to see how the surgical doctors are kind of comparing to medical patients who are on sliding scale. Yeah, I think just maybe there's other targets that are on the guidelines that we could also measure against, such as making sure that on their basal regime in the background, and that's it.
Excellent, thank you very much.
Thank you.
So the polls will now be open for your scores for this presentation. It should pop up on your screen now. And it should be up, yeah, good. Our next speaker is Dr. Rory Andelic, who's currently a CT3 approaching the end of his stage 1 training. He's looking forward to finally graduating from his pink core trainee lanyard. He is very familiar with the Northeast, having completed his undergraduate studies at Newcastle and postgraduate training in the Northern Deanery. He has an interest in regional anesthesia and medical education. Rory, I can see your slides, and it's over to you.
Well, thank you very much, and good afternoon, everyone. So as I said, my name is Rory. So my quality improvement project is called Flying the Nest. So I'm quite partial to play on words when it comes to titles, because we all need a hobby. So I'm going to crack straight on with this. So what is NEST? So NEST stands for the Northeast Specialty Training Committee. And this is a group of intensive care and anaesthetic doctors based in the Northeast, ranging from core trainees to consultants. It's been set up since 2021, and I was fortunate enough to become involved last year. And it was really in response to what's happening with specialty recruitment, in particular, the bottleneck that's now being created and the competition ratios that have kind of gone a bit crazy in the last few years. So for anyone who's kind of gone through training at the minute, you've probably heard this quite a few times from higher trainees and consultants of back in my day, all you needed was the primary and the pulse. If you had those two things, then you'd probably get a career in a specialty anaesthetist. Usually they follow this up with how glad they are they don't have to get involved with the current programme, which is always reassuring to hear. This is backed up by data from Health Education England. So in 2021, there was just over 1,000 applicants for just under 400 ST3 anaesthetic posts with a competition ratio of 2.67. Because of this, NEST identified an opportunity to try and make candidates more competitive, to improve the CVs and to guarantee that they should hopefully get these specialty registrar posts. First virtual meeting was back in 2021 due to COVID restrictions, and because of largely positive feedback, we then went forward and carried this on into future years. So for any intervention, it's always important to have a look at what you can do beforehand and to see what candidates' thoughts and feelings are on how things are progressing at the minute. So this is just an online survey we sent out to 34 candidates. 18 of them had planned to apply for specialty straight after stage 1 training. Of those who said they weren't going straight into it, the reasons cited for this were a combination of wanting planned time out of training to either pursue teaching fellow or trust grade posts or to work abroad, or further time to develop their portfolio or to pass the primary examination. Of those asked, only 3 people wanted to, had already been to other courses aimed at portfolio development. So, unsurprisingly, when we asked them what they wanted out of a course that we could offer, the big one was point scoring. So the self-assessment points that go towards interviews. So points being prizes. If you get enough points, you get an interview. If you get enough points in an interview, you then hopefully get a position. And then to subdivide that, most people wanted more experience in research, management, and quality improvement. More general points that people just want to know how to build their CV going forward and to just understand the process in general. So given that's now moving online, how does that look from a trainee perspective? We also want to take a very quick snapshot with quite an easy question of how people were feeling regarding specialty applications. So that's essentially what we did. So using my prowess in Microsoft Excel, I was able to make this table. And as you can see, of the 34, 25 either felt somewhat or extremely unprepared when it came to special applications. So again, Nest identified a position that hopefully we could boost some of those trainees up into the more prepared categories. So following on from that, we then developed this, which was our portfolio day last year. So this is Nest. It was preparing your portfolio. It was November. It was a half-day event, and initially it was planned as just a face-to-face. We also did a hybrid format for trainees who couldn't get time for on-call commitments or on nights. Topics were quite broad, so we had a range of specialty doctors and consultants who had either been through the application process themselves or who were heavily involved in marketing portfolios. And then these included the marketing scheme for portfolios, because there is quite a lot of nuance and changes that the college have made when it comes to what you would get points for. Optimizing stage 1 training, because stage 1 is not just about trying to get to stage 2, it's about passing your primary and learning how to give an anaesthetic and how to be an anaesthetic trainee. We had talks from trainees who were heavily involved in management, so we had representatives from the Royal College and from the Intensive Care Society, and we had a perspective from a recently successful trainee who had been through the mill themselves quite a few times. I think they're in the audience today, so congratulations again to Max, so I'll give them a shout out. We also had delegates from Crane and A-Line, and they would signpost any opportunity that people could have to get involved with research and teaching within the region. I think importantly as well, we did have a post-course social. As a trainee, I got into training just before COVID. So actually most of my experience with my contemporaries was through the hospital I worked in. So it was actually just a really nice experience to be able to meet other people who hadn't had the opportunity before. So moving on to our feedback, happily it was mostly positive. So 29 people responded. The strengths of our course were linked up quite nicely what people wanted out of the course. It was a greater understanding of the self-scoring system and what makes it up. Optimizing time and how they could use make the best use of their time going through stage 1 training, and CV opportunities, so really highlighting bits in the region that they could get involved in. 100% of the trainees then said that they would recommend this course to other trainees in their position. We then asked the same question that, following this course, how do you now feel about specialty applications? And thankfully, a lot of people then moved into the extremely and somewhat prepared categories. That's 26 out of the 29. I've also put in some comments that we had from the day itself, just again to reaffirm the main benefits that people found from our talk. Helpfully, some of the feedback from the constructive criticism we got was that from a CT3 colleague, that they thought, although the course was helpful, it would have been more helpful aimed at a CT1 level to really maximise the potential that they would have to build their CV by the time of specialty applications. So competition ratios are hopefully going to settle down in the next few years, but they're not going to get back to the levels that they were a few years ago. So the competition is always going to be there. And I think we have to respond to that by making sure that trainees feel supported to build their CV. We need to target trainees early. So they need to have an early exposure to what the self-assessment scoring criteria is to build their CV as successfully as possible. And I think a really useful thing for Nest to do would be then to the newest cohort of ST4 applicants, if they're successful or not, is then to ask them, looking back, what they might find useful that Nest could offer in future training days. So that's the end of my talk. Thank you for listening. And I'm happy to take any questions.
Thank you, Rory. You have sort of alluded to this a little bit, but what role do you see Nest adopting for trainees in the future?
So primarily Nest will always be a platform to help trainees gain specialty applications. But I think moving more broadly than that, that we would look more into just general career development. So moving through with specialty trainees looking forward to consultant posts, and then for doctors out of training. So for specialty grade and trust grade, just to build a kind of competitive CV all round.
And as you've been through this process, what advice would you have for stage 1 trainees now with all your new knowledge regarding speciality applications?
So this is something I probably didn't take my own advice, but looking back, I wish I had, in that it's really good to get a grip of this early. So the last thing you want to do when you're CT1 and just gone to interviews is then to think about ST4 interviews, but to have a look at the self-scoring criteria to see where you currently score and then to see where you could maximize your points. Even if you then put on the back burner and then focus on your IAC and your primary, to then come back and maximize your points there. And I think it also means that a lot of people fall into the trap of agreeing to do lots of departmental teaching and audit projects, which does take a quite significant amount of time. But then if you look at the point scoring system, you might actually only gain 1 or 2 points, where you could give the agency to then say, actually, that doesn't benefit me, and then to see where your time would be best optimized.
Thank you very much. The polls will now open for your scores, and it should pop up now. Thank you for an absolutely outstanding first abstract session. I'm now delighted to introduce our first keynote speaker for the afternoon. I'm just seeing if I can see Gerry. Professor Gerry Danjoux is a consultant in anaesthesia and sleep medicine at South Tees, and he's the clinical lead for prehabilitation. He's a clinical interest in perioperative medicine and preparing patients for high-risk surgery, cardiopulmonary exercise testing, risk evaluation, and sleep medicine. Gerry has been an absolute inspiration in the region when it comes to improving patient care through both research and through translation of this quality improvement into real patient care. He's locally mentored several of us through research fellowships, and this continued work has made him both a national and international expert in improving patient care. So thank you so much, Gerry, for coming to speak to us and to share your work. I can see you, Gerry, and I think we can see your slides. So over to you.
Thank you, Elke. Can I just check that you can hear me okay?
We can hear you.
Great. Okay. Well, thank you very much for that kind introduction, and delighted to be part of such an excellent program today. So thanks very much for the invite. Elke kind of contacted me a few months ago and kind of tasked me with a title of a career in quality improvement. And I kind of mulled over this at the start, and I thought, I'm not entirely sure what she would want me to do here, but hopefully I can fill the brief and see where we go. I put a colon there, or was it research? And I think you'll see as we go on that there's some overlap and there's a bit of meshing between the two areas, which I hope is okay with everybody. On the left-hand side of the title slide is my research and quality improvement team, and you'll get to meet them a bit more as we go along through the presentation. So I think I've skipped a slide there, so I'm just going to put a couple of quick declarations up, which I'll leave up for about 30 seconds for people to have a quick look at. Okay, so the scope of the presentation, I want to just briefly touch on quality improvement versus research, and to see whether that discrimination between the two areas is really that important, or whether, as I say, maybe there's a bit of overlap and meshing. Then I guess the main brief is for me to review my professional career in quality improvement and research, and maybe try and demonstrate how it's not a tick box, and how you can kind of make a career out of it in some way, and then share with you some summary and final reflections about things. So quality improvement versus research. You can see on the left here, I've got a few cogs, QI being quality improvement, then we've got the research cog, and then importantly, the big green cog is enhanced clinical care that we provide for patients. So quality improvement, I had a little look, and that's kind of a definition that I came up with from looking on various things like Wikipedia and Google. And it seemed to involve combined, systematic and continual actions within healthcare that lead to changes which improve patient outcomes and benefit the system overall. So the system overall means it benefits patients, it benefits staff, it improves this kind of streamlining of processes, and it requires continual evaluation to see whether something that we've implemented has a benefit and where we take it to the next stage. Clinical research, however, is more about determining the safety and effectiveness or efficacy of interventions, I guess, intended for human use. And perhaps that's more about generating new knowledge rather than a continual evaluation process and implementation of new strategies. However, it's in my opinion, and I'm happy to be asked about that later on, but it's only my thoughts that the two combined can't be uncoupled and that together they drive enhancements in patient care. So the start of my journey was here with the gentleman on the left, which is my father, who was born in Mauritius in 1931. And he had a kind of lifetime of, towards the end of his life, age from 60 onwards, of vascular treatments. So at age 60, he was diagnosed with a 10-centimeter aneurysm, which he had repaired with open surgery. He made a really good recovery from that, and then 13 years later had recurrent problems, and had a recurrent open AAA repair. He had a thoracic aneurysm stented and carotid subclavian bypass. And for anybody who's done vascular surgery, these are pretty kind of brutal operations, and they're pretty big procedures. He stayed in critical care for 14 days, in hospital for 28 days, and thankfully made a good recovery. But I think this was at a time when I was starting out on my journey in anaesthesia as a trainee. And I think this led me to subconsciously embarking on a career in vascular anaesthesia, and I guess striving to improve the care that we were able to deliver for people, whether it was at a small environment in the region or whether it was at a bigger environment on a national or international scale. And hopefully I've managed to do that in some shape or form over the years. So it all started really professionally when I started on a fellowship in Vancouver in 2000, and it was a specific vascular anaesthesia fellowship. And I was able to envisage at first hand the benefits at that stage of consultant-led pre-assessment, when really it was just a kind of vision in this country, and not many people were really formalising pre-assessment at that stage. And I brought those lessons back, and I was appointed to South Tees in 2002 at a kind of particularly pivotal time in the history of vascular services in the Tees Valley, when they were being centralised at South Tees from North Tees and Hartlepool, and also from North Allerton. So that gave us the opportunity to implement the UK's first consultant-led vascular pre-assessment clinic in 2002. And I was unable to embed that with a consultant colleague, Simon Baker from South Tees, as part of the preoperative pathway for vascular patients. And it was the first vascular pre-assessment clinic in the UK at the time, which was consultant-led. After 2 to 3 years, we decided to do a little review of the implementation to see whether it had been beneficial. And what we saw was quite encouraging. And we published, as you can see, the paper on the left here with Kay Cantley, who's now, I think, at the RVI. But we saw high levels of patient satisfaction with the shared decision-making model. So it was fairly early in the shared decision-making journey. We saw enhanced pre-optimization and very few late cancellations, which had been running at about 10 to 15% prior. We got enhanced staff training in place with medical and nursing colleagues. We improved patient outcomes, and the clinic is still running today with an embedded MDT and functional exercise testing in place. And without really being aware of it, I think this was the start of the quality improvement journey that I was embarking on. But at the time, I don't really remember us using the term quality improvement at that stage. So I guess having an inquisitive mind, I kind of thought, well, what could we do next to improve the quality of care and outcomes for patients? That wasn't to sit on my laurels. So luck should have it that the chair of the session, Dr. Kothmann, decided to come and do some work with our team. And she embarked on a research fellowship. And between 2006 and 2009, we started to embed research as part of the journey. And what we did was the first international kind of study looking at the benefits of exercise training in patients with aortic aneurysms. And these were patients who weren't immediately planned for surgery. They were under surveillance. So they had AAAs of less than 5.5 centimeters. This was a proof of concept study, and it involved in-hospital exercise at a moderate continuous level. But we also had a control group, which is important for comparative purposes. Overall, in the group, we saw a 10% fitness improvement in the exercise patients. It was well tolerated and patients enjoyed what they were doing. And although there was significant variability in patient responses, which is what you would normally expect to see in an exercise program, the overall modeled number needed to treat was 5. If that was a tablet, I'm sure you would all agree it would be rapidly adopted into clinical practice. So I think we established proof of concept at that stage. It was the first prehab study that we were aware of in AAA patients, and it formed the precursor to what was hopefully an exciting program of research and quality improvement from there on in. So this slide now gives you kind of a project timeline of as to where we've gone since then, and I'm going to briefly cover each of these things over the next few minutes. So next we embarked on a more definitive trial, which was called HIT-AAA. So this was an NIHR-funded feasibility trial, which looked at high-intensity exercise in patients who were coming up for surgery. So we progressed from the proof of concept stage to actually doing a feasibility trial in patients with large aneurysms. And everybody thought we were absolutely nuts. It had to be nuts to be exercising patients with aneurysms this big and certainly doing high-intensity training. So, well, we had to get on with it and see what happened. So we had 3 recruiting centres across York, ourselves and Sheffield. And we did a 4-week in-hospital high-intensity training programme, and we also had a usual care or control group. And the outcomes we saw was that basically it was fairly safe to deliver. We had 1 or 2 minor adverse events, but no serious adverse events. Patient fitness improved, and fitness improvements were maintained up to 3 months post-surgery, which was really encouraging. We saw a reduction in readmissions in the exercise group compared to the control group, and also a reduction in perioperative anxiety levels. There were high levels of attendance and enjoyment with the exercise, and we came out with a provisional cost per quali for our health economic analysis of about £4,000. Now, anybody who knows about cost per qualities and commissioning and adoption practice, NICE tends to look at initiatives that come in under £20,000, and they'll look very closely at adoption below £10,000. The sticking point here was that it was a feasibility trial rather than a definitive trial. So we were never going to progress at that stage to full-scale adoption. However, we felt we'd set the scene for future translational implementation. So next, I had a critical decision to make, and it was, do I go on and lose more hair than I've already lost and try and do a definitive trial across the UK or internationally, or do we get on just actually try and implement a new model of care, a new pathway, a new program into clinical care? And that's what we decided to do with PrepWell, which was what was up next. So PrepWell was a community-based program for patients before surgery, and it was about translating research into clinical practice. It was a collaborative project with Public Health, South Tees, and it was funded by a combined grant from the Health Foundation and also from Sport England. It was a multimodal community lifestyle and wellbeing support program rather than simply exercise, and it was for an expanded number of patient groups. rather than just patients having vascular surgery. So this was the first time that we were aware of that anybody had tried to implement a new model of care in the community before surgery like this, working across sectors. And we used the National Cardiac Rehabilitation Framework by working closely with our national leads as part of this implementation process. So we got about 150 patients through the program in the first 2 years. We successfully embedded a new pathway across several specialties with cross-sector working, and we got excellent patient feedback. And anybody who wants to learn more about this can do so on our website at prepwell.co.uk. We saw improvements in patient fitness, strength, and health-related quality of life, again, and also with reductions in alcohol consumption and serial improvements in anxiety and reductions in anxiety and depression. And again, encouragingly, there was a signal to maintenance of these benefits up to 3 months post-surgery. And we were rewarded for these efforts by being named runners-up in the BMJ 2020 Team of the Year Awards, which was a real accolade for the team. Then, of course, like everything else, we were kind of sideswiped just as we were getting in our stride by the COVID pandemic. However, I saw this as a new opportunity, so we bought a green screen and a camera, and we thought, well, we have to innovate and start to create a remote pathway for patients. The funding was still in place, and that's exactly what we did. So we worked with some industry partners, and thank you to Nikki Powley for creating this slide, which I use repeatedly in talks I do. But we innovated and worked with 2 industry partners to create a 3-tier pathway. So the universal offer was a website that we developed, which had audio-visual and written materials for patients, and anybody can access these and use them free of charge for patients who are under their care. We then had a kind of middle or targeted program where we were able to enroll patients onto a kind of digital platform, or for those who weren't digitally enabled, we were able to support them with paper-based materials. The platform had an algorithm in the background which stratified risk, and we were able to put together a bespoke program for patients and have 2-way communication. And that was supported by live exercise sessions on Zoom with patients wearing kind of heart rate monitors that we could track them for safety reasons. And then at the kind of top of the pyramid, we had this complex model which was working with an industry provider who are now called Surgery Hero, which was providing one-to-one real-time virtual health coaching through a mobile phone app. And I'm going to spend a little bit of time on this because this is a real kind of quality improvement initiative that Nikki was involved with, and anybody who has any further questions about this could also pick her brains about this. So Surgery Hero is an on-demand digital clinic supporting people to prepare for and recover from surgery. Coaches, real-life coaches, work alongside patients to create their own bespoke kind of health management strategies. So it's about self-empowerment, and it's a whole person approach through a progressive 8 to 12-week program. Our primary evaluation was something called patient activation measure. Now, patient activation measure is a 13-item questionnaire, which measures an individual's kind of self-efficacy through knowledge, confidence, and skills to manage their own health. On a final score of 0 to 100, patients are categorized in levels 1 to 4. Now, levels 1 and 2 are known as levels of non-activation, and that is a patient group who is less likely to engage in healthcare promotion and is likely to have worse outcomes from hospital treatments and healthcare interventions. Whereas levels 3 and 4 were the opposite. It was a patient group that were more likely to engage and were more likely to have improved healthcare outcomes. So what we wanted to do was to have as many people in levels 3 and 4 as we could leading up to surgery. This is really what I've just said, and there's been a bit of movement on my slide here, but basically I've just kind of highlighted that it's involved in clinical outcomes, healthcare costs, and patient experience. And essentially, the higher up you are on the PAM score, the more likely you are to do better. So what did we see? So we had about 50 patients through this program, and the average length of the program, as I said, was about 8 weeks, and this was before hip and knee replacement surgery. So we saw 71% of patients overall had a higher PAM on exit than on entry. And if you look at the graph, the solid green circles are the entry PAM scores between 0 and 100, and the rusty coloured circles are the exit scores. And you can see the median entry PAM was 58.1, and the median exit PAM was 67.8. So that is a 10% overall group improvement. Looking at it a bit more in the kind of group format, so we've now categorized in the graph levels 1, 2, 3, and 4, and superimposed on that, you can now see the line of activation. So on completion of the program, 84% of patients were activated. 42% of patients improved their PAM by 1 level or more, and 4% of patients were non-activated at entry. So a third of patients at the start of the program were in a non-activated category. But as you can see, on completion, nobody was at level 1. There were a few remainers at level 2, but nobody was at level 1. And in the cohort, we saw a reduction in length of stay versus a comparative group of hip and knee patients with a reduction in length of stay of 1 day. We also saw improvements in physical activity status, nutritional status, mental well-being, and sleep on exit from the program, with median relative changes, as you can see, between 5 and 20% on the right-hand side of the table. Moving on from that, I just want to share a few final things with you. And so latterly, we got a further grant from Sport England to do some parallel work with the PrepWell programme. And this is a study called iPrepWell. So we've now delved back into the realms of research, but this is research like I've not done before. And this is about developing a digitally facilitated prehabilitation platform for patients approaching surgery. So it's different to the Surgery Hero thing. This is a co-designed, this is designed by patients for patients, rather than as creating something which we thrust upon patients and then find that it might or might not work. So we're working with the health psychology team from Teesside University, also Northumbria University, and York St John, and with York Hospitals. And we are working on this programme. We're 15 months into it. We're finalising the platform, which has been done following some rigorous patient and healthcare professional interviews about what they would actually want to see in any digital prehab programme. And we recently did some filming. So this was just done earlier this week. And this is one of the things that's been really interesting for me that I've not been involved with before, about creating educational materials for patients. And it really kind of opens your eyes and gets you out of the operating theatre. And that's been one of the things about the journey. As I'll summarise it, it's got me to meet a lot of other people that I don't think I would otherwise have met on my kind of professional journey. So finally, and this is kind of, I suppose, the cherry on the cake for me, really, with the work that we've been doing, but particularly the PrepWell project that we've been running at South Tees, which is now coming to an end, has essentially been used as the template for a regional programme called Waiting Well. And this is a programme which has been funded by the North Eastern North Cumbria ICB board. And we've secured £9 million worth of funding over 3 years to implement a physical and mental health support programme for patients on waiting lists for priority 4 surgery. So that's patients who are waiting for things like hip and knee replacements and so on. There's a focus on the highest risk individuals being supported, and particularly people who live in social deciles 1 and 2, so they're in high areas of deprivation, which, as we know, correlates with an increased risk of health risk behaviours and comorbid disease. There's also a focus on supporting patients with learning disabilities. There are 7 hubs across the North East and North Cumbria, with the Tees Valley being one of them. And we are separating the programme off so that there's a programme down in South Tees and there's one in North Tees that we're working very closely together. And there are also a number of programmes elsewhere in Newcastle, Sunderland, Durham and Darlington. And we're just getting underway with that. And we've had a meeting this morning with our delivery partner, which are Public Health South Tees. But we've got a really exciting plan, and we get started next month. So anybody who's interested in that, please contact me and I'd be happy to talk to you about that further. So coming to the end now, that's just an overview. Hopefully I've presented my journey as a consultant in quality improvement and research and how they mesh together. I didn't feel I could kind of separate them off, because I think the two go hand in hand and really complement each other. It's been interesting over the career. This wasn't something I designed at the outset. It's the way that the cards have fallen. But what's happened is I feel that I've moved from small local beginnings with important research to work being recognised internationally and forming the blueprint for the regional Waiting Well programme, and also other prehabilitation programmes in places like Leicester and Nottingham have contacted us to say that we were absolutely pivotal in helping them to get started on their journey, which is always very rewarding and nice to hear. It's been an incredibly rewarding journey, but I would say also incredibly challenging. And at an individual level, it requires perseverance, it requires tenacity, vision. But the most important thing is to have a team around you. Everybody working in the same direction. They're the key requirements that I've kind of pulled together, just reflecting on this. And it's been quite interesting reflecting back on 20 odd years of this journey. It's given me an opportunity to leave secondary care and meet some other great people from all other walks of life, from designers to IT specialists to psychologists, academics and public health colleagues. And they're people that I probably wouldn't have had the opportunity to meet if I hadn't gone on the journey. It's given me opportunities personally and for other team members to present, connect and travel internationally. But most importantly, it's given the opportunity to make a positive difference, I think, to patient care and, as I said, be surrounded by a great team. So just to finish, I've got a few acknowledgements up there. I'm not going to talk through them. You can see who they are, but they're the team that we've got around us at the minute and have really helped us to take this programme of work through its journey over the years. So I'm going to finish there. And I'm happy to take any questions if that's what the team want me to do.
Oh, thank you, Gerry. That was an excellent talk. I've just got a couple of questions, if that's okay, and we've got a little bit of time. Clearly, this has been your life work, and I've known you for quite a long time, and it's been, you can see the road and how it's progressing. And you're so nearly at the stage of national implementation, and clearly you can see the benefits that this would provide to patients everywhere. How you're going to get over the last hurdle so that this becomes a national project? Because clearly this does work.
Yeah, I mean, it's always interesting, that question. This is about scalability and national kind of implementation. And with all of these things, there's a tipping point, and you can swim upstream. And if you haven't quite reached the tipping point for implementation and adoption, it becomes very difficult. But it's about influencing the key people in the right places with the right messages. And that's where the ICB side of it has become pivotal over the last year or two, in that there's been a degree of swimming upstream within the trust with PrepWell and trying to kind of get the message across that it's a good thing to do and it's worthwhile. But then sometimes just kind of body swerving that level and moving to the level above. That's been what's most important. it's also important to connect with other people nationally and internationally and work together. And, you know, we're doing that through initiatives like the International Prehabilitation Society. And it doesn't really matter where the final study comes from, whether it's from our group or whether it's from, you know, the Netherlands or Canada. But those studies are coming out, and those studies are going to be out in the next year or so. And I believe that there'll be enough inertia and momentum for implementation to become what I would consider to be a no-brainer.
Brilliant. And this is a slightly putting you on the spot question. You mentioned that you met so many interesting people, and I've met some interesting people with you, both nationally and internationally. Who would you say has been like the biggest inspiration to you on your journey, other than your dad?
Oh, that's an interesting question. I suppose, looking back, you know, there are two people who stand out early in my career as supporting me on the journey. I guess one of them is David Thomas, who was a consultant anaesthetist in Durham. I don't know whether David Thomas is still working. I haven't seen him for a number of years, but he supported me when I was a registrar to get involved in research. He subsequently developed my interest in vascular anaesthesia and basically trained me in the nuances of delivering high quality care in a scientific way for patients having procedures like carotids and open aneurysm repairs. And he also opened the door to me getting involved in things like the Vascular Anaesthesia Society. So he was a big influence on my career, so not directly on some of the work that I might have presented today. The other person I think who was probably influential was Professor Chris Dodds, who was academic lead for the Department of South Tees when I started. And although Chris perhaps didn't, you know, it was more of a supporting role that he created opportunities for me. So they're the two people I would say who stand out. There have been a number of people elsewhere, like Professor Mike Grocott and Franco Carli and people like that who I've interacted with, who have been very supportive throughout my career. But I think they're the two standout people for me.
Thank you.
Thank you, Professor Danjoux, for an excellent talk and highlighting how small steps in quality improvement projects lead to huge improvements in patient care. Please remember to use the scoring polls at the end of each abstract presentation to help us allocate prizes at the end of the day. It is now time for a quick coffee break, and we will see you at 15:15, 3:15. Welcome back, everyone. Hopefully you're all feeling refreshed, ready to listen to the next 4 exciting projects. Dr. Aswin Malhotra is an ACCS anesthetics trainee with 6 months to go until he completes core training. He has enjoyed learning more about anesthesia and has a growing portfolio of projects alongside interest in pediatrics, obstetrics, and regional anesthesia. Aswin, we can see you, and we can hopefully see your slides if you can get them on. I think they're starting to come on. Yeah, and it's over to you, Aswin.
Introduction. Good afternoon, everybody. So today I'd like to talk about whether green anesthesia is something that is straightforward, something that's, achievable for us on a large scale basis. I'd like to thank Dr. Jeevan Subramanian as well, who I believe is an ST5 now in terms of data collection. And this all happened at a district general hospital. Looking at this whole process, it's a lot of people, when we think about sustainability with anesthesia, we think about total intravenous anesthesia, TIVA, and balancing that against the practicality of setting it up and the convenience of doing so, as well as the cost that is associated with doing this. So the objectives of our work, of our project, was to analyze the carbon footprint of 4 typical lists within a district general hospital. The 4 lists include: 1, this is a gas induction with a pediatric dental list, quite volatile, heavy in terms of consumption. Second list is a short TIVA anesthetic for breathless. And third is a long TIVA anesthetic for robotic colorectal list. And the 4th one of an awake regional upper limb list, where there's no general anesthetic given, just block syringes, needles, ultrasound. And then to determine if the personal choices matter as well in terms of carbon footprint. So we compared the air miles travel in the last 18 months post-travel restrictions of the anaesthetist. The 4 different anaesthetists are responsible for the different lists, and to analyze the economic cost of the 4 lists as well. In terms of the methodology, it's a retrospective analysis. We looked at the volume of sevoflurane that's been used for list A from the Drago-Adlan logbook at the end of the list. We also looked at rubbish collection and cost calculation, procurement and pharmacy costs, looking at the vials and ampules of propofol, the bed strips, giving sets. And for the 4th list, we looked at the regional equipments, the block needles, probe covers, ampules of local anesthetic, etc. In terms of lifestyle data, it was an anonymized questionnaire, and we calculated the air miles and subsequent carbon footprint that each of the anaesthetists would have produced from the miles that they've traveled by air. It was difficult to look at the other aspects of the anaesthetist lifestyles and compare them, because a lot of them were quite similar. For example, they use electric cars with the widespread availability of electric car charging ports in the district general hospital. So this was the more straightforward way we found to compare their personal choice. And this is what we've learned. So the results of the carbon emissions, as expected, is from list A, which is the pediatric dental list, where it's quite volatile, heavy. In 9 patients, which again is equivalent to 1 session, is involved a high proportion of gas induction. Consumption, we had 153 mils of sevoflurane, 180 liters of nitrous oxide, and that amounted to 147 kilos of carbon dioxide per full day list. Extrapolating that to produce about 9,700 kilograms of carbon dioxide in an 18-month period. In terms of personal choice analysis, anaesthetist A, who's associated with the volatile dental list, produced only 438 kilos of carbon dioxide in terms of footprint, as opposed to anaesthetist D, who produced about 4,800 kilos of carbon dioxide in terms of carbon footprint. So now if we were to just go back very quickly, that's still half of the amount of carbon footprint that was produced with the volatile dental list, despite nearly 10 to 15 times more in terms of air miles traveled. So it's quite a significant amount of carbon, more carbon footprint with the volatile, with the anaesthetists that's associated with the volatile heavy list. Just for interest, following in terms of carbon footprint, the short TIVA were scored the second, followed by the third TIVA, followed by the regional list, which produced the least amount of carbon dioxide in terms of carbon footprint. In terms of cost, interestingly, the volatile anesthetic actually produced the highest cost per list. So this is, again, we're talking, and I realize that the number of patients is more, but actually it occupies the same session number. So 9 patients, one session costed £112, followed by the short TIVA list, then the long TIVA list, and then the regional anesthesia. But the short TIVA, then the regional anesthesia, then the long TIVA list. We found that the short TIVA list actually costed more than the long TIVA list because there were more consumables. Whereas with the long TIVA list, once the steady state, if you will, was reached during the anesthetic, the consumables were sort of just kept on using. So the 2 propofol syringes were just continuing to be used. So it didn't amount to more cost. It was a difficult thing to compare the cost of all of them in terms of how from a longer period of time, but this is what we found, and it's quite eye-opening because a lot of people may think that TIVA might cost more than volatiles, but actually from looking at this and looking at the numbers, it appears that the difference is actually that the volatile is actually more costly. So in conclusion, I think our clinical and personal choices, they both matter in terms of the carbon footprint. The volatiles are extremely polluting, even when we compare to the air miles. And TIVA is, although at least double the cost of volatile per patient, is actually cheaper for the allocated list time. There's also other clinical benefits in terms of better recovery profile, perhaps better wake up, less PO and V, which can be associated with increasing the success of day case surgeries. And the other point we should consider is whether we should all be aiming to do awake surgeries when possible as well, to reduce both cost as well as reducing the carbon footprint. Going forward, should we be looking at building a theatre environment in a way that is been built to provide TIVA anesthetic and to only provide volatile anesthetic for specific cases where there's reason behind that? Would that be a more economical way forward, as well as more green way forward as well? Something for us to consider.
I've just got a question for you. Obviously, there's been a lot of interest, especially in desflurane, and desflurane, the plan is to try and phase it out. Do you think that we should be looking at phasing out all volatiles and nitrous oxide, or do you think there's another way around this?
I think it would probably be unwise to eradicate it altogether, because I think that it still has a place. Volatile agents still have a place in terms of gas induction for pediatrics, for example, or difficult airway where you want patients to spontaneously ventilate and anesthetize them. But we can consider perhaps getting rid of the piped supply of nitrous oxide, because a lot of them do get lost in the pipe supply in terms of dead space. So we can perhaps use a cylinder supply of nitrous oxide instead to reduce any wastage. So we could be looking at that rather than eradicating all them all together, because I think they still have a place in our practice.
Thank you for that very thought-provoking abstract. We're now going to launch the poll for Aswin. So we'll just give that a second and hopefully that pops up on your screen. That's now popping up. Our next speaker is Dr. Catherine Phoenix. Catherine is a native Scouser who came to Newcastle for university and then, as she puts it, has never escaped. She now works part-time as an anaesthetic consultant at the Freeman Hospital with interests in pre-assessment, ENT and major urology surgery. She spends the rest of her time herding small children and getting out and about in the Northeast. Catherine, we can see you and I'm sure we can see your slides in a moment.
Hopefully.
Okay. Thank you. We can see your slides.
Marvellous. So thank you very much. I just want to take this opportunity to encourage people to practice more holistic quality improvement, which is runs off the back of the last presentation well, actually. And I'm going to talk about some work I've been involved in with day case robotic prostatectomies as an example. So prostate cancer affects between 30 and 55,000 men in England and Wales each year. And the prostate being deep in the pelvis here, curative treatment options are radical radiotherapy and radical surgical prostatectomy, which traditionally was achieved via a midline laparotomy approach, which sounded like the surgeons basically stuck their hand in the pelvis and fertled around for a while, just trying to drag it out. So I think it was a big, bloody, painful mess with a large estimated blood loss. Most of the patient needed a transfusion. They had drains, they stayed in hospital for over a week, and there was a large associated morbidity and mortality. The operation itself took 6 hours, so it was quite labour intensive on theatre time. And gradually, as time's gone on, thankfully, the techniques have become more refined. Firstly, with laparoscopic procedures and now with robotic cases. So this is the setup in theatre. For anyone who's not familiar with it, there's a surgical assistant next to the patient who's operating the port sites, while the surgeon sits on his little console in the corner operating the instruments. So we've moved to now a 3 to 4 hour procedure where the patients are generally in a steep head down position. They go back to the ward with no drains, they have a catheter for a couple of weeks, but they're basically out of hospital the next day, walking, eating, drinking. So this is the surgeon I work with regularly. He's called Prof. Sumru, and he just piped up one day that he wanted to start doing these as day case, which seemed pretty ambitious considering we've always thought of it as actually major surgery. So I thought we better check whether there was any anaesthetic reason why this couldn't happen. So in 2021, he had 55 patients, and this graph demonstrates basically that the blue blobs at the bottom are the patients that required 0 analgesia post-op. They were getting 20 milligrams of morphine intraoperatively at this time. And those that did require some extra were generally within 6 hours of surgery. This is an arbitrary 6-hour cutoff that we said, actually, if you didn't need analgesia beyond that time, you probably could be considered for day case surgery. The story is the same with the antiemetics. The scale is slightly different, but this line is still at 6 hours. And again, most patients needed no antiemetic, and those that did had it fairly close to the end of their operation. So in terms of drugs, it's possible, but do the patients actually want it? Well, we asked a bunch of patients the next morning after they'd had a prostatectomy, and most of them said they would have wanted to go home. They felt comfortable enough to, and they felt like they'd be able to look after themselves at home. So they're quite a fit cohort of patients, and this was perhaps surprising that so many of them were keen to get out. But when you think about it, would you rather be patient A on his hospital squeaky mattress under a sheet that's perhaps the same consistency as the cold white toast he's going to be served in the morning, with his bed buddy right there sharing a toilet? Or do you want to be this chap on the other side who's comfortable in his own bed with a lot more control over what's going on, right down to the fact that he's wearing his own pajamas? He can wander around his house at leisure. He can speak to his family if he wants to. And this just introduced the concept of social benefits of interventions. So it's not all about the money, which is what we tend to be focused on most of the time. There are a lot of social benefits to the quality improvement projects we're doing. As a further example, this is just a photograph of an old man who's terminally ill, and his dying wish was to see his horse one last time. And his care facility were able to facilitate this. And obviously there's not really any population benefit or financial benefit to this intervention, but there's a huge emotional and psychological benefit to him personally. You can find lots of examples of this, and it goes beyond the patient. This staff member looks like she has some social or emotional benefit from this intervention. And then you can fall down the rabbit warren of horses in hospitals. And this gorgeous creature is called Dr. Peo, and he is a horse that works in a hospital in Calais, supporting terminally ill patients. And I think you can see that this lady is happy to see her family member riding around a ward on a massive horse. I mean, who wouldn't be? Either that or she thinks she's completely delirious. But basically, it just shows that it's not just about the money. There are some social benefits that are qualitative and therefore difficult to measure, but we need to ask about them and consider them. The Sustainable Quality Improvement Group have a very useful website, and their whole purpose is to try and encourage us to think beyond the money, so to embed sustainability in QI. And this is projects we're already doing. It's not about doing a particularly environmentally focused one. It's about thinking about the social aspects and the environmental impact of what we're doing already. We need to protect the environment, obviously, and you can actually calculate the carbon footprint of a lot of what you're doing, interventions and drugs, etc., by these helpful databases on the website. So you multiply the cost of the product by this conversion factor to give a carbon footprint, and the unit for that is kilograms of carbon dioxide equivalent. So using these databases, we can argue that there is an environmental saving from doing day case prostatectomies as opposed to those with an overnight stay. And that's in the region of 65 kilograms of carbon dioxide equivalent, which is obviously completely meaningless until you translate it into something that your brain better understands. So one case is the equivalent of 800 bananas or driving 300 miles in a car. And if you scale this up to doing 4 of these cases a month, which is perfectly doable, probably a massive underestimate, over a year, you're saving the equivalent of 39,000 bananas and 14,000 miles in a car. There's £14,000 saving as well. So it's an all-round good thing to do, and patients seem to want to do it. Feels like it's possible. So we started to try and do it, but unfortunately, there were a few failed discharges due to post-operative nausea and vomiting. So this triggered the final part of the project, which was to look at the analgesia we were giving. And it had previously been very heavy in the morphine department, but actually we were able to show that there was no real difference in terms of post-operative analgesia, antiemetics, and day of discharge between morphine and fentanyl. So it's perfectly appropriate to use fentanyl. But the bigger message really is things are changing, and we wouldn't have thought that this was possible, and I'm sure a lot more major surgery will become possible as a day case. But it's important to consider the environmental and social impacts of interventions, because it's important, but it also gives major strength to the changes that you're trying to institute. But I'm sure what most people will remember is the horse in the hospital, and I mean, can you imagine trying to get that thing in and out of a lift? Thank you.
Thank you very much. Just a couple of questions. One, just a simple question. How do you decide which patients go on to have robotic surgery versus open surgery for these kind of patients?
So I don't think they're doing open surgery anymore. I think the open surgery was a big drain on resources. It took 6 hours, and it was really knackering by the sounds of it for surgeons. So at the Freeman where I work, they were doing, 38, no, was it doing 12 a year? They were doing 1 a month. Whereas with robotic procedures, there's more opportunity for training. Theoretically, you can do them from a different country, but we're able to have a much greater throughput. So this is now the preferred method. The other option would be radiotherapy for curative treatment. And there are patient factors which will decipher between the two, but actually they only offer curative measures for patients who have a life expectancy of greater than 10 years. So it's quite a nice list to do, and it's a niche population who probably are eligible for day case surgery because they are fit enough to be, put forward for this surgery.
It's interesting to see that you calculated the environmental impact of this QI, and you're saying it's probably something we all should be doing with our own quality improvement projects.
Yeah, I mean, it's I didn't realize these databases existed, and it wasn't something I was doing right from the start, but as we went through the project, it was easy then to look at the different facets. And you can understand the social impact by putting yourself in the shoes of the patient. What would make your experience more preferable? But the social also expands to the satisfaction of the staff, for example. But in terms of environmental, there are these databases that will give you a decent ballpark figure of how environmentally friendly or not your intervention is, and that's all on that SUSQI website. So although it's never going to give you an exact amount, it gives you a good idea of how bad different things are for the environment. I mean, we concentrate a lot on waste disposal, but actually what's much more important is trying to streamline services and reduce the amount of resources we're actually using, because it's the manufacture and distribution that actually is most environmentally costly. So I think we do need to think about it for every project, really. Even if it's something like, let's try and reduce the number of Venflons that are going in, that reduces the carbon footprint of the Venflon production and distribution, as well as the waste disposal.
Okay, excellent. Thank you very much.
Thank you.
We should have the poll open now for scores for your presentation. It should be up, and I think it is up. And so moving on to our next speaker, who is Dr. Amy Fox. Amy is a Newcastle graduate and an intensive care trainee in the Northeast. She's currently taking a year out as an education fellow in anaesthetics at James Cook Hospital. Amy's professional interests include healthcare professional education, promoting A-line, and attending anaesthetic specialty interviews. Amy, I can see your slides, but I can't see you. You want to put your screen up?
Can you see me now?
No, we've just got a black screen, Amy.
It might be a problem with my camera.
So,
is that working?
Why don't you just start anyway? You just carry on the presentation and see how we go.
Okay, sorry that you can't see me, but at least you can see my slide. So thank you very much for that introduction. So today I'm going to present some work that has actually been done by a group of us with the other people attributed on the screen here. It's about an educational project that we've done at James Cook Hospital around training in airway emergencies. So some of the national campaigns recently, for example, the RCO campaign on esophageal intubation, have kind of highlighted the importance of a team approach in managing these emergencies. And over the past couple of years at James Cook, there's been quite a turnover in terms of the staff within the theatre department. And within the kind of the group of senior ODPs themselves, they've identified that there's kind of an increasing number of more junior ODPs and anaesthetic nurses within the department who have limited real life experience in assisting with airway emergencies. So that was identified by them as a group, really, that they had a training need in this area. And one of my colleagues, Will Green, when he was at James Cook doing an advanced airway module, took up the challenge really of trying to introduce some training in this area for this staff group. So he set up a set of 6 simulation scenarios on kind of key airway emergencies that we might face in theatre, which would be run by himself with the help of the sim team there. He ran it for a few months, and the informal feedback that was collected was very positive from the ODP group. So there was a plan that even though he was rotating out, that he would like for that to continue. Unfortunately, there was a little bit of a gap during the kind of the transition period, but then myself, Lizzie Turnbull and Stephen Worthy took over that after a couple of months. At that point in time, we just wanted a little bit more information to kind of check that there was a benefit in continuing with it. So this is a survey of ODPs from the department. This is 42 ODPs, bearing in mind that some of these had already been through 1 or 2 of the simulation sessions. This just demonstrates that there still overall was a real lack of confidence among the ODP group in terms of assisting an anaesthetist during an airway emergency in theatre. So definite benefit in terms of continuing the training. So the intervention itself, the use of simulation as a learning tool is really well grounded in learning theory. And there's loads of evidence that it's associated with improved clinical learning compared to traditional learning methods. It's particularly useful in this type of group where you'll have a kind of a diverse range of people's previous experiences and knowledge. And I think it's also especially important in relation to uncommon clinical events. where prior experience, even if that is only through simulation and not having faced it before in real life, has been shown in research to significantly improve patient outcomes, which that's very much the case with airway emergencies. Thankfully, they are relatively uncommon events. So when we restarted after that kind of couple of month hiatus, Will had already written a set of 6 very good scenarios, so we chose to carry on with those. So they cover the airway emergencies that are detailed here. The training is currently delivered once a week on a Tuesday morning. It uses a bed space in the recovery unit. We're very lucky at James Cook to have a really good in situ sim team who come along and provide equipment and a sim tech to help us. And then the simulation and debrief itself is run by either one of us anaesthetic trainees, or there is now also a clinical lecturer who's associated with the sim team who has a background in cardiothoracic theatres. So he does sometimes run it when we're not available. ODPs and anaesthetic nurses in the morning are quite often available in recovery because they haven't been allocated a patient yet, or sometimes they can be released from lists once the first patient is on the table. So we invite them to attend in groups of 2 to 3. It is entirely optional, but most of them do come. And the simulation runs 3 to 4 times in a row to get several groups through it. Each scenario lasts about 20 to 30 minutes and they run on a cycle over the 6 weeks. So we ran this for a couple of months and the feedback that we collected at the end of each session actually identified that staff were very keen on what we were doing. But they actually thought that they had a further need for training in terms of the types of emergencies that they might face in the recovery room in addition to theatre, because that was one place where they felt a little bit less confident in managing emergencies on their own until an anaesthetist arrived. So it went through a kind of a revision and alongside the initial 6 scenarios, theatre-based scenarios, we wrote and added in an additional 6 scenarios, which were recovery-based scenarios. So that's these scenarios listed here on the right. Each of these does also have an element of airway compromise to them, just to get staff used to using kind of basic airway techniques and adjuncts. But there's additional things written into these scenarios in terms of learning points along the lines of things like performing an initial A to E assessment, initial parts of management for these patients until help arrives, and then some stuff about human factors, so communication, teamwork, things like that. So looking at how well it's been received, we do collect feedback from everybody once they've been through at least one of the simulations. When this presentation was written and submitted, we had only been doing it for about another 6 weeks post hiatus. But this shows that basically everybody that we asked, at least to some extent, agreed it had improved their confidence in managing airway emergencies. And everybody that we asked was very keen to come along to future simulation sessions and said that they would recommend it to their colleagues. There's another part on the feedback form that they're asked to fill in, which is a blank, like a kind of a blank box that asks them to identify the key learning points that they've taken from the session. That's really useful for them as a reflective learning tool, but it's also useful for us because it does demonstrate that actually the learning points that they are taking from the sessions align quite closely with what the intended learning outcomes were. So this is just a small selection of them, but it demonstrates that alongside some of the technical aspects, some of the non-technical things, so for example, stuff around use of cognitive aids, teamwork and communication is actually also being taken from the session. So looking at going forwards, at the moment they run only for the ODPs and anaesthetic nurses. And it has been really useful in terms of generating buy-in from that group of staff. But the overall purpose is to improve patient care. And I think that's probably not quite going to happen while we've isolated one segment of the theatre team. In January, there were new guidelines, DAS recommendations, which were published in anaesthesia, which talked about how to integrate human factors into anaesthesia. And their recommendations included one that talked about the fact that teams that work together should train together. And that's where we want to take this going forward. So ideally, we want to get it to a point where all of the members of the theatre team are involved in these simulations. But I think the next logical step will be to include anaesthetics trainees or indeed any anaesthetic anaesthetic doctor, because they're probably the next group that's relevant to the scenarios that we've got, but with a plan to evaluate that as we go forward and expand the scenarios. So thank you very much for your time. Hopefully I have inspired some of you to look a little bit beyond the medical workforce when you're planning your education projects, and I welcome any questions.
Thank you. It's a brilliant initiative. I was just wondering, how do you manage to get the staff to be able to attend if you're focusing on ODPs? Obviously there's a shortage of them, and were there any other barriers that you faced to implementing this?
Yeah, so it's a really good question. I think timing is the key to it. So we normally start in the morning at about 9 o'clock, 9:30. And because we run in the recovery room, what that means is that all the staff that are allocated to recovery that day, actually most of them don't have a patient at that time in the morning. Maybe one does, but most don't. So we generally tend to be able to get most of the staff allocated to recovery that day through it within about an hour. And then there's I'm not quite sure how it works at other hospitals in the region, but because it's such a big hospital, there's quite often trainee ODPs and ODPs who are just starting out. So there's quite often double allocations to a lot of lists. So once the first patient is on the table, we're also quite often able to get a small number of ODPs out of their lists to come and attend as well.
I think I just wanted to ask, how can you ensure, obviously it's a trainee run initiative, which is excellent. How are you going to ensure longevity or continuation, given that trainees move on?
So actually now we've got really good buy-in on a departmental level, I think, from more permanent staff. So I'm there as the education fellow, and hopefully will be another education fellow who follows me, who hopefully will kind of take the lead on it. But we do have really good buy-in now from the ODP side of things, so the lead ODPs in the department. There's a couple of anaesthetic consultants who are also involved. And then also, because we're lucky to have the SIM team there, who have a clinical lecturer who is now also allocated to come on a Tuesday, I think there's lots of permanent staff there to kind of guide it going forward. It would be nice if it stayed a trainee-led initiative, but I think there's enough permanent staff there now to keep the ball rolling.
Thank you. We're now going to launch your poll. So hopefully you can all see Amy's poll. That for a second, just to pop up. Our next presentation is Dr. Emily Good, who currently works as a Foundation Year 2 doctor at Bradford Royal Infirmary in Emergency Medicine. Since her anaesthetics rotation in FY1 in Leeds, she's developed an interest in pursuing anaesthetics as a career. Emily's continued to contribute to QI projects in the Leeds anaesthetic department, as well as developing a teaching programme for FY1 doctors covering NELA patients and how to prepare patients for a laparotomy. Emily, we can see you and we can see your slides, so over to you.
Perfect. So thank you very much for the introduction. So my name's Emily, and today I'm going to be talking to you about the service evaluation project that I undertook last year whilst I was in Leeds, just looking at high-risk emergency laparotomy patients. So as I'm sure you're all very aware, emergency laparotomies are incredibly high risk surgeries and can be associated with high mortality as well. So because of this, NELA have devised a guideline which basically states that all high risk laparotomy patients, so any patient with a predicted mortality score of equal to or greater than 5%, should ideally be operated on by both a consultant surgeon and anaesthetist. So bearing this in mind, whilst as a department we were going through our NELA data from 2020, we actually found that in Leeds we were falling behind these figures quite a lot. So our consultant surgeon and anaesthetist present combined actually only equated to 62% of cases, compared to the national average of 90%. And then when we split this up into specialities, only 83% of our high-risk NELA cases had consultant surgeons present, compared to the average of 96%. And then only 73% of our cases had consultant anaesthetist present, compared to the national average of 93%. So this led us to kind of think could our reduced consultant presence in these high-risk cases potentially be contributing negatively to patient outcome and to patient mortality? So hence why we decided to devise this project. Just change my slide. So our main objectives were to look at the total number of cases that Leeds were operating on with a NELA mortality score of equal to or greater than 5%, and split these into both in-hours and versus out-of-hours cases and look at the effect that this had on mortality. And then in conjunction with this, also look at the grade of operating anaesthetists and surgeons and combine this all with the mortality data that we found and see if this was affected at all. So just to briefly run you through our methodology. So we only looked at data included in the year 2021, and we only included patients who had a predicted NELA mortality score of equal to or greater than 5%. So that's patients who had a 5% or greater chance of dying 30 days post-operatively. We then categorised these patients on either in-hours or out-of-hours, depending on their entry time into theatre. So an in-hours patient would be entering theatre between the hours of 8 AM and 5 PM during a working day week, out of hours being any time outside of this. We also then created 4 staff categories. So our group number 1 was our NELA ideal standard. So that's both a consultant surgeon and a consultant anaesthetist operating during these high-risk cases. Our second group included a consultant surgeon and a trainee anaesthetist. Our group 3 composing of a trainee surgeon and consultant anaesthetist. And then finally, our group 4 composing of only trainee surgeon and trainee anaesthetist. Finally, we used our chi-squared test to do some statistical analysis of our results. So I'll just briefly run you through some of our results. So we had a total of 134 cases. And as you can see from this bar chart, the majority of our cases were had a predicted mortality score of between 5 and 9.9%. We then split these cases into whether they were done in hours compared to out of hours. So actually the majority of the cases done in Leeds in 2021 were done out of hours. So a total of 77 cases were out of hours compared to only 57 cases in hours. And then finally, combining all of this data together, including our staff category groups. So we can see group 1, which is our bar charts on the left-hand side. So that's our NELA ideal standard. That's both our consultant surgeon and anaesthetist. They operated on only 49% of cases done in Leeds, so quite significantly less than our NELA ideal standard. Interestingly, they also had the highest mortality rates as well, but if they were also undertaking the most cases, so explains some of that partially. We then moved to the other side of the bar chart, so group 4, so that's both our trainee surgeons and trainee anaesthetist. So they interestingly were doing the majority of their operating time out of hours compared to the other groups. So following applying our chi-squared test to our results, we found there was actually no statistically significant difference in the mortality in any of our groups, comparing both in hours and out of hours, including combinations of all of our staff categories, which we were initially quite surprised at. Looking through several other studies, so notably one by Livingston et al., which was quite a similar service evaluation project to ours, they actually found very similar results as well, and they didn't find any difference in the mortality rates in hours and out of hours. So we then got thinking as to what could some potential causes be for our results, and there's obviously a multitude of factors that go into patient mortality and contribute to that. So things like patient comorbidities, patient frailty, age of these patients, and including the quality of perioperative care that these patients receive as well. And then finally, one suggestion which one of our senior trainees mentioned is that actually quite a lot of the trainees, both surgical and anaesthetic, who are on the rotas for these out of hours cases are very senior trainees, so they tend to be kind of ST7 within kind of a month or maybe a year of becoming consultant. So actually, could the quality of care that these very senior trainees be providing be close to optimum levels? So that was what we thought. So thank you very much for listening to my talk. I'm very happy to answer any questions that anybody has.
Thank you very much. That was a very illuminating talk. Just a quick question. Do you have any future plans for this project?
Yes, so we're hoping to, in the future, combine our findings with other large centres who undertake a lot of emergency laparotomy cases in the future, and look at their mortality data as well and compare it to ours and see if there's any way that we could kind of improve our figures, and yeah, essentially just help to improve patient care.
Excellent. So we should be launching our polls for your presentation, and it should pop on screen right now. It's up on screen. Right, excellent. Thank you to all the abstract presenters. I now have the pleasure of introducing our last keynote speaker of the day, Dr. Rupa Mukrosan. Rupa has been an inspiration in anesthesia through her work with the Association of Anaesthetists. She has been instrumental through quality improvement, highlighting fatigue and campaigning for better workplace environment. She's going to be talking to us about human factors in quality improvement projects. You can see Rupa on screen. You can see her slides. Over to you, Rupa.
Right, thanks very much. And thank you so much for asking me to speak today. It's a real honour to come and speak to you. And yeah, great for everybody that's still dialed in. Well done, because we're all about to hit our circadian dip. It's nearly 4 o'clock, so stay with me. I'm going to speak to you for about 20-25 minutes, all about the human factors in quality improvement. Oh, my slides aren't moving. Hang on a second. Oh, there we go. Excellent. We just had a bit of a delay there. So just a few acknowledgements just to start with. So thank you very much to Nancy Redfern, Leona Walsh, and also to Mark Stacey for a loan of some slides. So human factors, what are we actually talking about? So I'm sure you all know this, to be honest, but I thought I'd just reiterate it really quickly, that we're talking about the kind of softer skills apart from your clinical skills, but they're really, really important. So we want to talk about communication, leadership and teamwork, workload management, situational awareness and decision making. So they're the main sort of components of this. But right in the middle of this circle really is you. And it kind of all starts with you, really. So it's really important that you're able to look after yourself and your well-being in order to function really, really well at work and also do amazing quality improvement projects. So I kind of thought of this, the slide on the right, the picture of the seedling. I kind of think about well-being a little bit like that. And I think it's quite a nice analogy, really. So you've got a seed that kind of needs nurturing, it needs looking after, it needs light, it needs food, it needs protecting, but actually it's really kind of fragile and it's really easy to not take care of it. And if we don't take care of ourselves, it means that we can't flourish when we're at work. So what is well-being and how is it like kind of officially defined? So there's quite a nice diagram here, which are kind of the different dimensions of well-being that the WHO talk. And they simply say that mental health is a state of well-being in which an individual realises his or her own abilities, can cope with the normal stresses of life and can work productively and is able to make a contribution to his or her community. And I think the word community is quite important there. And I'm going to talk a little bit more about that in a second. But you can see there's lots and lots of different parts to your well-being, aren't there? There's not just the physical, kind of like keeping fit, going to the gym. There's your emotional well-being, financial stuff, social and the social connections you make at work. Spiritual, intellectual, environmental, and also occupational. So what makes us happy at work and what are the really important things that make sure that we all feel kind of like happy and satisfied and feel that our work's really valuable. That's dead important, isn't it? So there's quite a few different dimensions here we can look at. Work-life balance is probably an obvious one and something you've probably thought about before, to be honest. But there's other things too, like it's important that we feel secure in our jobs. It's important that we have like decent job conditions, and that's little things, isn't it? Stuff like having lunch, being able to have a locker, being able to park your car. Social capital is massively important, and the social connections you make at work are really important in how the whole hospital functions, and that ultimately affects how we deliver care to our patients. We need to have autonomy and variety. We need to feel appreciated and need to be valued, but we also need to feel that we have meaning and purpose in our work. And when we have all of those things, that adds to our gives us a positive stance on our work and allows us to become competent and to develop and to flourish. So how are you feeling at the moment? So this is a little piece of work I did, and to be fair, it was done in lockdown, so within the COVID pandemic, and I surveyed some anaesthetic trainees. It was quite a small piece of work. It was only about 30 to 40 trainees, and we just did it via social media, and I just said, send me 3 words about how you are feeling at the moment, and this is what came back. As you can see, it's probably quite negative, but you'd probably relate to all of the things that you can see on the slide. I really, really hope that now we're kind of out of the pandemic, things are a little bit better, but I have to say, personally, I still identify with some of the things on this slide because I think work is really, really tough at the moment, and working in the NHS as a system is a difficult time for all of us. So what does the research say about how we're doing? So this is a longitudinal survey that's being done, and it's kind of been done with the backing of NHS England, but it's independent from them, and it comes from UCL. It was published in the BJA, and it's a really massive survey, to be honest. So this is reporting from the first bit of the survey. So it's over 6,000 people, and that is anaesthetic and IT staff. So that's nurses, doctors, healthcare, anybody that's working in those environments. And they completed the survey and before and after the winter surge in 2021. And it's really, really shocking results, to be honest. You might have seen this, it hit the headlines, it was in The Guardian and all sorts of different newspapers, because a huge, huge number of our staff met threshold criteria for one of the following. So severe depression or anxiety, PTSD, or problem drinking. So before, that was 51%, during the pandemic, 64%, and 46% after. So this survey is still actually running, and you may have been part of it, and we'll report on the sort of the data post-pandemic should be coming out pretty soon, so we can see how things are doing. Hopefully they'll be a bit better. So is some of this kind of us as well? Like, because I think being doctors that we really put quite a lot of pressure on ourselves. And I saw this picture on Twitter. It's from @Liz and Molly, and I just thought it was brilliant because I really identify with it personally. I don't know if it's just me, but like the tiny little dot is what one person is physically capable of doing, and yet what we expect of ourselves is absolutely massive. And I think sometimes what is expected from us at work also feels a bit overstretched and a bit more than what we're capable of. So it's just worth sometimes like putting things in perspective, trying to keep it real. What can I do, and what is within my control? So you'd have all come across this before, I'm sure. So it's a Yerkes-Dodson stress curve. And the point of putting this up in this talk really is to say that stress has a positive side to it as well. It's not all about being stressed, isn't all about being negative. Because if you don't have enough stress, you're going to be at the green end of the graph where you're like inactive, bored, and your performance isn't very good really. So we all do need a little bit of stress to flourish at work. So, but you want to hit peak performance. And to hit peak performance, you have to have enough stress, but not too much stress, because you can see what happens as we go and the curve becomes more red. As the stress levels increasing, the performance actually starts to drop off. So you need just the right amount. If you get too much, you're going to tip into fatigue, exhaustion, and eventually burnout. And that's exactly what we want to avoid, because it's really hard to get back from there. So, like I've kind of said, it's just a bit of a balance really, isn't it? You need a certain level of stress to motivate us and help us feel like really fulfilled in our work and enjoying work. But too much stress is bad and can negatively impact on our cognitive performance. our physical well-being and our self-control, and that impacts on our patients. So what happens when you have too much stress? These are some of the things you might see and you might recognise in yourself. It gets a little bit harder to concentrate. Our reaction times get slower. You can have difficulty focusing. It's really hard to make decisions when you get too stressed, and it's hard to control your emotions as well. Also, the way we recognise risk is just different, really. You have problems recognising when something is risky, so you're more likely to take risk. And we also have difficulty in communicating with each other. So you can see how all of those things can combine together to make work quite hard, really. So I love this model of stress, and I wanted to share it with you because I think it's just really nice, really. So your stress is like a bucket, and you can see it filling up there with the water, and the water is all the things that are building up, making you more and more and more and more stressed. But what do we do about it? Well, we need to punch holes in our buckets to release the pressure, release that water, and make us feel better. So we'll just see it go up again. There's all the different things on the right, the stresses you might have. And there we go. We need tools to release our stress. So how to think about my stress bucket and how I'm doing at the moment. So just thought I'd share with you where we are with things. So here's my water. This is what's been happening this week. We've had lots of theatre list overruns. Lunch has been a luxury in getting out of theatre. I've also been on call this week, which is really, really busy. There was a big crash on the A19, so that didn't help things. I've had a late starting list. I had not just one broken anaesthetic machine, but 2 broken anaesthetic machines. And by the time we got it all fixed, it was 11 o'clock before we could start the list. So I found that quite stressful. In terms of not at work, what about at home? So I've had the kids, obviously it's still winter. They've all got some dreadful lurgy. I've had 2 out of 3 off school. They went back to school and then they gave it to their childminder. So then she went off sick. So again, that causes problems. There's been lots of deadlines for different things. And I've had teaching sessions to prepare for. So there's been quite a lot going on, really. And I thought, well, what have I done? What are the holes in my bucket that I've put in there to try and make all this a little bit better? So I've had a good night's sleep. Amazing. It makes all the difference. Totally would recommend. I've actually only worked a 2-day working week this week, which I think has helped despite one of them being on call. But when I was on call, I stayed at my very good friend's house for on call, which was absolutely brilliant. So I did a bit of socialising as well. And then post call, I treated myself to a nice pyjama day and a day of box sets on the telly, which was great. Then I've gone for a sunny walk on the beach, and to really treat myself, I've had a takeaway as well. You can see actually when we look at like the stress bucket, the water and the holes, I'm probably a bit behind on at punching holes in my bucket because there's more in my water list than my holes list. So I think this weekend I probably need to concentrate on doing some more nice things to relieve my stress, just so I'm all ready for the next week. So how's your stress bucket? So this is quite a good little worksheet for you to try. And it actually comes from a GCSE website, but I still think it's absolutely brilliant. So it looks at how is your stress bucket. So number 1 is your water. What's stressing you out? And then think about what's real stress and what's imagined stress. And then we're going to think about, actually, I can only deal with what the real stress is. Look at what's your chain within your gift to control and what is out of your control. And then you can adjust your list accordingly. And it says, get organised and ask for help if you need. So number 2 is your holes. What's letting out your water? What are your coping mechanisms that are going to help you build resilience and manage your stress levels? And 3 is the tipping point. So this is really important. Like, what are the things that happen to you that tell you you're getting too stressed? And anyone that knows me or works with me knows that it's when I start losing things. That's what I know. I need to slow down and put some more holes in that bucket of water. So what can we do to make things better? There's some really, really simple but really effective things you can do. So kindness is incredibly important. So kindness and gratitude just spread the joy, really, and spread the love. So say thank you whenever you can. Like, it really, really makes a difference to your day. And the research shows that giving gratitude not only helps the person that's doing it as well as the receiver. So you both get a benefit out of that. Make sure you have like good work-life balance, and make sure you can exercise regularly if possible. Planning ahead helps as well, deciding on clear goals and priorities. And if you think about that circle diagram I put up earlier about what we expect ourselves to do and what we can do, it's quite important that we pick realistic goals. know yourself and know what trips you up. You can look at the ABC of calming. So if you Google the ABC of calming or the A to Z of calming, it's got some really excellent tips on little things you can do. And remember, there's always someone around you can speak to who can help you. So resilience can be a little bit of a dirty work on it, but I think it's got its place. And we define resilience as the ability to be happy and successful again after something bad has happened to you. And it's the ability to recover or adjust easily to misfortune or change. So what are the things that protect us and make us resilient? So things that help us deal with stress are things like positive self-esteem, being sociable, so those social connections again, having supportive family relationships at home, having positive role models, and making time for opportunities for fun and joy. The skills as well that we can acquire, we can get better at doing these things. So we can get better at managing our negative feelings. We can get better at problem solving by practicing. We can work on our social connections and our relationships. It's important that we take time to recognise and value all the things we've achieved as well. And it's also important to create opportunities to relax. So there's lots and lots of things going on that can improve our well-being. So this comes from a piece of work by Redfern and Wren, and they looked at people that were referred to Elke Health doctors. And they found out that there was a couple of things that really played into your performance. So there's the individual characteristics, and that's your like coping style, your level of stress, your motivation. But then they found out that organisation and work stressors, both of those things feed in together and they really affect your performance. So we talked again, didn't we, resilience? I'd definitely have a look at this document if you can. It's on the Association of Anaesthetists website, and I think it's really, really good. There's the Baker's Dozen of mental toughness, and it talks about the ability to be happy and successful again after something bad's happened. But equally, it talks about how we become resilient by the bonds between the team members that we have and those connections, and that they are actually much, much more important than any one individual. So this really, really is a team effort, and good peer support and social cohesion will help with everybody's mental health in a positive way. So I thought it's important we think a little bit about the individual and our behaviour. So it's worth just stopping a minute and thinking every now and again, well, how do I want to be seen at work? And what kind of person do I want to be? So role modelling is really important. So if you're a senior trainee, that's to the more junior trainees, the whole theatre team, and just how everybody behaves actually really, that creates the culture within our workplace. So we have every one of us has a role to play within that work culture. And think about how you're looking after your well-being within your workplace. Like, is the environment supportive? Can we make our departments more supportive? Is there cohesion within the department? Does everyone feel valued, and does everyone feel able to have a voice? And again, I really liked this diagram from Atlas and Molly, and it talks, well, you can see it's all about kindness, isn't it? You know, a tiny little bit of effort has a really massive impact. So there's lots and lots of resources that we can tap into. So this is just a screenshot of the Association of Anaesthetists homepage, and there's lots of stuff about well-being, physical health, fatigue, mentoring, career support. So please have a look at that and work your way through the pages. There's lots that you can learn from there. And I wanted to mention mentoring. So this is an article that myself, Nancy Redfern and Louise Swan wrote. And mentoring, if you've not come across it, I'm hoping that you have because you work in the North East, but it's a structured conversation with a trained mentor that helps you become more effective at managing problems. And it's actually just about empowering you to discover your own solutions. So it's absolutely not advice giving. In fact, it's completely the opposite. There is a national mentoring network, which can be found at the URL, which is just there. But we are very, very lucky because Louise Swan, that's written this article, also runs NEMO, which is the North East Mentoring Service, which I'm sure you've all come across. And I'd really, really encourage you, if you haven't had a try, just email the email there on the screen, nemomentoring@gmail.com, or tweet them at Nemo Mentoring and book a session. So it's brilliant for exploring opportunities as well as dilemmas. So really, I'd recommend giving it a go. And it's all free and it's completely confidential. So I kind of wanted to wrap up really with this, and Mark Stacey at the Association of Anaesthetists talks about this a lot, and it comes from Stoic philosophy. I think it's just brilliant really, because it says it all, doesn't it? It's 3 C's, and it's all about controlling what you can, coping with what you can't, and concentrating on what counts. So thanks very much, and if there are any questions, I'm happy to take them now.
Thank you, Rupa, for an amazing talk. I feel thoroughly inspired. I'm going to get my bucket and puncture lots of little holes in it. And that brings us to the end of the programme today. I think your natural it just infuses everybody, which is just amazing. I think we can all agree that our speakers have just been fantastic. And I'd like to thank everyone again for taking the time to educate us, share your work with us, and simply be here today. And for the vast amount of people for holding on to the end. We've had such a brilliant day with so many highlights. I think I've learned loads of things I want to take back to my hospital, things I want to try. I'm definitely going to start teaching the ODPs again, but there's been so many brilliant things. And as I said, between Rupa and Gerry, you just feel inspired to do quality improvement, no matter which hospital you work in. And so we've now sort of reached the end of our very exciting day, which we hope you've enjoyed as much as we have. And I really do feel that we've all learned absolutely loads.
So in addition to our speakers, we'd like to say thank you to all those behind the scenes, including our tech team here today, who have made this day possible. We'd also like to thank Anesthesia Learning in the Northeast for facilitating and hosting this event. I now have the pleasure in announcing the winners in the abstract section based on the scores that you have been submitting throughout the afternoon. So in runners-up, we have Rory Andelic with his Flying the Nest presentation. Fellow runner-up is Amy Fox in in-situ simulation for building confidence of managing airway and other anesthetic emergencies for the wider team. And the winner is Matt Bickerton with the cannula decompression of the pneumoperitonium. So please remember the talks have been recorded so you can watch back at your leisure.
I'd just like to say congratulations again to everyone who's received prizes. We did only award prizes to trainees. Finally, on behalf of the organisers, thank you to all of us who've joined us online today and for staying on until the end. It's been an absolute pleasure to host a national online meeting here in the North East in a lovely venue. And after the meeting today, you should receive an email with a link to provide feedback for the event. The meeting is still in the early stage of development, and your feedback is invaluable in helping us to plan for future meetings and to ensure that this event continues to be valuable and an educational meeting for everyone who has an enthusiasm for quality improvement, education and anaesthetics. You'll receive your certificate of attendance via email, and we hope you all have a lovely weekend. Thank you very much for joining us. Goodbye.
Goodbye.